Good morning, everyone, and welcome to the ABTA Newly Diagnosed Empowering Your Journey Patient and Family Meeting. My name is Emily Lippert, Program Manager here at the American Brain Tumor Association. We are delighted you have joined us online today. The ABTA's patient and family meetings are free events typically held across the U.S. where brain tumor patients and loved ones can hear from experts about updates in brain tumor research, treatment, and care. This year, we chose to host our meetings virtually to protect the health of our community during the COVID-19 pandemic. Although we are saddened we cannot connect and network in person, we hope our virtual program will be an enriching experience. Since we are unable to meet in person, we thought a good way to connect would be to participate in some polling throughout the meeting. When a poll is launched, a box will pop up prompting you to respond to the question. Your answer will be anonymous and only collective results will be shown. Let's test out a poll right now. What region of the US are you tuning in from? Ooh, it's a tight race. Give it a few more minutes. Still going up. Looks like the Midwest and the Southeast are fighting for the top representatives. All right, I'm going to end the polling now. All right, we have most representation from the Southeast, with the Midwest coming up in second, and then the Northeast and West. Well, welcome everyone. We really love that each of you are joining us from all over the US. All right, our second poll is, please rate your understanding of brain tumors. We want to gauge where everyone's understanding of brain tumors are at the beginning of the program, and then we're going to evaluate everyone's understanding after the program. All right, still going. Great, thank you so much. So it looks like everyone has a general understanding of brain tumors. There's a few that have little or very little, and some with great, but we really hope after today's programming that these numbers will be higher, that you will increase your understanding of brain tumors. Thank you so much for interacting with us. I would like to thank ABTA's Program Planning Chair, Dr. Erin Dunbar, for her support in the development and execution of this meeting. Dr. Dunbar is the Director of Neuro-Oncology of Piedmont Brain Tumor Center in Atlanta, Georgia, and has been a longtime friend and partner of the ABTA. Dr. Dunbar serves on our Clinical Advisory Council and has chaired several patient and family meetings and our annual national conference. The ABTA is grateful for our partnership with Dr. Dunbar, who carefully crafted this program based on survey feedback from previous meeting attendees. The purpose of this meeting is to empower and equip newly diagnosed patients and caregivers with information and resources to make decisions throughout the treatment and care. And with that said, please welcome our chair, Dr. Erin Dunbar, to say a few words.
Hi, everyone. I want to warmly welcome you to this event. Although we wish we could be giving each other maskless smiles and warm hugs and handshakes, we're meeting in this virtual forum to connect and together empower each other at this very special time in our lives, the beginning of a brain tumor journey. We hope you enjoy this, and we hope you enjoy the recording that will be here for you always. Thank you.
Thank you so much, Dr. Dunbar. I would like to thank all of our speakers for taking the time out to share their insight and expertise with us today as well. Additionally, thank you to ABTA's presenting sponsor, Novocure, our gold sponsor, SDP Oncology, our silver sponsor, Karyopharm Therapeutics, and funders Genentech and Integra Foundation for their support of this virtual event. Without the time and effort from each of these individuals and organizations and support from volunteers and staff, we would not be able to bring you this quality educational programming that has brought together the brain tumor community. All right, are we ready to begin? Our first session of today's meeting is all about the American Brain Tumor Association, who we are and how to get involved. The ABTA continues to be a proud advocate, and we are steadfast in our mission to be a strong ally and resource for the brain tumor community. This presentation will discuss the many ways that we are here to serve you and how you can get involved. Please help me welcome ABTA's President and CEO, Ralph DeVito.
Thank you, Emily, and thank you, Ambreen. Appreciate all the hard work that you all put in to make this event happen. Thanks to everyone for joining us this morning. A special thanks to Dr. Aaron Dunbar. Aaron is a friend and longtime partner and collaborator and a leader in the brain tumor community. So thank you so much, Aaron. And I want to add my thanks to the folks that have sponsored today's virtual, very important meeting, especially our friends at Novocure. Today, I'm going to present to you an opportunity to learn a little bit about the American Brain Tumor Association, what we're doing today, but let me assure you, we're excited about the future. We're excited about growing our impact, continuing to be even better collaborators and leaders in the brain tumor community, because there's so much more work to be done. Okay, so looking back to where things were in the early 70s, we just didn't have the capacity, the resources to support those going through this very serious challenge of a brain tumor diagnosis, including, though we had neurosurgeons, we did not have neuro-oncology as a specialty. We did not have the collection of brain tumor data and analysis and availability to the public and to clinicians, and we were very pleased to have played a part in the creation of the Central Brain Tumor Registry of the US, which today is a premier place and source of that very vital information. So there's so much that we have advanced, and the ABTA has played a role. Next. Our mission, we are leading as we are trying to create a better understanding and better treatment for those who are diagnosed with a brain tumor. But our goal is to improve, to extend, and ultimately save the lives of everyone who are diagnosed with a brain tumor. Next. How do we do it? Well, as you can see on the screen, it's multifaceted. We serve patients both directly and by referrals. We have wonderful collaborative relationships. We have public education and awareness, like the event we're having today. And I'll share some examples of how we are funding breakthrough brain tumor research. Next. Next. So here's our mission. Let's start with our legacy. Our legacy is investigator-initiated, peer-reviewed brain tumor research. And we are nearing $33 million of investing in brain tumor research. We are proud of the many hundreds of research projects, both at individual institutions, multi-institutions, but primarily in the US, though we have funded a number of global important brain tumor projects. And we have researchers all over, and there's not a time or a session that I have at a brain tumor center where many of the folks that are now leading that brain tumor research have not referred back to an ABTA funded research. In fact, just yesterday, Dr. Mitch Berger was talking, we had a session with ABTA board members, of which Mitch is a new board member, and he was sharing about how vital it was to receive an ABTA research grant early in his career and the difference that it made. Next. One of our gems is that we bring together the researchers we have funded, and we call it the AARN, the ABTA Alumni Research Network. And 2.5 days, up until 2019, it was in person in Chicago. Last year and this year, it's completely virtual. We had about 60 people attend our 2020 virtual AARN 2.5-day session. We're excited about this year's session. You can see on the screen, the last time we met was in 2019 in Chicago, and here are many of those that joined us for 2.5 days. They meet, they learn, they collaborate. We have seen research requests surface just spontaneously from the conversations that many of the folks that you see on the screen had with one another and come together to go forward. Next. In addition to that wonderful group of researchers we have funded directly, we also pool our money with 5 other brain tumor organizations that we call the Brain Tumor Funders Collaborative. And we're able to do things collectively, larger awards than we could do individually. And our last award was about a $3 million pool of money to fund researchers studying immunotherapy and primary brain tumors. So we're looking forward to this 3-year body of work, and we meet on an annual basis to in-depth understand the status of that project, the low-grade glioma registry, and many other research initiatives that we are involved in. Next. So next. We are very proud of our second big body of work, and that is serving the patient and the family. And I'll share with you a little bit about how we do it. As Emily said, I hope you have paper and pen handy. Please write down this, abta.org, abta.org. That is our website that many hundreds of thousands of people take advantage of the ever improving, ever updated content on our website. So you see here on the screen, some of the highlights, all tumor types for all ages, no matter where you are in your journey as newly diagnosed, recurrent side effect issues, we're here. And I'll share with you a few other ways that we serve people, but this is one source of information for everyone, anywhere, anytime. Next. We're proud of our printed brochures. The Brain Tumor Primer is our most widely known, but we have individual tumor type brochures. We have a brand new metastatic brain tumor brochure that we're very proud of. So please, these are available free of charge for patients. We have just a cost that we charge to institutions if they need a bulk supply of them. But please contact us if you need any of these brochures. Next. As I mentioned, in addition to the website, in addition to sending you printed information, we have staff available Monday through Friday, 8:30 to 5 p.m., who will listen, who will share information, who will help you think through the kinds of questions you might want to ask of your physician for an upcoming visit. Or just sit there and listen and talk to you. I'm very proud of the work that we do by phone. We also have this service available by email. And of course, if you need to call during the weekend, we'll get back to you as quickly as possible. That's our ABTA care line. And the phone number is on the screen that you can write down. Just go back, just write down that phone number, 800-886-2282. Next. In addition to talking to someone or emailing with someone in an individual and personal conversation, we have a growing presence online, and you can join the connections anonymously. It is a way to enter into conversations about your tumor, a friend's tumor, a family member's tumor. You see on the screen 28,000. I learned yesterday, I believe Embreen updated that to over 30,000 members of our connections. And again, to learn more, you could call us, you can email us, or certainly go online. Next. Our webinars, we are proud of those. We have them about once a month. We are highlighting the one that we had last year on late treatment effects and survivorship. Dr. Patrick Nguyen, a renowned leader in the brain tumor community. These are amazing, talented experts who give of their time and their knowledge to you to make it available live. But like this, we are recording it, and we have an ABTA YouTube channel. So go to our abta.org and you will find previous webinars, you'll find previous patient meetings that we were able to record. Not all of our patient meetings have been recorded, but we are doing that for this one and going forward. Next. This is one of our patient and family meetings, and this year we're going to have 3. This is our first, again, led by Dr. Aaron Dunbar in partnership with Aaron and Breen and Nicole. Dr. Nicole Wilmarth heads up the mission work of the ABTA. She's a staff leader and a great overall leader in the brain tumor community. But you see these events, this year they're all virtual, and we normally work in partnership with institutions to hold these, but we have this one, we have one coming up on metastatic brain tumors, then a final one on survivorship. Again, go to abta.org. Next. We have our premier event. It is the single most important event that the American Brain Tumor Association puts on every year. Last year we had around 1,300 people register. It was our first ever virtual national conference. Last year, this year, again, because of the pandemic, as Emily indicated, we've got to be sensitive to our community. And so our 2021 national conference will be virtual. You see there September 10 and 11. And we're excited about it. We are planning for 2022 to be hybrid. We'll have it in person, but we'll also have it live streamed free of charge for you. And again, it was recorded last year. It'll be recorded again this year if you cannot make it, or if you miss part of the 2-day series of incredible content. Next. One of the things that we offer that not everyone takes advantage of, we've had, I think, around 800 total matches since we launched this. This is an opportunity for those of you that have been diagnosed, that have been through your treatment, that are now healthy, you want to give back. So you serve, we'll train you. You serve as a mentor to others who are going through the same kind of journey you've been through. So you see on the left, bottom left, the mentors we have available. And the bottom right, that number is now around 800 that we have matched. So again, call us, email us, go to abta.org. If you either want to be a mentor, we'll train you. If you want to be served and connected to those that have been through a similar brain tumor journey that you may be about to start. And the same is true for caregivers and family members. We can match you with another caregiver. Next. Some of you say, I've been through this. I am now feeling healthy enough. I want to get involved. How can I help those? How can I raise money? How can I serve patients? Let's just spend a couple of minutes. And again, call us and we'll give you far more information. But next. We have ways to raise money. The only way that the ABTA can offer free patient services, can fund breakthrough brain tumor research is if we raise money. And here are some of the ways that we do it. We used to have signature walks and runs called BT 5Ks. We had a wonderful pivot in March of last year caused by the pandemic to completely virtual. And though we had them, it just devastated our revenue streams. I'm proud of the staff. I'm proud of the volunteers that did continue with events that could take place. And this year, towards the end of the year, we might have a couple of in-person fundraisers, but next year we are anticipating being fully back, having in-person events, our signature events, volunteers who want to have their own fundraiser, either events at home, events in the neighborhood, reach out to us. We will coach you. We will give you resources that you then go out and create your own event, your own way, in your own community. They're called Fundraise Your Way events, and they really help us very efficiently and effectively raise money for our mission. Next. One of the things that Alicia Campbell does is she's our National Volunteer Coordinator, and her job on a regular basis is to connect with those that have an interest in giving back. And so today at 4:30, if you're not totally worn out from a full day of great content, take a break, join us at 4:30 for a half-hour virtual volunteer social hour, or on the paper and pen that you have in front of you, contact Alicia Campbell at our phone number that we just gave you, and she will connect you. She will help you understand in detail what can you do as a volunteer with the ABTA. And at 4:30, you're going to hear from 2 ABTA volunteers who have just done that, have just given back in so many ways. Next. You know, we do a lot of things in a lot of ways for a lot of people. Our Mind Matters e-news is free of charge, and it's the best way for you in a holistic, comprehensive fashion, get a good sense of what's happening with the American Brain Tumor Association and the larger brain tumor community. It was normally an every other month publication. It's now quarterly. We're going to see how that goes this year. We want to hear back from you. Is a quarterly newsletter sufficient? You want us to try and go back to an every other month publication? So I'm sure you're asking, how do I get access to this? You'll see on the screen, abta.org. You'll sign up, you'll get the publication, and you'll be able to stay in touch with everything happening, not just with the American Brain Tumor Association, but the larger brain tumor community. Everything from the month of May, where we have a fabulous array of opportunities around brain tumor awareness. In July, we have GBM Awareness Day, so we'll be able to give you an overview of what is happening. And let me also make in conclusion, a pitch. In addition to you helping us raise money, in addition to you helping us by becoming a mentor, helping others going through a brain tumor experience, we also have an ongoing need of volunteers with a particular skill set. Maybe you're a photographer and you are willing to go to an ABTA event and take photos and provide those to us. That would be very valuable to us as we communicate the message widely. So there are a lot of volunteer opportunities. You will learn about those on Mind Matters. Of course, though, you can contact Alicia Campbell at the ABTA. She's a full-time staff person and can connect you to the wide array of opportunities that you can give to us. We're trying to do a better job being on social media. You see at the bottom of the screen, if you've not yet done so, join us on Twitter, follow us on Twitter, join us on Facebook, LinkedIn. I have a Twitter. Please feel free to follow me or Nicole or any of our staff. It is a way for us to get the message out pretty rapidly on trending issues, and as we learn things, we can share them pretty quickly. Again, one final slide here. Let me say thank you for joining us today. As you go through your journey, or your family member or your friend, we are here to help every step of the way. So thank you.
Thank you so much, Ralph, for sharing with us about the mission of the American Brain Tumor Association. As Ralph mentioned, we would love to get connected with you. Please reach out to us through our website, www.abta.org, or call our care line. We'd be happy to assist you in any way that we can. Our next session is titled, Beginning Your Brain Tumor Journey, How to Prepare for Your Medical Team. We understand that your first few appointments with your healthcare team can be incredibly overwhelming. In this session, you will get a behind-the-scenes look at how the medical system works and understand how decisions pertaining to treatment are made. Welcome back our chair, Dr. Dunbar, who will introduce our first speaker.
Hi, everyone. I want to welcome you back and tell you that we were really privileged to have a collection of speakers today that represent the continuum of patients and families at this time, and also represent the topics that are truly important. Each speaker chosen, including Dr. Agi, represent the premier providers advancing the field in science, education, and are also wonderful humans. So I'm very privileged to introduce Dr. Agi. He is a professor, scientist, and trialist representing the Northwest in San Francisco. He is an expert in the surgical management of brain and skull-based tumors, is a trialist, professor, and educator. Let's all warmly welcome Dr. Agi, and please begin.
Well, thank you. It's a pleasure to be here this morning. My name is Manish Agi. I'm a professor of neurological surgery. I'm a surgeon scientist, so I divide my time evenly between the surgical care of brain tumor patients and basic science research into advanced therapies for brain tumors that we hope to bring to clinical trials. I'm also really honored to have been a past ABTA grant fundee for my research and a member of the AARN. So I'm going to start. Well, I'm going to talk to you about beginning your brain tumor journey and how to prepare for your medical team. So I have no pertinent disclosures to share with you, but what I'd like to really do today is walk you through the first appointment when you have a brain tumor and you first see a specialist. So the question is, how does it all start? So 2/3 of brain tumor diagnoses occur when brain-related symptoms such as headaches or memory loss are disclosed to a primary medical doctor, primary care doctor, and that person astutely decides to get a brain MRI. And this is where we enter sort of a challenging part of this process, which is that the brain for medical providers and the nature of how we train is probably the one part of the body where things have become so specialized that they don't necessarily, the primary doctors will not necessarily know how to counsel a patient once a finding arises on a brain MRI. And it's a little bit different in that way than sort of a heart problem or a lung problem. And so as a result, typically that imaging finding, that positive report on an MRI will lead to a patient being notified by the doctor's office of the findings as they are relayed on the report, which is often not in the most layperson-friendly language. So it'll be described as a mass with a certain size, but the report won't necessarily disclose what the mass is or what it means to the patient. And so that finding will trigger a referral to a neurosurgeon because there is a recognition that that's the starting point because a procedure is generally needed to obtain tissue. And so when we encounter a patient, we typically, my office will receive a phone call from either the patient directly or the doctor's office. And the urgency often lies not just in the fact that it's the brain and there's a tumor there, but the anxiety that the patient undoubtedly is dealing with due to the what they've been told and the lack of detail and the need for further insights. And so with that in mind, we try to schedule these appointments very quickly, particularly in the current climate of telehealth and Zoom. If I get a new referral with any sort of tumor, I will not just look within the confines of my sort of clinic day, but any day of the week, as 7 days a week, schedule a Zoom with a patient. And I think that reassurance and providing in a timely manner is very important. And so what are the questions that, and I say that the neurosurgeon should discuss at the first visit, because I think some of this isn't just my style, but I do think it's important that these things get touched on no matter who you're talking to. And if they're not, they're good questions to ask or information to relay. And so we start with the patient's symptoms. How long have they been going on? Which is very important for the doctor because it gives you a sense of what is the nature of this process? How rapidly has it been affecting the patient? Sometimes you have a tumor that looks like it's been there for many years, but the symptoms have only been going on for days. And that's not uncommon. It's sort of felt to represent that a chronic and slow process. Something about it just tips over the edge in the days leading up to the appointment. How the symptoms are affecting their work. This is a very important thing these days. We all want to be able to do our jobs. And when something happens to us that prevents us from doing our jobs, that's very devastating. And so we try to drill down on that and what you do for work, because my ability to get you back to work as your surgeon will vary depending on whether you're a teacher or a construction worker in terms of the mental and or physical demands of your job. How the symptoms are affecting your activities of daily living. Do you live alone and have trouble doing your laundry and cleaning up? Or do you have some support, but you're now unable to do sort of your part of the household day-to-day maintenance? And a lot of times these answers come not just from the patient, but their family. And so appointments are often with patients and their families together, and the perspective that the patient and the family give can vary, particularly if the tumor is affecting the patient's memory or verbal communication skills. And then once we get this background in mind and get a sense of what's going on, we go to the MRI, and this is probably, in my opinion, one of the most important aspects of the first visit. The patient has often not seen the MRI. They may be anxious about seeing the MRI. And I do think it's important to try to break through that anxiety, because I think even the most simplistic, even a person with the most simplistic understanding, in my opinion, there's a benefit to understanding what your MRI looks like. And this is where I call this sort of radiology 101, where I take anyone with the most basic understanding and try to walk them through their own MRI. And I do this in a way that I really make sure they understand what I'm showing them. And so I look at their MRI in different, what we call planes. There's this sort of flat axial plane, there's the side sagittal plane, and there's the face-on coronal plane. And I try to use terminology that they hopefully understand. And I orient the MRI. I use an arrow to show, and particularly on Zoom these days, it's a little bit easier in some ways. I show them what the front and the back is, what the left and the right is, because it's often flipped around on an MRI. And the other thing I do is I start on a MRI picture of their brain that is unaffected, because I want them to see what so-called normal looks like and orient themselves before we get to sort of the alarming part, the part that might concern them, which is the tumor. And I explain how contrast in the MRI works, because a lot of times, patients are wondering, why did they have to start an IV and give me that stuff? And contrast is a very important part of why we look at an MRI, and I show them all that. And then ultimately I get to where the tumor is, and I show them what parts of the brain the tumor is in, what the functions of those parts of the brain are in, and then we tie that back to their symptoms, correlate the MRI with their symptoms. And this gets at the part of, there may be some of your symptoms that are somehow not related. We all have sort of a mix of day-to-day symptoms that may be neurologic in nature, but only some of them may actually trace back to the MRI finding. And then what are the anatomic functions of the normal brain that are being disrupted by the tumor to cause the symptoms? Some of their symptoms may be due from the edema or the swelling around the tumor, and some of them may actually be from the damage that the tumor has caused to the normal brain. And sometimes if their doctor has started them on dexamethasone or steroids, they may report some improvement in symptoms that could have been due to tumor-related edema, which is very helpful to tease out, because as a surgeon, I can sort of be, as your surgeon, the substitute for that steroid by improving your tumor-related edema. But if there are parts of the brain that have experienced any damage or destruction from the tumor, it may be harder to improve those symptoms with surgery, although surgery could certainly prevent those symptoms from getting worse, which could be just as important. So then we get to sort of, what is this tumor? What type of tumor could it be? And I think it's very important to obviously focus in on what we really think it is, but underscore the importance of getting tissue, that no oncologist like Dr. Dunbar is going to treat them necessarily unless we can make a good effort to get the tissue that'll help guide the treatment decision-making. And then I explain to them what the diagnosis means, what it involves. And, this often leads to a lot of questions, such as, What's my prognosis? And for that, we may touch on it a little bit, but we underscore that until you have a final pathologic diagnosis, it's a bit premature to be talking like that. And so I try to keep the focus on sort of the nuts and bolts of what it could be without getting too caught up in what that means for them. And then a very common and sort of a question that really tugs at my heartstrings is, what caused this? Or the even more difficult, what did I do to cause this? And I really think it's important to emphasize that we don't know what causes brain tumors, but for the most part, there's no sort of personal risk factors or genetic risk factors for the average new patient that comes to clinic, that it really is just random chance, a mutation that maybe arose in the cells of the body as we get older. And that this area of uncertainty is why we do research. And sometimes that question comes up, if not at the first appointment, at later appointments as well. And so then we get to what are the next steps. And as your surgeon, I'll walk you through the aspect of, can we safely get tissue? Every so often there's a tumor where even getting a little bit of tissue poses a lot of risk. And we have to have a conversation in which we bring in oncologists or radiation oncologists and ask, could this be safely treated without getting tissue? But for many tumors these days, we can get tissue. And then we say, can we get it through a biopsy, or would it be better to attempt to remove the tumor? And thankfully, a large majority of tumors, we are able to attempt some sort of removal. It's really only a small portion that end up getting a biopsy, but we review the data on whether a biopsy versus a resection, what its impact would have on your outcomes, and what the better course of action is, how much of your tumor we need to be able to take out in order to really help you. And then we review the detailed expectations with surgery. Probably the first question that comes up is, how long would I need to be in the hospital? And we walk you through sort of average so-called length of stay, and when you can expect to go home, whether you might need to go to rehab. What are some of the risks of surgery, and when can you see them occur? When would you, if you had a neurologic side effect from surgery, what would it be like, and when can you expect it to get better? If you had neurologic impacts from surgery or even before surgery, and you might need rehabilitation for a week or two after surgery, we walk you through that and whether that can be done closer to home. We talk about what recovery will be like. What would your needs be at home if you live alone, or if you have stairs, what some of the challenges might be. And what sort of caregiver needs do you have? Will your family need to take time off from work, and who would be best equipped to work with you, and what they can expect to have at home? Many programs such as ours have a caregiver program, and so we're able to give you binders with information for the family in terms of what to look for at home. What does a seizure look like? What does difficulty swallowing look like? So those are some of the things we will walk you through. Some additional topics that come up, general anesthesia. Patients may say, I've had some bad experience with anesthesia. I may touch on that, but I also ensure them that they will get a consult with their anesthesiologist. We may talk about postoperative steroids, seizure medications, and antibiotics in terms of the role for those things. We may talk about banking your tumor, which is a part of something that many centers do, and it's a separate consent from the consent for surgery, but it's a way that patients can provide a service to others with similar tumor diagnoses, because it allows researchers to someday look at their tumor and analyze it and understand it better. We may talk about clinical trials, because some of them do require enrolling ahead of initial surgery. And I should mention that clinical trials and your ability as a patient to help is not just limited to your ability to help yourself by participating in a clinical trial. It's really about helping all patients understand whether a treatment works. And these days, it's not just about enrolling in therapeutic clinical trials, but there's a lot of registry trials. It was mentioned previously, a low-grade glioma registry. There's a lot of registries you can enroll in ahead of time. There's neurocognitive studies where you can enroll ahead of surgery to understand the impact that the tumor is having on your cognition and whether the treatments will help with that. And so there's a lot of opportunities to participate in some really exciting studies these days. I'll walk you through the hospital routine, because it won't just be me that you will see, but I have residents who will round on you you every morning, and I'll give you information about how to get in touch with me if you have questions before surgery or while you're in the hospital, because obviously I'm not there through every day or through sort of 24/7, but I'm certainly reachable 24/7. And then we will touch on some longer term considerations such as driving, return to work, quality of life, although many of those things also will be part of the discussion, not just preoperatively, but postoperatively as well. We will talk a little bit about what you can expect once you go home or leave the hospital, because there is a point in time, and this gets at sort of the transition to my portion of this talk and Dr. Dunbar's portion of the talk, is this transition that occurs from the way I describe it is that the neurosurgeon sort of hands off the ball to the neuro-oncologist, who then becomes sort of the quarterback of the team. But after surgery, the transition will often occur at the weekly tumor board, which is a big part of your care at any of these centers, where your case will be presented at a tumor board that is attended by neurosurgeons, neuro-oncologists, radiation oncologists, and radiologists. Your imaging will be reviewed, your postoperative MRI will be reviewed, your pathology will be reviewed, and a member of the neuro-oncology team will then be reaching out to you to provide information on next steps, which basically means they will be setting up an appointment with you. But I will certainly give the patient a preview of the importance that surgery is really just part of their treatment, or maybe just part of their treatment, depending on the tumor type. And I will touch on whether they may be seeing a neuro-oncologist, this is all ahead of surgery, and what they might expect in terms of discussions around chemotherapy. And sometimes when it's clear that the tumor is going to need these things, I may describe them just so they're not caught off guard. Is the possibility that the chemotherapy might be oral or intravenous, and then radiation, like the duration of it and where they do it. These questions actually do come up because patients really like to sort of be planning ahead, as would any of us in that position. And then we touch on many patients come to UCSF, where I am, for surgery from really large distances, and obviously that's something they understandably choose to do for some level of expertise, and I'm really grateful for that. But 6 weeks of radiation may make it more challenging to do that. And thankfully, these days, there are radiation facilities that can provide very good radiation treatment, with our providers weighing in and making suggestions, but sometimes the patient doesn't necessarily need to make such a long trip to undergo daily radiation. So that's a question that comes up early in the discussion. But with that, I'd like to, and then the last bit that comes up is this business of the sort of post-operative role for the neurosurgeon. So we certainly want to be involved in your wound cares and your wound healing. That's the part of your body that really the surgeon has created, and I want to make sure that it meets with your satisfaction. So did we do a good job sparing your hair? Did we, and these are some of the things we check. We are very attentive to before surgery and even after surgery as you undergo treatment, and make sure that the treatments don't disrupt your healing. We check in on your postoperative neurologic recovery. Are your needs being met in terms of your motor recovery and your cognitive recovery? And then we just make sure that that handoff that we talk about from myself to the neuro-oncologist has actually occurred, and that you've got your appointments, and that you're comfortable with your neuro-oncologist and your treatment plan. And that basically sort of my final words typically are that I reassure them that I will remain a part of their journey, that their MRIs over time will always be brought to my attention, that they don't necessarily need to regularly see me, but they can certainly keep in touch, and I will be constantly aware of their scans and watching their journey with tremendous investment and excitement, but that the neuro-oncologist will then be sort of heading up things. And that's where I will now transition to Dr. Dunbar.
Thank you very much. That was fantastic. I agree, there is a passing, and it is such a privilege to always have the neurosurgeon as part of the team. I always like to say on retainer in your back pocket, and that's a fantastic place of reassurance for us as neuro-oncologists to have our neurosurgeon stay with us across the journey of a patient. I'm going to move on to part 2. disclosures. So as I pick up the baton, I would like to talk about preparing after surgery. I think of it as the who, what, why, when, where, and how of moving on your journey. And those include creating a medical team, creating a home team, understanding your tumor, understanding your goals of care, preparing for the first few visits, creating a care plan, communicating with your team, and preparing for the unknown but possible. So here we go. Creating your medical team, truly to help you live your best, longest life. Creating a multidisciplinary team that communicates with each other and communicates with you is essential. This is a list that is actually not even exhaustive. People across their journey need all different types of folks helping them, but not necessarily all at the same time. So Dr. Agi mentioned tumor boards, and that is absolutely essential with periodic parts of your journey. You're going to have specialists, therapists, and advocates come and go on your journey. Your family, friends, and caregivers will always be a part of that medical team. So creating that medical team, let's talk about that a little bit more. As soon as we Google brain tumors or brain tumor care, there's a tremendous amount of things that are identified as important. There are certain criteria that correlate with high quality brain tumor care, but not all for everyone, not all at the same time, and not always in the same way. Some of them include a dedicated program that specializes in brain tumor care, that has specialists and brain tumor staff, centers that have high volumes of patients and specialty services, multidisciplinary care, multidisciplinary tumor conferences, clinical trials, molecular genetic testing, and robust services for patients and their caregivers. So we encourage you to ask your physicians, which ones are the most important to me now, or which ones might be important to me later? Which ones need to be physical, like a person touching or examining you, or which ones could be done by telehealth, like Dr. Agi was saying, a Zoom call with someone close by or far away? Which ones do you need to do as the patient, such as physically go and get your tissue tested or get a special exam or MRI? Or which ones can your providers do, such as engaging in peer-to-peer electronic consultation or tumor boards across the country or across the world? So we encourage you to stay informed about the value of each of these criteria and work closely with your physician and advocates and organizations like the ABTA to always make sure you have the right people on your medical team. We also want you to create a home team, and that includes family, friends, social work support, folks you know within your work, folks that may be part of your hobbies, and different organizations such as the ABTA, government organizations, charity organizations, or even folks that hire or volunteer to help you. One of the most provocative aspects of creating your home team really correlates with the ring theory, which I learned about many years ago and always rings true. Anytime one of us is affected by a crisis or a challenge in any way, we naturally create support structures that are analogous to rings. And the concept here is that the person in the middle of the crisis, at the center of the crisis, can always feel vulnerable and be able to be honest and even what we would consider complain about what's going on. But those that are in the outer circles should always be leaning in with comfort. So a good example is I ran into a patient right before our national race in Atlanta, and that person was a veteran runner and volunteer. And that person felt very bad when they were affected by a tumor, that they were not going to be able to complete the race themselves or continue on with their volunteering. Someone that came to visit with them in the hospital turned to that person's spouse and said, "Oh man, I'm going to really be challenged that I'm not going to have your loved one be able to pull their weight with volunteering at the race this year." And I thought, oh my goodness, that was not something supportive to say to that person at the center of the ring who was really battling a challenge that was unplanned at that time. Instead, that person on the outer part of the ring should have said, "Hey, listen, you'll be able to volunteer in a different way next year, but what can I do to help you?" So that's an example. Please look up that site. It's really helpful. So understanding your tumor is also very important. Dr. Aggie started us off very well. There's all different pathology lingo, primary versus secondary, which is also metastatic. We're going to talk about that in a minute. This continuum of benign to malignant. A benign tumor in its essence is something that you treat once, it's cured. However, the overwhelming majority of tumors are actually somewhere along the continuation of malignant, which means at some degree, at some time, it has the opportunity to grow or spread or impact someone's quality of life or length of life. There's all different types of testing and all different types of diagnoses. For instance, classical diagnoses, which might be cytopathology or histopathology, is really looking at what is the outside of the cell and can we identify it. However, what we really want to know in pathology diagnosis is what's that predicted behavior of the cell. And that's really where we get into molecular and genetic characterization. And there's a variety of methods and a variety of different ways in which it's reported. So for your reference, I will direct you to certain common testing facilities like Caris or Foundation One that are able to really do that precision medicine for each patient. So further about understanding your tumor. Classically, tumors either start in the brain or spine or spread to the brain or spine or sometimes the nervous tissue lining. So the picture to the left, I'm describing that there is a central healthy cell, but it can go into abnormal patterns, which becomes various types of abnormal tissue we call tumors of cells that start in the brain. Or the picture to the right is there to represent, you can have a cell in the body and it goes through missteps and become a tumor cell, and then it can spread to the brain or spine or tissue lining. Understanding your goals of care is also very important. This slide represents that for us to help a patient and their family across their continuum of life, we really want to zone in on what are someone's goals of care so that we can optimize their plan of care. We think of people in two equal ways. Number one, what can we do to slow down their tumor? And we think of that as tumor-directed care. The other equal important way we care for someone is symptom-directed. How can we shepherd your safety, quality of life, and minimize someone's symptoms? And that requires a balance for somebody to live their best, longest life. So if we think about the tumor-directed care, how can we slow someone's tumor growth rate or lower their tumor volume through different treatments? And then we think about how can we help somebody's symptoms, whether it be increase their safety, such as risk of fall, or their quality of life, such as their ability to enjoy their loved ones or go back to work or meaningful hobby? Or how can we minimize or prevent the symptoms of a tumor, such as fatigue or low blood counts? And it's always a balance between the risks and symptoms of the tumor and the risks and symptoms of the treatment. So there's a lot of analogies that describe this journey. I like the analogy, the fact that every individual is living their own life, very analogous to their own life story or their own life novel. And we become components of your life story. What an honor. So as we start in your chapter of life that becomes included in it the plot of having a tumor or the plot of your loved one's life having a tumor. We think of this as being chapters of care, that in one chapter of someone's life novel, there becomes a tumor as part of that, and we become part of that chapter. So if I lined up 3 or 4 people who had a similar tumor, had a similar health, and were starting a chapter of their life story that had a brain tumor in it, each person would have a different number of pages to their first life chapter, which is a new brain tumor diagnosis. So our job as providers of your care is to help you add as many pages to this chapter of a new diagnosis, as well as many pages to future chapters. Another job is for us to be very smart and efficient about helping you change through the different chapters and always be having a lot of options for you to get your treatment directed at the tumor and directed at your symptoms. But the binder of this individual life novel is your quality of life and your goals. When we think about helping you prepare for the first few visits, we think of how can we help you prepare before the visit, at the visit, and after the visit. So before the visit, I draw your attention to the fact of how am I going to get there safely? What am I going to bring? So things that you want to bring are caregivers, whether they're on FaceTime or Zoom or Skype. We want you to think about what caregivers or advocates do you want to bring to the meeting. Bring plenty of medicines. You could be at the care facility for several hours, or even if you're doing the Zoom calls, you may need to redose your medication. We want to make sure you have plenty of food and drink. We want to make sure if you're traveling that you bring plenty of money. There might be parking garages, vending machines, or cafeterias you need to eat at. We want to make sure you have cell phone or computer or laptop chargers. And we want to make sure that you bring tape recorders or have devices that you can tape the exchange. Always make sure you let us know you're recording you, because we might position our bodies different or pay extra special attention to make sure that you can hear us clearly. We want to make sure that as you're talking to your healthcare providers, you're making sure you have an accurate list of your medications, doses, and frequencies. You let us know about your allergies. We want to know your provider's names and contact information. And we want to make sure that you have allowed our facility to see the images that you want us to be commenting on. That is a very special area where you need to help us prepare, because another provider might have said, oh, I'll make sure Dr. Dunbar or Dr. Aggie can see your images. But you really want to spend extra attention to make sure that we have all of the images you want us to comment on, and that we can see both the report and the images. They can be power shared, or CD-ROMs can be sent ahead, or you can bring CD-ROMs. We want to make sure you help us understand the goals of the visit and that we know your questions and needs. We also want to make sure that we are very, very attentive to you at the visit to address those things that I just mentioned above. That visit is a sacred exchange, and we are so privileged to do that with you. We also want to make sure that you are very helpful to us as to know how can we serve you after the visit, and how can you be focusing on continuing to squeeze out the most of that visit. And that includes really taking advantage of what we've offered. Have you signed up for our electronic portal through the electric medical record? Are you using our social worker, our support groups, etc.? We ask you to really be honest and patient and proactive. We want to definitely make sure that we get it. The healthcare system is crazy, and there's a lot of things outside of your control and outside of our control. So really be proactive and have patience. Forms, insurance, pharmacies, vendors, other services can be confusing and frustrating for us as well. So let's team up and we can do the greatest good together. One particular area of advocacy is you really need to learn how communication is different in your different phases of care. For instance, we have an electronic portal called MyChart, and you can sort of email your providers. But that's not checked in the hospital, and it's not checked when you're in rehab, and it's not checked on nights and weekends. So when you're in different phases of care, make sure you're checking with your care providers. How are they communicating with each other? And what's the best etiquette or flow for you to communicate with the people that you want to be communicating with? Create a care plan. Across your care continuum, there's different phases of care. And there's also different modalities of care. So this conference is about selecting your initial treatment at the initial brain tumor diagnosis. And at that time, it might be a combination of surgery, radiation, medicines, or devices. And you want to work with everyone on your care team to really help you get started at this new diagnosis with the right modalities of care. And it'll change across the continuum. Some of the questions we get asked the most are about concepts of prognosis and prediction. So I wanted to also describe that for a minute or two, because that's important to creating your care plan. Prognosis and prediction factors can be used to help you select treatment now or later, as well as things like balancing the arms of a clinical trial. So there are things that are within your control as a person or a caregiver. Your age, health, and that alludes to something called performance status, which we're going to talk about in the next few slides. But also your access to care, your access to centers or your local providers, access to clinical trials, tumor boards. Also, you defining your goals of care and accessing support of those around you and your community. But there's also factors that are related to your tumor. And there is nothing you can do to control the factors in your tumor. You can control the things above, but not your tumor. So these pictures on the screen, the top red balls to the left and the right are to represent a tumor cell or a tumor. And on the left, I'm describing that there are certain factors within your tumor, a marker, an aberration, that you can't control that do portend a certain behavior or tendency to outcome, and those are called prognostic factors. Future speakers are going to talk about those in greater detail. And then other factors are predictive factors, and those are ones where we have external influences can influence a tumor cell's behavior and cause them to act one way or the other. And that could be a certain type of treatment, medicine, radiation, surgery, and those are predictive factors. So ask your providers about what factors are in your control and what ones are part of the tumor, and how can they stack the odds in your favor that we're using those factors to help you have the best possible tumor-directed therapy and symptom-directed therapy. Some examples of performance statuses you'll hear are one called ECOG performance status. And those tend to be things like how physically active are you, how much are you out of a chair and up and around, and how much can you do for yourself. Another factor that's common is called Karnofsky performance status, or KPS. And that's a different scale, typically about how close are you to normal activity, normal amounts of work, normal activities around your house. And there's another scale called neurologic functional status. And those are related to different amounts of neurologic symptoms, how active are you at home and work, and how much is your burden of neurologic symptoms. When we think about starting tumor-directed therapy, we think of what are the things we can start, and that includes what are the ways we can start your therapy? General science, general safety, what are your goals? And then there's things that we can help you with, like strategy, order of therapy. We can help you with logistics. Is something an oral therapy, an IV therapy? Do you have to get it in a clinic or a hospital? Can you do it at home? What are factors like cost or insurance? How often do you have to do it? Are you interested in a clinical trial? And what's the support required by others, such as driving or assistance putting on a device or taking medication? Is it located close to you or far away from you? When you're on your therapy, there's lots of ways we help you monitor it. Exams, health, blood work, other tests, always asking you about your goals and symptoms, always talking with you about your goals and wishes, and checking imaging. And then every treatment comes to a natural end. I always like to say there are stopping rules to everything we start. One would be, do you want to be on this treatment anymore? This is your life, your body. This is your individual life story. Do you want this in your life? You're the boss. We're your helpers. Also, is it safe and tolerable? You can feel fine on it, but it always raises your liver test. So maybe we want to change or stop. Or things seem to be safe in your blood work and your MRI, but you really feel bad and we can't make that symptom better. That's a legitimate reason to change your therapy or stop. And then, of course, is it getting the job done? And that has to do with the pre-selected goal we started that therapy for. And those are very important things you want to talk about with your healthcare provider. And then communicating with your team. I can't emphasize this enough, and this is going to be the backdrop of several future talks. The more you communicate with the members of your team and those on your home team, the better and longer life you will have. So that includes red flag symptoms that you can ask your provider about because they're so individual to each person and each person's tumor. Ask your providers, your advocates, and your helpers. Let's talk about my goals and wishes and talk about them often. And share your goals and wishes with people often. So the picture on the bottom right is a cartoon to say, think, tell people, think, tell people, think, tell people across your care journey, update people so they can help honor you and help you live your best life. So lastly, prepare for the unknown and possible. This picture to the right is an insurance document, but I really, a cartoon from an insurance document, but I think it really is true. Of course, our plan is always smooth driving, smooth plan ahead, but we all know life. Take the pandemic, for instance. Life is crazy and it's different and changing, and sometimes it's planned and sometimes it's unplanned. Numerous studies helping people with brain tumors tells us that the better we plan, the better and better longer our lives will be. So the next several talks are going to be about financial health, advanced directives, life logistics, creating a palliative care plan, focusing on symptoms, quality of life, and safety, and creating advanced care planning. So preparing for unknown and possible also includes an example of creating the highest continuum of inner peace. The picture at the bottom is how we all go through life. We start dependent, we transition to become independent, we think in our teenage years, and then of course the highest level of human evolving is becoming interdependent. And that is an example that we all need each other in our journey in life, and including across our brain tumor journey. So with that, I'll leave with references and say that these are references at the beginning of your brain tumor journey that I hope you look toward, and I hope you look toward always. So we'll take questions at the end. Thank you very much.
Thank you so much, both of you, for sharing your perspectives and insight. We will now take questions. As a reminder, if you have a question that you'd like to ask, please type and submit it using the Q&A box at the bottom of your screen, and we'll answer questions as time allows. So one of the first questions we have, Dr. Age, goes back to your talk. You talked a lot about questions that patients and families should keep in mind when they're going in for their appointments. And it can be a lot of information when you're going to these appointments and getting all that insight. Do you have any advice on how patients and families can stay organized, keep track of that information, remember what to ask, and just how to cope with all that overwhelming amount of information they can get?
That's a great question. So I think these days we have a lot of technology that allows you to organize information. I think patients are always asking me very kindly if they can record their encounter with me, and you know, they're very clear that that they have sort of a memory issue or a need to organize information, as would any of us. And so that's a facility. For the telehealth visits, you know, as the physician, I can record the encounter and provide them with the link to it. There's, you know, there a number of patients will pursue sort of organized online repositories where they can sort of store their information and go back to it later. So, and much of the information that Dr. Dunbar alluded to can just be, you know, stored on a folder on an iPad or and always be retrieved later.
Thank you so much for sharing that insight. Dr. Dunbar, did you want to share any insight on your end?
I agree very much. I do believe that getting organized is helpful, and there are a variety of electronic mediums. People's electronic medical records can now store a tremendous amount within the patient portal of their records, and then using electronic devices that also record questions amongst family members, memory tools of how to take medicine can be fantastic. So I direct you to ABTA Connections and some of the sites, including the New Diagnosis Primer book, for more tips and tricks.
Thank you so much. Dr. Dunbar, we have another question for you. You had talked about kind of building out your support network with family, friends, your healthcare providers, social workers. Can you share any advice for those patients that might not have a strong support network? They don't have family or friends that they can turn to, or an active caregiver that's supporting them. What are resources they can use, or how can they cope with this when they don't have that large support system?
That's an excellent question. I do believe that the ABTA serves the care home across someone's entire brain tumor journey. I also encourage you to work with your local brain tumor center or cancer center or hospital social work and ask them to assist you in identifying support groups that you can be virtual and anonymous online, or potentially go in person. A social worker can be a phenomenal help to help you identify community resources. You may be a retired firefighter or be able to join an AARP group or a young adult group. So it is a serendipitous time to meet future friends and future support by identifying that you need help at this incredibly tender time. Of course, always your physicians are your advocate, as well as the many people you hear today that represent their areas of specialty and advocacy: counselors, life coaches, social workers, therapists. Each of them are ready to help you create that virtual home team and medical team.
Thank you so much for that advice, Dr. Dunbar. Dr. Age, we have another question for you. So again, going back to that initial encounter with your physician and what to talk about, If a patient already had that initial meeting and they didn't think to ask those questions or have as thorough of a conversation with their provider, what can they do moving forward to ensure that they're getting the information that they need?
That's a great question. So a couple of things come to mind. I've certainly had patients who've I've had an initial encounter with, and they reach out and say, I have more questions. Can we, reconnect in a second encounter? And happy to do that. I would say that anyone you engage with and as your provider or surgeon should be willing to do that. I mean, it's, totally understandable if you didn't ask questions or if there were things I wanted to get to and maybe didn't in the course of an encounter. And so I think sometimes the simplest solution is to just reconnect or re-engage. But the second thing that I think is become increasingly feasible in with the advent of telehealth is sort of second opinions. I think it's important to understand that no provider will ever look at you negatively should you seek a second opinion, whether they be the first opinion or the second opinion. And I've been both first opinions for people who end up getting seconds, and I've been second or third opinions for people who've gotten first. And when I do a second opinion, I start out from scratch and I give my opinion, and then it's really only afterwards that I may get some insights into whether that opinion differs from the first. And so I try to be sort of an independent opinion. But I make sure I tell them if I know the first opinion and that I trust them and that they're reliable. But I also tell them that two colleagues who are, both bright and collegial and cordial may have truly different insights into a disease process. And that's why there's, no better consumer than an educated consumer who seeks out as much information as possible before making decisions.
Dr. Dunbar, did you want to add something? Dr. Dunbar, you're on mute.
I did. I wanted to absolutely corroborate what he said so beautifully and share that our goal is for you to live your best life with your own individual life story. And to do that, we encourage you to seek second opinions or potentially have a local and a faraway provider that coordinate your care. But to do that successfully, it's really helpful to us when you let us know you're doing that, first and foremost, so that we can help you squeeze out the most value of that other visit. If we do not know you're also seeing one of our colleagues, then we can't help you make the most out of that visit. I could know if you're going to see one of my partners across the country, I will help them zone in on the most high yield 2 or 3 questions they can comment on, instead of starting from scratch for the majority of the time and energy them and their team are going to spend with you. So keep us in the know and we'll help you, and we'll be happy and glad that you did that.
Thank you so much, both of you, for your advice and insight. We're getting a few questions about symptom management, and I just want to let our attendees know that we will have a session coming up later in the day specifically on symptom management. But as we're talking about beginning your brain tumor journey, is that something that you as physicians talk about early on with your patients? Do you talk about potential symptoms and side effects that they should look out for as they're making treatment decisions?
Dr. Aggie, would you like to start?
Sorry, could you repeat that?
Sure. So the question is, this session is about beginning your journey into the brain tumor diagnosis and experience. So having those initial appointments with your physicians, do you talk about symptoms and potential side effects from treatment early on so that patients are more informed, or is there any way that patients can be informed of that information during these beginning phases as they're trying to make those important decisions about what route is right for them?
Yeah, no, I think regarding the surgery part of it, as I discussed, we walk through the details of, what their starting symptoms are and what realistic expectations are for how those symptoms might fare after surgery. And so the nature of the brain is such that even though many symptoms may slowly get better in the long run, they should be prepared for the possibility that they'll get worse for a few days after surgery. And so that's one thing we discuss. I think in terms of new symptoms and risks of surgery, I tend to word those as percentages. So give them sort of a, this has a 1 in 100 chance of happening, or this has a, 1 in 10 chance of happening, to just give them a sense of not just what might happen, but realistically, is it a likely outcome or is it a less likely outcome?
Thank you so much. Another question we have is talking about community hospitals. Unfortunately, sometimes at community hospitals, patients and families might not have access to the breadth of knowledge or patient support that they would at larger institutions. What advice can you provide for patients and families that are at smaller hospitals, smaller institutions that are trying to get that information so that they're not kind of left in the dark or are naive about what they're going through?
Dr. Aggie, would you like to start, and I'll
Sorry,
finish?
smaller. I'm not. It was breaking up on me.
Oh, I'm sorry. For patients and families that might be at a community hospital that doesn't have access to the resources or information or knowledge that a larger institution might have. Patients might not be getting the same information that they would at a larger institution, but they still need that education and insight as they're trying to make decisions, trying to understand their diagnosis. So how can we ensure that those individuals are still getting access to quality care?
Well, I think the ABTA offers a large amount of information that can sort of help describe sort of standard terminology, standard processes, information about pathology, treatments, et cetera. I think the community patients at community hospitals still have access to, especially these days with telehealth, they have access to the larger centers no matter where they are in the country. And so we are often, doing phone calls or sending out information to people very far in isolated regions. So I think we should, it's really important to understand that location is less of a barrier than it used to be. And certainly when it comes to information, it's available to everyone. And I've had conversations with people over the phone who don't have internet access and are really, and then I've, sent them information through sort of the US Postal Service. So I think persistence is the key, because the information is out there no matter where you are in the country and what your access to technology is.
Thank you. And Dr. Dunbar, did you have anything you wanted to add?
I agree. Information is incredibly easier to get about your tumor at the new diagnosis time point, particularly through legacy information available on sites like the ABTA and other references that I put at the end of my slide set. I agree that local community teams of providers can communicate so much better with additional colleagues at academic centers or places around the country or the world when appropriate. And we can do a lot of the work of communicating or sharing information, whether it be searching for clinical trials or multidisciplinary tumor board meetings. So I will share with you, though, that have an honest conversation with your provider and say, I'm interested in getting the best initial start to my brain tumor care. What are the questions I'm not asking? What are the things you would do if you were my, if you were my family member? What would you have me do? And if it's not available here, how can you and I partner to do those things virtually or physically? And they may put a well-placed referral for you, or can tell you about a resource that you decide, if you have the means and desire to go, that you would like to pursue it. But you may find out that your tumor is sufficiently common that state-of-the-art treatment in your local community is more than sufficient to get started, but that at a later time would be more high yield to seek virtual or physical support from a further away location. So a lot of it is honest dialogue and touching base with programs like this.
Thank you so much, both of you, for your insight on that. Another question goes back to second opinions. So we talked a little bit about how patients do have the right to obtain a second opinion and talk to other institutions and doctors. How can a patient actually go about receiving a second opinion? Can you just share a quick overview on what that process looks like, how to get a second opinion, and then how do you weigh those two decisions when you're deciding what's right for you?
So I can start with that. There's a number of mechanisms for it, but sometimes your insurance will authorize a second opinion if the same provider who referred you to the first opinion places a referral to the second. It'll be marked as a second opinion, and some insurance companies will authorize that. Sometimes it may be something that's paid for out of pocket, but if it's just a consultation, the out-of-pocket costs, and it's labeled a second opinion, the out-of-pocket costs may be very manageable. So we offer a second opinion service that's, and I don't have, it's a very small out-of-pocket cost for just a quick consult, in part because the nature of a second opinion is such that the information may be for the provider packaged in a way that allows them to work very expeditiously and get you your answers quickly. And in some ways, time is of the essence with second opinions because that clock is already ticking, particularly for more advanced disease or higher grade disease. So there's mechanisms both sort of formally through insurance and through your primary care doctor, as well as just self-advocacy that allow you to obtain that.
Great, thank you so much. Unfortunately, that's all the time that we have for questions for this session. Thank you both for sharing your insight and opinions. I will turn it back to Emily and we'll move forward with the rest of the program.
Thank you so much, Dr. Aghi and Dr. Dunbar, for kicking off our meeting with such an informative session. We hope each of you gained insight into how to prepare for your medical team. And thank you to those of you who asked questions. If your question was not addressed live, the speakers will stay on a few minutes and type a response back while we move forward with the rest of the program. I'm going to hand it back over to Chair Dr. Dunbar to introduce our next session and our next speaker.
Thank you. What an honor it is to be able to introduce Alvina. What an incredible resource she is, and you are going to be so excited to hear her talk. She is a psychosocial behavioral specialist, currently at the helm at the National Cancer Institute, NIH, Neuro-Oncology branch in Bethesda. However, she's really representing a lot of America in the world. She has lived in Oklahoma City, Houston, and even a period of time in Africa with her family. So she really has an international viewpoint on what she'll be speaking about today. She has served special roles in a variety of disease processes, including ependymomas and many at the NIH. And she's excellent at looking at innovative strategies for mental health and coping, not only for helping people have the least amount of symptoms while they're receiving treatment, but even into out-of-the-box innovations like virtual reality for coping with symptoms. So Alvina, take it away.
All right, can you hear me?
We can hear you.
Okay, awesome. All right, so thank you, ABTA, for having me, and to everyone that has joined today, welcome, and hope the information shared today is helpful as you navigate through your journey as a patient and as a caregiver.
You should have control.
Okay.
There you go.
Okay, I have no disclosures. All right, so before getting into some of the tips and techniques and how you empower yourself during this time, I wanted to share a few slides focusing on the brain tumor patient experience and provide some insight on what you could go through and make sure you know that you are not alone in your experience. With a cancer diagnosis, you will experience difficult emotions throughout the illness trajectory. And depending on where your tumor is located, you can experience mood and personality changes. It's important to note that brain tumor patients report an elevated level of distress prevalence. And with this emotional burden, it can be challenging to find healthy ways to cope with your illness. Being diagnosed with a brain tumor can feel like a traumatic experience where you're caught off guard, you aren't ready, and the emotions you experience can continue to feel like they're not going away and can show up at unexpected times. So when you were newly diagnosed, you may go through the Kubler-Ross grieving process and just losing some aspect of self and working through those emotions. I will go through the 5 original stages, and then I'm also sharing some additional stages that were added by a psychologist who dealt with her own chronic illness and what she felt were important areas that she experienced during her journey. To start, shock and denial in the beginning may go hand in hand. There are questions about, how your life is going to change and how you're going to live with those changes. It's important to note that if someone continues to be in denial, then taking the necessary steps to manage your illness may be dismissed, and this can be a dangerous way of coping. Then you can move into guilt, where you can look back at the decisions you've made that you may regret, you may bargain, plead, and feel desperation in this stage where you feel if you start to exercise more or eat better, you would hope that your illness goes away. Next is anger. Once you know that your pleading and bargaining won't work, the anger settles in, and anger is a necessary process of healing, and it has no limits. It can extend to doctors, family, friends, your loved ones, and it can be felt later on in your illness and can hold you back from doing some of the things you would like. Next, we move into anxiety and depression. These feelings may feel like they may last forever, and you may withdraw from life. One of the things to note is that the experience of depression may not be a sign of a mental illness. It could just be an appropriate response to this change in your life. But if the feelings of depression are lasting for a longer period of time, then make sure you do seek help. Then we move into loss of self and confusion, where you're not able to recognize yourself. You may be physically limited. Then it's about reevaluating your life, role, and goals. Being diagnosed can mean you may have to give up some things. And so it's about making some adjustments to your goals, reevaluating your role as a husband, sibling, a friend, and looking at what you can do with life now and moving towards a space of acceptance. Not saying that you're okay with where life is at, but now you're just okay with making the necessary adjustments to live your life in the way that you can. Some call this the new normal. And also I wanted to add that this is not a linear process. How you experience the stages will be different, and some areas may not show up for you, and others you feel you may go back to off and on as you're dealing with your diagnosis. So let's move into just, how you're dealing with your diagnosis. I know there are questions and concerns you may have, but like I mentioned in the beginning, you are not alone in your experience. This list of questions is more about checking in with yourself to see what has been going on in your head lately. With you being newly diagnosed, are you finding it challenging to adjust to what that new normal is? Do you feel you can't control different aspects of your life anymore? Are you scared? Does anxiety and uncertainty creep up on you? And are you concerned about your family? All these questions are important to be aware of, and how you focus on what you can control is important during this time. So let's move into normalizing how you check in with yourself and prioritizing this in your daily routine. The following are a few questions to ask yourself as a way to check in with your feelings. First question to ask, how am I feeling right now? Knowing what your primary emotions are, which are the emotions we usually see, like anger, sadness, happiness, and then going down further into your secondary emotions, which can really give you an idea of why you're feeling the way you do. And as you can see from this chart, The secondary emotions extend out from the primary emotions, and the darker sections of the circle show their intensity. So for example, let's say my primary emotion that I'm experiencing in this moment is a little bit of fear. And to understand a bit more of why this feeling is showing up, that secondary emotion is a little bit of anxiety, wanting to make sure that my presentation goes well. This is a great tool to use to understand a bit more. So yes, this is a great tool to use, something to carry with you, especially if you ever have difficulty with expressing your emotions. And next, I want you to think about what do you need in the moment, especially if it's an unpleasant feeling. Sometimes it's being able to ask yourself, do I need rest? Do I need to eat? Or is this a good time to really share with someone how you're feeling? Then it's about what that first step can be, from getting something in the pantry, maybe taking your shoes off to sit and rest, or opening your contact list and calling that person will provide the support you need. So it really is about checking in with your emotions, not allowing them to just sit and dismiss them. It's about acknowledging their existence in the moment and taking a proactive approach to get to a place where your emotions are less intense than when you started. I recommend, checking in with yourself on a consistent basis, scheduling it daily so it becomes part of your routine so that you're able to take moments to make sure you're feeling okay before moving on to certain tasks. And a link for this chart will be shared with you after my presentation. So now when you think about feeling empowered, it's first defining it, knowing that it is the knowledge and confidence you have to have influence over different aspects of your life. That feeling that you get in validating yourself, making certain decisions to improve how you feel about a situation, improves your sense of self-worth and the value you place on self. And ensuring that feeling continues to show up in different aspects of your life means utilizing certain steps to get there. So first, it starts with creating goals that mean something to you. Let's say you want to improve your communication with your healthcare team, especially with being newly diagnosed. You want to make sure you have that connection with the people that will be taking care of you. So once you establish your goal, it's moving into taking a specific action. And that action could be preparing for your appointments by keeping a journal in between appointments to report your symptoms, or it's about working on being assertive and asking for things to be repeated for you, or maybe just having someone there that can help with asking questions during your appointments. Once you figure out what that specific action will be, it's moving towards gathering evidence. And this will be the stage where you see what is working and not working from your action plan and making adjustments as needed. And lastly, it's about being able to witness a real change. This is where you celebrate because of the work you have done to take control of a situation that wasn't working the way you liked. So now, based on your efforts, the change you notice could be how comfortable you feel during your appointments, or just feeling like your voice is being heard. And so building on this image you have of self and your abilities, it's also about focusing on self-efficacy, where studies have shown that the more effective patients feel in their coping capacity in dealing with their cancer diagnosis, the more adjusted they feel and they enjoy a higher quality of life than those that feel ineffective. And so with all of that information, now let's focus on what you can do during this time to feel empowered during this process. So first, it starts with awareness of unhealthy ways you're coping to understand what things aren't helping you during this time. The first thing is being aware of if you're withdrawing socially, not communicating with your loved ones, missing events or calls intentionally, wanting to be left alone. And with this, when you start to be alone with your thoughts, that's when everything you can think of can seem problematic and can exacerbate unpleasant emotions. Number two, know when you're getting hooked on the why thoughts. How does it help you in this moment? Does it take you away from gathering the evidence you need to answer some of those why thoughts? For the questions that you and your providers may not have an answer to, creating healthier ways to cope with those unknowns may be helpful. Maybe create a list of distraction techniques that help with shifting your focus get back into a hobby, create a playlist of calming songs to listen to, watch something, or maybe listen to a podcast. Number 3, make sure you know when you're trying to power through your symptoms to the point where you aren't listening to your body and understanding, what it may mean in certain moments. Rest is okay. Having to make adjustments on how you do certain things is okay. Taking longer steps to do something is also okay. Number 4, dismissing your emotions makes it easy to have all those uncomfortable emotions pile up, and this allows them to come up in unexpected moments towards the ones you love. Number 5, if you're getting into the habit of researching, understand what that does. If it creates certain feelings, know your why before you start researching. Make sure you know what information you're trying to get an answer to, and what are the reputable sources you can focus on in getting this information, maybe getting assistance from someone and setting those limits so you allow yourself breaks and you're not just searching to search for things. Create your reasons before you start so you know what you're trying to answer. And number 6, know when you keep comparing your journey to others and why that isn't healthy for you to do. You may have the same diagnosis, but your journey will be different, and your stories may not align in your experience. So don't look at yourself as the one that is experiencing more symptoms or less. Don't try to place labels on yourself that keep you in this box that you feel you have to fit into. And number 7, not having an outlet can also impact you in an unhealthy way. If you're holding your thoughts in, not communicating, how this process is affecting you, no one will know. And this could be where having a psychotherapist help who has had experience working with cancer patients can help you in how you process things. And lastly, with number 8, when you disqualify the positives, you start to only look at the negatives. You let this be what consumes you, not saying that you need to find the positives all the time because some days may be tougher than others. But when small positives do happen, try to savor in that moment. From a positive MRI, maybe it's forming a better bond with certain family members throughout this process, being happy with just having support around you, and maybe just feeling less intense emotions than your last appointment. These are experiences to look out for. They can help you change your outlook a bit. So look for these moments and create a process on how you continue to remember them. So next thing, on building on how you feel empowered, it's about recognizing the things out of your control. When you start to think about all those things that you don't have an answer to or can't control, like the results of your MRI or how long it may take you to recover from surgery, focus on doing something called dropping anchor. When you drop anchor, think of it as this. Just like you would drop anchor when a boat sails into the harbor, just as a huge storm is approaching, you drop anchor to manage an emotional storm of just feeling overwhelmed, having any unpleasant memories, or dealing with a stressful situation. It's a way to get some control in the moment and get out of your head using the acronym ACE. So with A, it's for acknowledging the feelings and thoughts you're having in the moment. So right now, I'm noticing I'm feeling a little bit anxious. And then C is for coming back and connecting with your physical body to just regain a sense of self-control, being able to focus on what you have the most control over when difficult feelings and thoughts arise. It's the physical actions that you can take, shift your stance a little bit, breathe, stretch, put both feet on the floor as a way to just control your movements. And then E, a way that you engage with your world. Focus on what you're doing, focus on where you're currently at. Is there a task to work on to really just get your mind focused on what you need to do? So in any moment, you can use this statement, I need to drop anchor, and then use your acronym just to kind of manage, what things to do in the moment. This is a way that you just gain your control back, focusing on some of those things that you can control. Now, some of those things that you can't control, how you're communicating with your family and friends, how you manage your symptoms as they arise, getting a second opinion, making some adjustments in your life to really accept what that new normal is. It's about how you put certain plans in place to prepare for certain things you may go through as you're navigating through your brain tumor journey. So whenever you start to think about everything you can't control, again, ask yourself, what is this taking me away from? And what can I do now to move towards how I would like to live my life in this moment and what's within my control? All right, so now with all of the things to be aware of, it's now about focusing on some of the things you have some influence in to make sure you're creating a life for yourself that helps with improving your overall well-being. So first, it's about just managing those self-defeating thoughts, focusing on ways that you can restructure some of the thoughts you have. It's very easy to come down on yourself, but creating a new set of statements like, I will just take this day by day, or I'm doing the best that I can be ways to really help you take a step back from continuing to label yourself when things aren't going as well. Number 2 is keeping a journal. It's a nice way to express yourself, especially in moments where you feel others may not understand what you're going through. It can be a way to problem solve and also help you separate what things you can do something about and what things it's just about working on how you just accept that it's happening. Something called a constructive worry time, where you set aside time each day to think about some of the concerns or worries you have. Writing them down, spending time on each, thinking about what that first step you can take will look like. And if something is out of your control, then it's what things you can do to let it go. This method is helpful so that you're not constantly bringing your worries to bed. And it's a way to focus on those things earlier on in the day and just creating a system for how you manage your thoughts. Journaling can just be a way really just to release anything that's going on with you. You can write as messy and as neat as you want because it is your journal. And also journaling prompts can help with just not feeling like you're writing the same things over and over on a daily basis. All right, so number 3, it's tapping into your feelings, accepting that positive and negative feelings will happen. And also, if there's ever an issue with communicating your feelings, knowing that there are other ways you can describe how you're feeling, from colors, maybe a cool blue, or maybe red hot, to maybe a former shared experience where you were feeling happiness or joy, to levels of intensity, so light, medium, or strong, where light may mean, in this moment, I'm not crying anymore, I'm doing okay. Medium could be, I'm smiling through it. And strong could just be, I'm feeling really ecstatic right now. Have some ways that you spend a bit more time with yourself and others when you're feeling good. And for those not so great days, check in with what you need. And number 4, communicate your needs. Have someone that you can talk to for you to get any help that you need. Make sure you're having those open and honest conversations with loved ones you trust and your healthcare team. Now also, if you want to implement a system on how you will communicate with your family and friends after your appointments to help give you time to process anything, create a plan for that as well. And number 5, create a life that is still yours by making routines that work for you now. This could be a time where you create a different set of goals from short-term to long-term goals. And with your goals, creating a system. Some have found the SMART goals method helpful in accomplishing their goals. First, starting with S, being as specific as possible about what you want to accomplish. Then M is moving into how you will measure this goal, how you will track your progress. A is this goal attainable? Can you achieve it? R is asking yourself if this is a realistic goal for you, making sure you're not putting unrealistic expectations on yourself. And then T is timely, having a date set on when you would like this goal accomplished so you know how to pace yourself and you can make any adjustments along the way if you need more time. Number 6 is balancing out your time. Creating a system on how you want to focus on certain tasks, complete certain activities when you know you'll have the most energy, and with your daily routines, create a life outside of your appointments. Schedule time for yourself to focus on other things that may help you relax and take your mind off of things. And lastly, with some of the things already mentioned, some I feel can fit in some of these areas that I'm about to go through, but I thought it would be good to highlight the different dimensions of self-care to know what it can consist of. You know, most of this content was pulled from the NCI Connect's website for rare brain and spine tumor patients. It's a section on self-care that that I help to develop for patients. And I know sometimes we hear self-care get thrown around a lot, and sometimes it, you know, the focus is really just on pampering yourself. But I think hopefully with looking at these different dimensions and what, you know, you can include, it really is about just, you know, simple techniques that you can apply on a, you know, a daily basis. You know, you can create your own checklist of things you would like to prioritize with each dimension, but here are some examples to consider in managing your self-care. So when we talk about physical self-care, it's really just how you take care of your body, and what that can look like can start with creating a sleep routine for yourself to help with just, you know, how you decompress from your day and help ease you into sleep. You know, maybe adding activities to help you move your body, you know, listening to your body and recognizing signs that tell you it needs rest. Eating a nutritious diet to help improve how you feel is also part of this. And then next is your mental self-care. This is how you manage your mental state, and that can look like saying no to the things or people that don't put you in a good frame of mind, you know, setting limits for certain tasks, learning to disconnect on certain days, and maybe setting certain daily intentions for yourself to get your day started in the right direction. Next is your emotional self-care, and it's about how you effectively manage your emotions, having healthy ways to cope with a range of emotions you experience. You know, doing this can mean creating a coping skills box, you know, filled with things that can help manage unpleasant feelings, from pictures, scents, cards, or messages. Now, within this dimension, you want to incorporate possibly a deep breathing technique to help shift your focus in tough moments. You could create a list of triggers to be aware of that cause, you know, certain unpleasant emotions, and creating a plan on how you handle them. And also you could utilize psychotherapeutic services by talking to a therapist. And social self-care focuses on the connections you continue to prioritize with others. This dimension can include creating a system to continue to check in with your partner or loved one, even as life gets busy. Also, sitting down to think through how you divide up responsibilities. You can also set time to do fun activities with loved ones and friends throughout the month, and also remembering to communicate to someone when you need help. And next is professional or work self-care, creating a balance with how work will look and also how you will challenge yourself professionally. Let this area be how you bring awareness to what overextending yourself looks like and creating a plan on how you manage that. Also, starting the workday with creating a list that you focus on. You could end each day writing out 3 things you did well, and this could also be a good time to identify what resources are available to you from your employer. And lastly is spirituality, how you find meaning and purpose in your life. This is where you can focus on activities that reflect on your values and the things that matter to you. Meditation could be a helpful technique to implement to train your thoughts and shift your mindset. This is also where you can reevaluate some things, you know, focusing on what matters to you, what you want to do with your life, how you want to treat yourself and others moving forward. And then it's about setting some firm boundaries with people and situations that you know don't help with how you want to live your life in the moment. And I did forget to share that with caregivers, this information can also be used by you during this process. Most of the techniques can be applied for anyone that's just having any challenges, you know, with their emotions, with their thoughts and behaviors. All right, so this next section will be on how caregivers can build a support network during this time. So let's get into it. Before getting into all of the support network and you know what that includes, I think first it's about also creating a self-care plan for yourself that you will prioritize, you know, when things get tough, and you need to remember what things are helpful to manage how you feel. It's about creating this plan for yourself. First, it's focusing on a list that can be helpful when you are upset, overwhelmed, or stressed. With this section, include things that help you relax. Maybe it's the smell of certain things. I know for me, lavender is very helpful when I'm stressed. Maybe it's talking to friends, maybe painting, taking a walk. Really, recognize and write out what are those things that really help you relax. Also, what do you do when you're in a good mood? What helpful reminders can be helpful throughout the day? Maybe statements like, let me be aware of any areas of my body that carry tension, just so you're always possibly kind of scanning your body for that tension and hopefully release it in moments where you're feeling a little bit tense. And also just add anything else here you may feel maybe important to prioritize during these moments. And number 2 is just make a list of people that you can contact when you need support or distraction when you create this list. Put next to each person what they can help you with throughout, whether it's someone you can vent to, someone you can laugh with, or who will listen or just help encourage you. Number 3 is list out the positive statements or affirmations that you find comforting. If there are certain positive statements you read to calm your mind down, this is where you will add that. You just want to make sure with this plan that all the things that you tend to forget to lean into when you're feeling overwhelmed are now put in a place where you can remember they are there. Number 4, which is very important, is list out the things to avoid to not make certain situations worse. Avoiding certain conversations with certain people, not getting on social media, or just being alone with your thoughts. Know the things that may trigger you into unhelpful behaviors during times of stress. You want to make sure you create that support for yourself so that energy can be something that is uplifting instead of discouraging you during a tough time. And lastly, number 5, be creative on how you create this plan. Put it on a note card, but if it needs to be bigger, make it an art project and keep it somewhere where you can see it often so you don't forget it. Take a picture of it so you can come back to it when needed. And a quote that I thought was important to share that I heard during my meditation last week was, when you say yes to others, make sure you're not saying no to yourself. Okay, so now let's get into a few things on how you manage things for yourself and the patient. So first, start with who to include in the patient support network. This list is going to include everyone that will potentially play a role during this process to provide you the information and support you may need, and have a way that you organize this list. Your healthcare professionals can help provide you with additional resources you may not be aware of. Your family and friends can help out with tasks that you find you may not have time to do. Professional caregivers and caregiving organizations can help with resources and also providing you with assistance, giving you a break to run your own errands at times. And support groups may help in how you deal with this whole process. Being able to share your story with others that are going through a similar experience. And some things to ask yourself when looking for a support group to just make sure it will be a helpful and beneficial process for you. Are they helpful and supportive? How old is the community? Is the community specific to my needs? And is there a medical professional moderating or facilitating? Just to make sure there is balance in the content being discussed. Number 2, how will you share your needs? Sit down and figure out what are some of the things you will need help in. Create a checklist, and the ABTA has that covered for you, in addition to resources in their caregiver handbook and resource center, as well as other social support options like their support group locator and their peer support network that can connect patients with a mentor who has been through a similar brain tumor experience. And our other speaker, Megan, will go more in depth of what social support resources are available to you later on in the afternoon. Just revisit your checklist often if things change. And also when you need to share your needs, learn to utilize assertive communication where you implement I statements. So I need your help with how to communicate with the insurance company, or I would like your help to collect resources regarding the patient's diagnosis. And number 3, how will you delegate tasks? Assertive communication is also helpful here. To figure out who all will be helping and get input on how you can provide help for you during this time. Create a plan on what help looks like, from helping you run errands to helping with cooking, or also if you're not able to be available for an appointment, who could step in for you. The system you create will help with how you stay organized and be kind to yourself during this time. It could take time to get everything the way you would like, and know that there may be some tasks that you would have done differently, but take those steps back to savor in just having that support so you don't have so much on your plate. A few resources for signing up for different tasks and scheduling of those tasks can be found on Caring Bridge, Sign Up Genius, or Lots of Helping Hands. So next, how to support the patient. Information from cancer.net provided some ways to start. So start by having conversations so this process with the patient feels like a collaboration and everyone is on the same page. Learn to create routine check-ins for how you guys check in with each other on how you're doing, or just creating any goals together. Suggest specific tasks that you can help with if the patient is having a hard time deciding what you can help them with. You could also organize a phone chain or support team to check in on the patient. Creating a list of things you can do together outside of your appointments can help with taking everyone's mind off of any stress that is occurring. You could also help out with fundraising if that is something you both agree on. And also helping to just make sure those difficult calls could be a task, or just be the point of contact after appointments so people know who will communicate with them to get any updates. This process will take work, but it's working together to see how you both continue to make sure you're taking care of the things that are needed. All right, so with everything that I covered, also wanted to highlight some studies within the neuro-oncology branch at the National Cancer Institute that focus on improving the psychological distress you may feel. And since I focused on well-being techniques, wanted to share that we have a virtual reality study open and recruiting from our postdoc, Dr. Amanda King, that uses a VR headset to manage distress. You can choose from a variety of scenarios that can assist in relaxation, which can be a healthy coping technique to utilize to help deal with any anxieties that may arise prior to your appointments, during and even at your home. You also get to keep the headset, which is also nice. The next study is the Calm Intervention led by myself, which allows you to work with a calm therapist, participating in 3 to 6 sessions to help provide you a space to process your feelings. This study is currently being reviewed, and we hope to have it up and running in the next few months. And both studies wouldn't be possible without the help and guidance of Dr. Terry Armstrong and our team at the NOB, and also our branch chief, Dr. Mark Gilbert. And here are some resources that will also, I think, be provided to you after the presentation. And thank you again for tuning into this presentation. I hope that it was helpful in just really helping you restructure your perspective during this time. Thank you to the ABTA again for giving me this opportunity, and I can take any questions.
Thank you so much, Alvina. That was a great presentation. As a reminder, if you have questions that you'd like to ask for this session, please type and submit it using the Q&A box at the bottom of your control panel, and we'll answer questions as time allows. All right, so one of the first questions we have here is regarding sharing your thoughts and feelings. You talked about how it's really important to be able to recognize how you're feeling. But how or what advice can you provide for patients and caregivers that are trying to communicate that to each other? So a caregiver trying to explain to a patient how they're feeling, or vice versa. Because it can, especially for caregivers, they can be a little apprehensive about talking about their own feelings when the patient is the one that's going through the brain tumor diagnosis. So what advice can you share on that experience?
Yeah, no, that's a really good question. I think one of the things I think with the check-ins that I mentioned is I think creating those goals of like what those check-ins look like. And so if those check-in, I think if the goal that has been set is like, okay, within our check-ins, we are going to focus on some of these difficult conversations that, we want to discuss in this space, just so both of us are understanding where the other one is coming from, then I think it's bringing that into those check-in moments. I think it's really about, reflection. So when you're tuning into what the other person is saying, to make sure, each of you are understanding and listening, it's reflecting back what you're hearing. And I think also at the end, it's knowing what the goal is. Is there a problem solving technique at the end? Are we working towards, something during the conversation? So it's knowing that, I think being open that you're going to have those difficult conversations, but kind of creating those spaces to do that, whether from the check-ins that you have with each other.
Thank you so much. Mm-hmm. Another question that we have is asking about journal prompts.
Yes.
Where can patients and caregivers find journal prompts so that they can get some information on, how to jot down their feelings and what they're going through?
Yeah, there's, you can definitely just Google journal prompts, and I could also provide some if needed. But yeah, you can really just Google journal prompts that, focus on certain things, whether it's journal prompts for your feelings or journal prompts to manage your thoughts. And so with that, you can get a list of prompts that help you really start out, how you journal.
Thank you so much. And just as we go through the questions, I'm going to leave this resource slide up for anyone that wanted to jot it down.
Okay.
Another question we have is about being able to ask for support. And again, this is from the caregiver perspective.
Okay.
You talked about how to identify what your needs are and sharing those needs. Mm-hmm. But can you provide any advice for those caregivers that they kind of feel like they have to take it on, excuse me, all on their own and may not be as open about reaching out for the help? What advice can you share for them to let them know that it's okay to reach out for help?
I think one, you have to give yourself some self-compassion during this time, right? Because this is, I don't know if you've, heard the quote. It's like, for you to take care of other things in your life and to fully put yourself, in those things, like you also have to make sure like your mental and emotional needs are being taken care of. And so I think that's why I think it's that importance of checking in and knowing like sometimes you can't do it all, and so, being okay, like if other people are asking and wanting to help, whether it's giving them small tasks, but it's recognizing when you are not being kind to yourself and knowing that, hey, sometimes you need rest, sometimes you can, ask for help, and it's okay to do that. It's okay to be a little bit nice to yourself during this process.
Thank you so much. I think self-compassion is definitely important, both for patients and caregivers as they're going through this challenging experience. Okay, let's see. Another question we have is about guided meditations and breathing exercises. Mm-hmm. We will be sharing links to these exercises in our resource handout, but do you mind just touching on some of those resources and where people can turn to, maybe if someone wants to start looking into those right away?
Yeah, so guided meditations, just like, for the prompts, like you can Google them also on YouTube. There's also there's different apps like the Calm app or Headspace. But with guided meditations, it really is just about a way that you're guiding yourself or someone is guiding you through the relaxation process. And, for some meditations, it's from 5 minutes, anywhere from 10 to 15 minutes or longer. But it's just a way of how you kind of, calm your thoughts down. You stay in the present moment, even when things are distracting or maybe come into your head. It's still basically coming into your body to know like, hey, I can relax in this moment. I can take some time for me. And I think with any meditation, it's creating those spaces in your home. So if it's about, creating, I know for me at one point I was going in my closet, especially if life around me was busy, that was where I would meditate. So, finding a space where, you won't be bothered for a few minutes and actually doing your meditations there. And then relaxation techniques. There's different breathing techniques of diaphragmatic breathing, where it's really doing that deep breathing from the lower part of your abdomen, because when we are anxious, we usually breathe from the upper part. So just learning, different deep breathing from 4-7-8 breathing or square breathing, and all of this you can Google as well. And then also just like progressive muscle relaxation is a way that you just learn how to identify when your body is tense, but also it's a way to release. And so recognizing, that in moments where you do feel tension, there is also a choice that you can make to release that tension in those areas.
Thank you so much for that great advice and insight. Another question we have is regarding someone who might not be having symptoms, or maybe they have a benign brain tumor, but they're still experiencing a lot of fear and uncertainty related to their diagnosis. Is it normal to feel that way, even when you're not having symptoms, or you might not be feeling as bad as somebody else? And how can we accept those feelings and then move forward?
I think what comes to mind here, or the word that came to mind was like survivor guilt or survivor's guilt, where yes, you feel like, how did I not have that many symptoms? And I think it's accepting that your story, is still a story to tell. Like, you have this narrative that you can still share, like you can still, share the feelings that you're experiencing. I think, like I mentioned in one of the slides, not comparing yourself to others. Like, what you're going through and what you're experiencing is just as important as anybody else's. And so if you're having difficult feelings, whether it's how you journal, having a therapist that you talk to, having a close person that you share, this information with, I feel like it's still really recognizing and having that awareness that your story is just as important. You're going through a change. And so it's being able to kind of gradually deal with that, not being afraid to express the feelings that you're having, and having other ways that you manage your self-care.
That's great, and such an important topic to touch on. So thank you so much for sharing your insight on that. Another question we have is regarding therapy. How can patients find a therapist? Is this something that is affordable? And is it something that's covered generally by general insurances?
That's a good question. I think it depends on insurance. I think there's, a certain amount that's covered, but it's really checking with your insurance providers to find therapists or psychologists for counseling. You can start with Psychology Today. There's also, online therapy that is available, like virtual therapy, where you do maybe phone sessions or video sessions online with a therapist. I think there's a BetterHelp, there's Talkspace. So there's different resources, especially maybe if you don't want to physically see someone, you can, also choose to do, virtual services.
Thank you so much. Now, another question we have is regarding how can patients tell the difference between whether, the mental issues and experiences they're having regarding their mental health is just related to, the emotions of having to deal with a diagnosis like this, or it's related to the brain tumor itself. Should they be bringing up these concerns with their provider, with their social worker, and how do they talk about it?
I think so. I think it's important to bring it up as you are, coming in for your appointments. I think that's where, the whole maybe making sure you're jotting down the symptoms that you're experiencing in between appointments. For some, mental health diagnoses like depression, if you're experiencing these symptoms for, 2 weeks or more, making sure that you're getting the help that you need. And so I think, keeping a log of this and bringing it up to your providers, just so that they are aware. And also it's something that, from one appointment to the next, they can keep note of it. And hopefully with that, it's, if things continue to get worse, they can possibly recommend, seeing a social worker or seeing somebody locally.
Thank you so much, Elvina. It looks like that was the last question that we had. Thank you again for your time and your insight. I'll go ahead and turn it back to Emily.
Thank you.
Yes, thank you so much, Alvina, for sharing with us this really informative and empowering session, and for sharing all the wellness practices and strategies to empower oneself during a new diagnosis, or even if you're caring for somebody during a new diagnosis. As Ambreen mentioned, all the resources mentioned in today's, the whole program actually, as well as just the presentation you heard, will be shared post-event, so each of you can access the resources at a later date. And thank you to all of you who have asked those really important questions. We will now have a short break featuring our sponsor lightning round. During this break, sponsors will share about what resources they offer to patients. We encourage you to listen in during this break to gain useful information. For those of you who need to actually take a break, feel free to stand up and stretch your legs, use the restroom, grab a snack or a beverage or something to eat, and we will resume the program at 12:45 p.m. Central Time, so about 25 minutes, and then we will resume the rest of our program. Enjoy your break, and we'll see you back soon. Bye.
I had my daughter, and now she's 19 months, and she's a little human that we created. So we pretty much watching her grow up. Can you say hi to the phone?
Hi. Here we are at our turnaround point, and you see I'm totally alone. Aha! We found him. He's a shade seeker.
Sonny and Dottie and Laura graduated from medical school.
We didn't know that we would have the opportunity to sit there in the audience and hold hands. Well, they recited the Hippocratic Oath. So that was pretty special.
I've got a daughter and I've got some grandkids and a husband, and every time we get to celebrate one of their birthdays, it's just one more time that I'm here for it. And I'm so thankful for that.
Happy birthday, dear Pierre. I gave Pierre a really special 60th birthday party last year, which also happened to fall on the day of his diagnosis anniversary 1 year. There were 55 people there, and they came from all over. Friends came from Texas, from Chicago, from Oregon, from Washington, and it was really special for him because it was all his friends really celebrating his life.
My wife and I were able to go to Ireland this year, and we spent 8 days there, and it was a great time.
This thing called a 5-peak challenge. You basically do the 5 highest peaks in San Diego in one day. I'd been training for that before, and I kind of took a break because obviously I had surgery. And I built myself back up. I accomplished the 5-peak challenge, which was a big feat for me.
Pierre is a major football fan, being from Texas. So I bought tickets to a Chiefs game at Arrowhead Stadium in Kansas City and flew us out there for a game. During the halftime, the cheerleaders came and found us and gave him a signed ball by Chris Jones. So that was really amazing.
I'm an avid guitar player, so I got back into doing that, and I played a couple live gigs and just doing that with the Optune on. So I wasn't going to let cancer or the thought of cancer and the diagnosis kind of take away from living my life.
Each year on my craniversary, I send a note to my surgeon and to my doctor and just, tell them how appreciative I am that I'm still here to be able to send that note.
Hi, I'm Christina Schultz, Head of Patient Advocacy at Karyopharm Therapeutics. We would like to thank the American Brain Tumor Association for all they do to support patients and their families, and we are proud to support the 2021 Patient Family Meeting. Karyopharm is a commercial stage pharmaceutical company pioneering novel cancer therapies and dedicated to the discovery, development, and commercialization of first-in-class drugs directed at nuclear export and related targets for the treatment of cancer and other major diseases, including glioblastoma. If you would like more information on Karyopharm Therapeutics, our novel compound selinexor, or clinical trials we're enrolling in glioblastoma, please visit our website at www.karyopharm.com. That's www.karyopharm.com. thank you again to the American Brain Tumor Association for this opportunity to support the 2021 Patient Family Meeting.
I know everyone's jumping back on after the break. We hope each of you were able to take advantage of the break and stretch your legs, get a glass of water, grab something to eat, and we are now ready to start our afternoon program. Dr. Erin Dunbar will introduce our next session and speakers. Hi, Erin.
Hi, everyone. Welcome back. I'm very privileged to introduce the next two speakers. Firstly, they've been integral members of Women in Neuro-Oncology and Women in Diversity Committee within the Society of Neuro-Oncology, which is helping to make sure that we fully represent those who we are caring for and that the providers who care for patients are being fully represented. So thank you to them. First, I'd like to introduce Dr. Priya Kumsekar. She's representing the North Central area of the United States at Northwestern University. She is an associate professor in the Division of Neuro-Oncology at the Feinberg School of Medicine. She is a clinical trialist and an educator. Areas of interest include metastatic disease and clinical trials for novel therapies. I'd also like to introduce Dr. Seema Nagpal. She is representing the Southwest at Stanford University School of Medicine and is a clinical associate professor of neurology in the Division of Neuro-Oncology. She is also an outstanding clinical investigator and educator. Her areas of interest include collaborative research, where she is translating between specialties to create novel advances to help people affected by brain tumors. I'd like to turn over the control to these two fine speakers to begin. Thank you.
Thanks so much, Erin. So Emily, do I have control of the screen now? Is that right?
Yes, you have to hit accept. It says it's waiting for you to control.
Oh, I'm sorry.
That's okay.
Oh, it's saying that I can now.
Let me try again.
Emily, I'm so sorry. Where is it? Where does it say accept?
I'm going to resend it in 1 second.
Okay. Oh, great. It says click to start control, so I clicked and I don't have control.
It says you have control. Try hitting your arrow button. There you go.
There we go. Okay. All right, perfect. Thank you so much. Hold on 1 second, okay? Oops. All right. Always still getting used to the virtual world still, right? Even a year later. But anyways, thank you so much, Erin, for that lovely intro. These are my disclosures. And what Dr. Nagpal and I are going to discuss today is the whole extent of brain tumor care, right? What we want to focus on is to let you guys know that brain tumor care goes well beyond just the tumor-directed therapies. You know, we talk about chemotherapy, radiation, surgery, and so forth, but that's just the center of our spoke here. You know, there's this whole other area around there of brain tumor care as a whole that goes well beyond these treatments. And in that is also the quality of life. That's equally important to us as neuro-oncologists as the cancer care and the tumor treatment directed therapy itself. So this includes things like managing medications, activities of daily living, and integrating all these health concerns outside of just the direct cancer care and the direct tumor care. So this in and of itself, Dr. Nagpal and I could talk for hours on end, I'm sure, and we've selected some key topics that we think are going to be most hopefully beneficial to you all today. So the three that I'll be discussing, so this is kind of everything around tumor treatment care. The three that I'll be discussing today are steroid management and side effects related to steroids. I'm going to talk a little bit about brain tumor rehabilitation, the different components of it, and what brain rehab means. And then I'll also discuss, something very pertinent to the times right now, brain tumors and its relationship to COVID-19, sort of facts you should know. So as many of you guys know, steroids, corticosteroids, particularly dexamethasone, are frequently used in tumor care. And it's very possible that many of you or your loved ones could have received therapy with dexamethasone. It's often prescribed before and after surgery, and it's really prescribed for brain swelling. And so the medical term that you might hear for that is cerebral edema. So cerebral meaning your brain, and then edema is the medical term for swelling. So when brain swelling can cause a variety of neurologic symptoms, including headaches, nausea, vomiting, or focal neurologic deficits. And the way that I explain this to my patients, where if we were to sustain, let's say, an injury in our arm, we technically have infinite amount of space to swell because there's nothing kind of caging it in. Your brain is different because when your brain sustains an injury of any sort, it's limited by the skull. So when it swells, just like anywhere else in your body that sustains an injury, it swells, that fluid accumulates, and the brain is sort of caged in by the skull. So we see all of these symptoms that occur for that reason. So we really reserve it in use outside of the perioperative or before and after surgery. We really reserve the use of steroids for patients with symptomatic brain swelling or symptomatic cerebral edema. We don't tend to use steroids with asymptomatic or brain swelling without a lot of symptoms. The way that I also describe it to my patients is, for me, I'm this character here on the right. It's a love-hate relationship. I love steroids for the amount of time that it helps my patients have an improved quality of life. But I also sort of hate it for all the side effects that many of you guys might be familiar with that it can cause. So I'm going to go over some of those today, but dexamethasone, so we've talked about this a little bit. This is what we use most commonly in brain tumors. And it's really similar to a natural hormone that's produced by your adrenal glands, which are glands that live right above your kidneys. That's why they're called adrenal. And they can be given orally, so in tablet form or liquid form, or it can actually be given intravenously or through your veins. Stopping the drug abruptly can cause negative symptoms. And this happens because when we give you dexamethasone, the natural hormones that are produced by your adrenal glands tend to slow down their production. They see that as a signal of, okay, there's steroids being brought in from the outside, so we can slow down production of it inside. And so for that reason, we gradually wean patients off of steroids, particularly when they've been on it for a long time, because we need to gradually have your adrenal glands start to make more of this natural hormone on its own. So there's a balance there, and that's another background as to why we might get side effects from steroids and a quick wean. So when we do wean too quickly, we can see things like loss of appetite or an upset stomach, drowsiness, confusion, headache, a variety of different symptoms, but that's the reason why we wean slowly. So this is a schematic of a lot of different side effects we can get from steroids. And unfortunately, it's not limited to what we see here. These are just some of the more common things. So as you can see from the model on the right, it affects pretty much every organ system in your body. And really from head to toe, it can affect everything. So it can start with your brain and cause things like mood swings or insomnia. It can cause with your skin thinning, actually, easy bruising, thinning of bones, or osteoporosis. It can cause stomach ulcers. So many of you guys who are on steroids might concurrently be on other medications that can help protect your stomach. And what we see with long-term use is what we call your hip and shoulder girdle. So your shoulders and your thigh muscles can get weak. So that can impact when you are, for example, standing up from a seated position or getting up off the toilet. Can cause weight gain, high blood sugar, can raise your blood pressure, and can lead to infection. So it can cause a slew of symptoms.
You have control now?
All right, so with all that negativity, Why use it? Well, there's a lot of good reasons why we still use steroids. So the main reason is, of course, it decreases swelling. And the way it does this is by decreasing blood-brain barrier leakiness. So in your brain, the blood vessels have what's called little openings here where fluid can literally leak out. And when that leaks out, then swelling increases. When we fix that leakiness and less water leaks out, that swelling decreases. When that swelling decreases, there's less pressure on the brain around it, and therefore whatever symptoms you might be experiencing, headaches, nausea, whatever the case may be, should decrease as well. So this is a brain image that your doctor might show you, where you can see here this white arrow is pointing to this, basically this white area, which is the swelling around the tumor. And on this right image, letter B, the swelling is depicted with this dark blackness. So that's the area that can cause a lot of symptoms that can be alleviated by being on steroids. So our goals of use is really to, again, improve upon the symptomatic swelling. So if it's asymptomatic swelling and not causing harm or quality of life issues, then we typically don't routinely treat with steroids. And that swelling can be from anything. It can be from treatment itself. So classic treatments that cause swelling are things like radiation or immunotherapy, or it can be swelling from the tumor itself. We really don't intend steroid for long-term use. So sometimes we just do it to bandage through the symptomatic period, and then we can gradually get off of steroids so that it doesn't cause a lot of those symptoms that we discussed. And an important thing to keep in mind is that steroids can make immunotherapy agents less effective because it decreases and it decreases a lot of different immune cells from being stimulated. So we want that immune reaction when patients are on immunotherapy. Bevacizumab has shown to decrease the need for steroids or dexamethasone. So often when patients become dependent on steroids, if they're getting a lot, particularly if they're getting a lot of those side effects on that slide that I showed you all, we often replace it with a drug like bevacizumab or Avastin. So switching gears here to rehabilitation and brain tumors, rehab may have been a large part of many of your treatments or your loved ones' treatments, and brain tumor rehab, you may have learned, is really, a very multidisciplinary specialty. And we tend, when we think about rehab, to think mainly of kind of the big ones like physical therapy, occupational therapy, speech therapy. But really what rehab is to help a patient at any point in his or her treatment course to maximize their functionality and to restore the ability that they had previously. So that takes a really large team of a lot of different specialists. So it includes psychiatry and psychology, dietitians, nutrition, chaplains, social workers, rehab nurses, and a rehab doctor. So that rehab team, particularly if you're in inpatient rehab, is typically led by a physiatrist. And a physiatrist is basically a rehab doctor. So they're a physician specialist in physical medicine and rehab, and they're responsible for a lot of patient functional health. So basically, this is a specialty that emphasizes the prevention, diagnosis, and treatment and restoration of function. So this is not just physical function, but it's function in every way, shape, or form in life. And that could be vocational function, that can be recreational function. So there's a lot of different, it's a holistic approach to rehab. And it addresses the function of the whole patient as opposed to just an organ system or just your speech or just your walking. It's really a holistic functionality. So what can some of these functional issues be? So, we think of things classically like weakness, deconditioning, and mobility, loss of mobility, but it also includes a lot of things like activities of daily living. So that means things like being able to cook for yourself, clean up, make it to the bathroom okay. And cognition, communication, swallowing, these are all kind of go under this speech category of speech therapy. And then there's things that you might not think about regularly, like bowel or bladder dysfunction, or even sexual dysfunction. There's skin integrity and breakdown. So there can be wound care involved here. And really, also another core member of this team is that social support, social worker, psychiatry, and then also vocational and economic concerns, getting you ready to work again maybe, or what work might look like, or basically potentially even addressing a new normal and how that functions for you in your life. So this is really multifaceted. Deconditioning might be a term that many of you guys have heard of, and it's something that we see relatively frequently in some of our brain tumor patients. And it's really a multifactorial phenomenon. So it's not just one cause, a lot of different causes, and it's basically occurs with non-use. So it can result in this functional decline due to changes in multiple body systems. So it's not just your muscles. But what ends up happening is with deconditioning, so with not using, you can lose 5 to 10% of your muscle mass per week, which is a lot. And it can even change your resting heart rate if you're not moving around a lot. So your resting heart rate can increase by 10 to 12, beats a minute by just having inactivity. And just a little bit can go a long way. So even just maybe getting to 50% of your maximal output and strength or cardiac exertion could help prevent this deconditioning. It can cause a lot of, social isolation and depression when you're deconditioned, when your body doesn't feel like it normally did. And it can also lead to decreased pain tolerance. A separate but related issue is cancer-related fatigue. And this is something that we hear a lot amongst our patients. And I'll kind of go through some of the key components of cancer-related fatigue, and also maybe some of the things that we can do to prevent it or to safeguard as much as we can against cancer-related fatigue. One of the key hallmarks of cancer-related fatigue is that no matter how much you rest or sleep, that it really just doesn't relieve that fatigue. And these are some of the key symptoms that we hear. So besides just the weakness and the need to rest, we can see decreased concentration, decreased motivation, sleep issues like insomnia or emotional reactivity, mood swings, and difficulty completing daily tasks attributed to feeling fatigued. Of course, it seems, probably one of the hallmarks, and perceived problems with short-term memory that might just be not your memory not working, but actually your brain just being so fatigued that you're not remembering things properly. And we also hear this sort of limb heaviness, like my arms and legs feel so heavy, I just can't do anything. And there's, again, a lot of contributing factors here. It's not just occur because of one reason. So it can be direct tumor or tumor treatment effects. So that the tumor treatment could be from radiation, could be from chemotherapy, from hormonal inputs. So there's a lot of different reasons as to why our treatments and tumor itself can cause cancer-related fatigue. But there's also the other medicines involved. And I think Dr. Nagpal will also be talking about seizure medications and maybe some of those effects. And you can see that it's not the cancer-directed care always, but sometimes it's the care of the treatments that we do around it that can also contribute to fatigue. And then the sleep difficulties that might arise, maybe changes in nutrition, or really, I think one thing that often gets overlooked is just depression and mood and everything around all of these life changes happening that is just really mentally and physically fatiguing. So what can we do about cancer-related fatigue? So there's a lot of different options here. And I would say one of the top things is just moving our bodies and staying active. So that's a huge part of it. And then there is also cognitive behavioral therapy. There are support groups, counseling, and all of these are often channels that are within the rehab facilities or rehab doctors that can help guide you and also can help open doors for these different therapies. There are different medications that can be helpful. So the first two that I have here, methylphenidate and modafinil, are stimulants. So you can talk to your doctor or your rehab doctor about adding a stimulant on. And it can help you get you into this positive cycle, because a lot of my patients, for example, when we start a stimulant, then they're able to be more physically active. And when they're more physically active, their energy is better. And when their energy is better, they're able to be even more physically active. And it just ends up being sort of this positive cycle that we're looking to achieve with our patients. And similarly, if the underlying cause for the cancer-related fatigue is brain swelling or depression, steroids or antidepressants can also help achieve getting you into that positive cycle of improved energy. And lastly, and kind of most importantly, I would say, is sleep hygiene. You know, it seems quite intuitive, but sometimes, actually, I would say 50% of the time when I'm talking to my patients and we're talking about fatigue, I find out that for some reason or the other, they're not sleeping properly. And you don't need your neuro-oncologist to tell you that if you don't sleep, you're going to be tired, and that's just going to add to your multifactorial fatigue. So this is a really important thing to step back and be honest with yourself on your sleeping, and then also see, you know, how can my doctor help me sleep better? What can we do? And it's not always medications. There's a lot of other behavioral things that can help with your sleeping that then can get you again in that positive cycle. So the exercise molecular effects are big. So I just want to spend one slide on this, because I think it's really important that we tell you that, you know, you might hear a lot from your doctor or your rehab folks, whether it's your physical therapist or whomever it is, to say, you know, if you're tired, get some physical exercise. Well, I want to tell you that there's been multiple studies showing that this actually works, right? The exercise helps fatigue and can actually alter specific pathways of tumor initiation or carcinogenesis, so like tumor formation, and it can exert a cancer preventative effect by increased efficiency. This is like a very sciencey slide, and I apologize for that sort of heaviness here, but I guess maybe I'll just suffice to say, doing physical exercise actually can chemically change things on a cellular level. So it can be really helpful both for cancer-related fatigue as well as directly for your tumor care itself. So it's just my plug for you all who can stay active to stay as active as you possibly can, if it's just a walk a day or whatever it is. So I'll just briefly touch on the different folks. I think for time's sake, I'll just spend a few seconds a slide here. So I think many of you guys are familiar with physical therapists. They often focus on lower extremities more than upper extremities, but really just treating the whole body. These are trained, this takes a lot of training. They're trained professionals, and they can really help you with mobility and function. Occupational therapy is really to help with function and use. So everything from hand therapy to helping with adaptive equipment. We use our occupational therapists to help us with driving evaluations to see if patients are ready for driving. They're also really heavily trained, and their goal is to help you function with whatever deficit you have so that you can do all the things, or as much as you can, of what you were doing prior to the dysfunction. And then speech and language, I think, you know, many of you all know that they can help with your talking itself and swallowing and chewing, but they can also help with different cognitive therapies as well. And these are also, again, heavily trained professionals. And I'll just touch on the last few. I mentioned this earlier, you know, vocational training and counseling is also a really big part of rehabilitation, because getting you back to work again, if that's something that's important to you, is something that's important to your rehab doctor as well. And even recreational therapy to get you to enjoy the things that you enjoyed before. So these are all things that are a part of the rehab program, along with people who help with prosthetics and orthotists. Again, this is not as big of a field in brain tumors, but this is all under the rehab umbrella. So that's actually switching gears in the last 5 minutes here. That's the end of the rehab portion of the talk. And then I'll just spend the last 5 minutes here talking about what I think is the elephant in the room, which is COVID-19 and brain tumors, or the reason why we're all virtual today and not in person. You know, I'll tell you some of the key things that I've told my patients, which is that brain tumors and other brain tumor patients and other cancer patients are at a higher risk for more severe disease. And patients on chemotherapy have an even higher risk. So your doctor's probably doing more telehealth visits, and they might have even had impacted clinical trials. But we're fortunate that I would say most of our clinical trials are still enrolling across the country, and you can ask your doctor about specific ones there. Patients with active cancer, as I mentioned, are at increased risk not only of COVID, but of its complications, and as well as patients who are on active immunosuppression. So that are things like chemotherapy or specific chemotherapy agents. The vaccine therapies and the patients who are enrolled on the vaccine studies were not typically cancer patients. So patients with a weakened immune system and how they respond to the vaccine is not fully known. But all of that being said, I think I skipped a slide here. We still heavily recommend vaccines. So again, this is a really busy slide that I wanted to provide you guys so you know that our NCCN guidelines, which is our comprehensive cancer network, the guidelines are in fact to have cancer patients prioritized in the 1B, 1C category, and that it's recommended that all patients that are receiving active therapy and solid tumor patients, which includes brain tumor patients, that they undergo the vaccine when available, despite that lack of data. So basically what we're saying here, I think when should you get your vaccine? You should get it when it's available to you. And for cancer patients and patients with comorbidities or patients older than 65, you're going to be prioritized. And you want to consider concurrent chemotherapy and a potential lesser immune response, but that shouldn't stop you from getting the vaccine. Because I have a minute, I just want to go over this because I've had a lot of questions from patients on this. So as you guys know, there have been 3 vaccines approved here, and I have them listed in reverse order of their approval. The Johnson & Johnson vaccine is a more traditional, what we call adenovirus vector vaccine. And I'll just speak 1 minute about this Moderna and Pfizer and how they work. So these are mRNA vaccines. So literally what's being injected in are pieces of genetic codes that code when they get into your body for the protein and not the virus itself. So just the protein of that, and it trains your immune system to attack that protein as a foreign body. So because of that, you can get this mRNA vaccine and literally train your immune system to recognize the spike protein or the specific protein on COVID-19 as a foreign body so it can attack it if you're ever faced with that vaccine. So that's what this new technology is. So I'll just end by including on these last couple slides some resources for you. So on this slide here are COVID-19 brain tumor resources, and I think this will be provided to you. And also included is some other caregiver resources and patient resources on the topics we discussed today, particularly around steroid use, rehab, as well as some COVID resources. All right, thank you guys for your time today and for allowing me to participate. I'll turn it over to Dr. Nagpal.
All right. Well, now I have to see if I can get my arrows to work. There we go. All right. Am I in charge of slides here?
We are removing control from Priya right now, and then we're going to give it to you, Seema.
Okay, great. Thank you.
And Emily, when I do that, can I take my video off? There we go. Okay.
There you go.
As I'm controlling the screen, I'm down in the lower left. There we go. Okay.
You got it.
That's me. Here are my disclosures. And so I'm going to start by talking about seizures and epilepsy, and then I'm going to switch over to dietary supplements and cannabis, and then a little bit to close our session out. And I just want to point out that each of these sections, including what Dr. Kumtekar talked about, could take an entire talk by itself. So we understand we are not teaching you everything, okay? So what is a seizure? A seizure is really a brain arrhythmia. It's abnormal and it's synchronized, which means it's happening at the same time, rhythmic activity of brain nerve cells. And it's sort of like a cardiac arrhythmia, which is the same thing, which is synchronized heart muscle contraction, but not in the way that it should be happening. So this picture, the squiggles on the top group in A are sort of normal squiggles that your brain makes, kind of organized. And you can see in B that we're getting to disorganized squiggles. And that is basically a seizure electrographically. So what do we see in a patient? Well, it's a poorly predictable stereotyped, which means it's usually the same activity or the same set of events every time. And it can be altered or diminished consciousness, involuntary movements, or like classical convulsions that you've probably seen in movies. 60 to 70% of patients with a brain tumor at some point may experience a seizure, not all of them the big ones, okay? But the risk of it coming back off medicines, if we don't give you medicines and you have an abnormal brain MRI, which most of our brain tumor patients have, the risk of having another one is as high as 80% if we don't give you medicine, which is why many patients, you've had one, you're gonna get a medicine. Epilepsy is simply a tendency for seizures to happen, and the definition really keeps changing, but in a brain tumor patient, that can be after one seizure. So for patients who have tumor that's actually inside the matter of the brain, that's usually considered epilepsy. If you have an external brain tumor, like a meningioma that's pushing on the brain, you may not get long-term epilepsy from having the brain tumor. All right, let's see if I can, there we go. So what is a focal seizure? So focal seizure is really electrical activity arising from a single spot in your brain. And that can be responsible for motor changes. So sometimes patients will show up with a thumb doing that. Usually all seizures lasting about 10 to 30 seconds. That's it. And then the brain kind of turns them off all by itself. So we can have thumb twitching, we can have a sense that something is rising. It almost feels like reflex, but it's almost the same every time. And even my husband, who is an epileptologist, describes a patient who could remember being at a fair and smelling popcorn and hearing the carousel, but it was the same every single time. It can happen with or without altered consciousness, but usually focal seizures are what our brain tumor patients have. Why is that? Because you have something at a specific spot in your brain. So most of the seizures for brain tumor patients start in a specific spot, but they may turn into what we call a generalized seizure. What is a generalized seizure? It means that that focused spot that we started at is now spreading to the whole brain. And so the entire brain, or both hemispheres of your brain, are now involved in the abnormal electrical activity. Primary generalized seizures mean that they start with both sides. In general, we don't actually see those in patients with brain tumors because brain tumors are a focal problem. Secondarily generalized is what we typically see, which means it started in that one focus and it can be super fast that it goes to both sides, or take a long time, or never go to the other side. The reason that's important is because when you're looking at your loved one or yourself having a stereotyped activity, you might not see what I've got pictured here on the right-hand side. That's the sort of classical movie seizure, which I would say less than 10% of my patients actually have. So it's important to recognize the abnormal motor movements that happen stereotyped the same, last 10 to 30 seconds. That could be a seizure. You might want to talk to your doctor about that. It's also important because we use different medicines for the generalized seizures than we do for the focal with secondary generalization. So there are many, many good medicines to prevent patients from having seizures. And you can see here that over the course of time, we actually have lots and lots and lots of more options for you. I have put in purple boxes the things that are the most likely to be used. So sodium valproic is valproic acid or Depakote. In our field, there is some thought that maybe that is also doing something to the DNA during treatment. that has not panned out in larger studies, but it's still relatively tolerated. Can make people sleepy, and it can cause some weight gain. So for me, that is not my first choice of medicines. Topiramate or Topamax is a medicine that's often used for patients who also have migraine. So if Priya or I are seeing a patient who has a history of migraine, and the tumor and the surgery and the treatment has made that migraine frequency more and worse, and maybe we're a little worried about seizures in there, like thumb twitching, topiramate might actually be a great choice because we do two things at the same time. That medicine is actually associated with weight loss. Not, I think, the only one on here that is. Lamictal or lamotrigine, that's my husband's favorite medicine. And he says if he was going to be on it, a anti-epilepsy drug, that's the one he would pick. So why isn't everyone on that one? Well, it takes about 6 to 8 weeks to get up to a normal adult dose, because we can't give you the whole dose all at once. So that's why we don't use it as often, but it is a great second line drug. It's also a really good drug for any patient who's truly having difficulty with levetiracetam, also known as Keppra. Keppra is probably the brain tumor doctor's favorite drug. It's generally really well tolerated. If we give you a dose within 6 hours, you're actually at a normal adult dose. So that's fantastic. They're all equally effective, which is why we start with that one. And Keppra also doesn't talk to your chemotherapy. So they don't interact very much. That's why we choose that one first. The downside is that for some patients, Keppra can make them irritable. And it's not just a little irritable, it's like a lot irritable, meaning B-type personality, very passive person, suddenly will like get pulled over by a cop for speeding and then punch the cop, right? So it's a big difference. We're not talking about little difference, big difference. For those patients, I think Lamictal is a great option, and so is lacosamide. That's that top one in the purple box. It's also known as Vimpat. And the benefit of Vimpat also is that we could start you on a pretty good dose and you're pretty close to having a therapeutic adult dose very quickly, unlike Lamictal. So again, lots of options. And if these aren't working for you, there are lots of other ones on the list that aren't purple boxed that our epilepsy teams can typically help us make a good decision for you with. So what happens when you're having one? Some patients might actually get an abortive medication, meaning one that stops the seizure. Why do we need to do that? Well, we may need to do that if you have a tendency to have longer seizures, or if you're a patient who has a tendency to have one and then another and another and another. Doesn't happen that often, but it certainly can. These abortive medicines are also a fantastic way to stay out of the emergency room, because for a patient who starts to understand and know how their seizures are happening, you could take one of these medications, which is the same stuff you get in the ER, and kind of write it out at home, and then call your doctor or message their team and say, hey, I had another event. I took this medicine and now I'm better, but what do I do? And the answer might be, hey, we need to increase your anti-seizure medicine, the daily one, or hey, why don't you come in because this is the third in a row. So it is helpful for having patients have a little more control at home. So what changes do seizures make for patients' lives? Well, I always talk about having regular sleep. It's super important. One of the biggest times that neurologists see patients having a first-time seizure is when they go off to college and they pull their first all-nighter. So this is independent of tumors. Lack of sleep can lead to seizure in a brain that has a tendency to do that. So important regular sleep is important for seizures, as well as being energized the next day. Remembering to take medications twice a day. These medicines typically are not once a day drugs. I have a lot of patients who will put an application on their phone or an alarm on their phone to sort of really get used to taking the medicine twice a day. For patients who have had a change in their consciousness when they've had a seizure, we like to ask them to plan to do activities together. So swimming alone without a lifeguard in the pool, probably not a great plan if you might have another event. Hiking alone if you don't have a way to call for someone, also probably not a great idea. And things like scuba diving, et cetera, companies often will not even let you do it. Just depends on how well controlled your seizures are. In certain states, having a seizure that alters consciousness or the right-hand side of your body may affect your ability to drive. That is important to talk to your doctor about, because if you are advised not to drive and that state is a legal reporting state, there may be legal ramifications if you were driving and, you know, God forbid you get hurt yourself or hurt somebody else, but the legal ramifications, if there's an advisory not to drive, can be devastating. So definitely ask your doctor about the rules in your state. Alcohol consumption is a question we get a lot just for brain tumor in general, but specifically to epilepsy. I want to say that the books will tell you you cannot and should not drink. You know, I'm a believer that life goes on and there are things to enjoy in life. If you would like to have a glass of wine, probably okay to have a glass of wine or two, probably not okay to have the whole bottle, okay? What we do know is that it's not really the going up on the alcohol that's a problem, it's the coming down side. So if you've had a lot and you're coming down from that, that's when you have a tendency to seizure. It's also important to know that those abortive medicines I showed you, that intranasal one in the pill, basically like 2 glasses of wine, okay? So you can also, if you have a ton of benzos, that's what those drugs are, and you come off of that, it could also lead to a seizure. So moderation, and there are some unfortunate patients where even a little bit of exposure can cause trouble. Most definitely not. So moderation, please. Okay, so my goal for patients with epilepsy, I would love it if I had no seizures, no drug side effects, but when that's not possible, the answer is balance. Okay, and what do I mean by balance? Well, you know, I might not get rid of every blast thumb twitch, and I'm okay with that as long as you're okay with that. Because if I add 2 or 3 medicines together to get rid of your thumb twitch, you might also not be awake very much. So talking to your doctor about what your goal is and what their goal is and making those align is very important. Hopefully, however, you're in that 70% of patients where the first drug works and you don't get repeat seizures. So that's really good. Okay, so switching to nutrition. I think this is a topic that both Dr. Kumtekar and myself and Dr. Dunbar get asked for almost every patient. What should I do about my eating habits? Well, the answer is there are a lot of opinions, and it's not entirely clear who is correct, but I think you'll start to see a trend in my general answers here. So you can see on the left here, that's actually the old food pyramid that we probably all learned in school. And that food pyramid from the USDA has been changing for the last 20 years. On the right, on the top, you see there's another pyramid where they didn't make it stacked. They made it all next to each other, which is hard to understand. So the most recent iteration is Choose My Plate, which is probably the best depiction we could get, which is heavy on fruits and vegetables and grains, choose your protein, and then dairy has its own little category on the side. And that's a nice balanced plate. I like that plate. So the ketogenic diet is probably the most common diet that I get asked about. Like, should I do keto? Should I do keto? What does a ketogenic diet look like? Okay, this is the keto food pyramid. Increased intake of fat, increased eating of meat and eggs. So this is actually tough to do if you want to be like a keto vegan. I don't know how easy that is. For those of you not in California, you probably never even heard of someone trying to do that, but I do. Reduced breads, pastas, those easily convert into sugars in your body. And dramatic decrease in fruit intake. So to get really, quote, ketotic, you actually might have to not eat any fruit, which to me is very sad. Certain vegetables only, and a very strict ketogenic diet, if you can look on here, is relatively unpalatable to most adults. In fact, the most successful ketogenic diets are done in children who are impaired enough that they have to eat through a feeding tube. So they're very successful at it, but adults, it starts to be not fun, right? If you want ice cream or French fries sometime, they don't fit on the diet. So why do people really feel like this might work? Well, cancer eats sugar or uses sugar at a higher rate than normal tissue does. And what you can see on here is a brain tumor that we're looking at by CT, MRI, and by PET CT. And PET-CT looks at increased glucose or sugar uptakes. And you can see that red spot, that's the tumor. So it is definitely eating more sugar. Cancer converts sugar into building blocks like cell outer membranes, new DNA, proteins, instead of making sort of normal energy that your cells need. So in theory, reducing sugars could theoretically force slower tumor metabolism. And I'm going to be very careful here and say theory, because your brain also eats 1/4 of the sugar in normal metabolism. So without a tumor in there, your brain's already hungry for sugar, and that's how you think and that's how you function, okay? So does it really work? Well, all of the studies for ketogenic diet and brain tumor are quite small right now. There are some that are running, but this one, it has been published. And you can see there's only 8 patients in it. And it's not entirely clear that it changes any outcomes. So you can see the overall survival is kind of all over the place there. And maybe due to a lot of different factors beside the diet. On the far right-hand side, you'll see compliance. It's really difficult. This was actually a pre-made meal diet, meaning patients didn't even have to cook it, didn't have to do anything. They were provided a pre-made meal. And a 3 meant they were capable of fully doing it. And you can see that one patient just couldn't comply because probably didn't like it. And then 2s are, I partially did it. And then another who also didn't quite participate fully. So I think it's hard to say that that is something you should and have to do. Dr. Kumtekar, you probably have a similar issue that many of the patients who go hard on the keto diet actually lose a ton of weight. And we know that during cancer treatment, it's actually not to your benefit to lose weight if you are of normal weight or even underweight. We want you to maintain weight because you're going to have to fight off the chemo. And you're not going to necessarily want to eat quite as much during chemo. So my goals for patients: maintain weight, enjoy what you eat. Let's try and avoid side effects. And yes, the ketogenic diet does cause side effects. The biggest one being lack of enjoyment of having your food. And the second is that some patients get super constipated on it and other patients get super diarrhea on it. Temodar already causes constipation, so we can be increasing an uncomfortable problem. And when that's not possible, then striking a balance. Again, this is a discussion with your doctor, discussion with your nutritionist even, about how far do I go, or should I do a partial? When do I do it? Should I do it during chemo radiation? My answer is usually like, how about not during chemo radiation? How about after? Because you're already going to be tired out and not real excited about eating in your normal way. So another big section or area of questions that we get is about supplementation. Like, what stuff should I take? What other stuff should I take? What is that other stuff? So there are vitamins, minerals, plant and animal extracts, and amino acids that are added to your diet, typically in pill or in oil form. And they're not under FDA regulation for efficacy and safety. And that's probably the biggest reason you're going to see your doctors being like, we don't know, because there's just not a lot of data about what these things do, how well they work, how much harm they can cause, and how they interact with what we're already doing to try and treat your brain tumor. I think my biggest pet peeve too is that they can be super duper expensive. I've had patients paying $2,000, $3,000 a month for big packages of supplements. You know, if we knew it worked and we had good data to be like, yes, this works, 1, we would tell you, 2 would probably be covered by your insurance company. So antioxidants are good, right? So this is a big category of supplements. It's vitamins A, C, E, beta carotene, and selenium, and actually a number of additional ones. So outside of cancer, we tend to think that protecting your cell membranes from these insults on the left-hand side is a good thing. Ultraviolet rays, atmospheric pollution, stresses, and poor diet. What does that do? It takes normal oxygen in your body and it kind of makes it a little crazy. That's what the free radical is. And that free radical can zip around and knock into cell membranes, knock into DNA, and actually cause trouble. So your body has this nice balancing mechanism to grab those normally. And vitamin A, C, E, beta carotene, all that stuff kind of increases the grabbers and makes you a little bit safer. under normal circumstances. However, antioxidants may actually be anti-treatment. Why is that? Because the chemotherapy we're going to give you and the radiation we're going to give you both actually rely on free radicals to kill cancer cells. We want to break cell membranes and we want to break DNA so that the cancer cells die. So that means vitamin A, C, E, beta carotene, selenium could actually all be counteracting the activity of your chemo and radiation. So that's why it's really important to, most radiation oncologists will actually tell you not to take these during radiation, but it's important to, during chemo and radiation, try and minimize the extra stuff you're taking because you really don't want an antioxidant. Can supplements do harm? Well, the answer is we actually now have data about this. So in 2020, the American Society of Clinical Oncology published a paper in breast cancer patients, more than 1,000 of them, patients using vitamin A, C, and E, carotenoids and CoQ10 before their cancer diagnosis at high levels or during their cancer treatment actually had an increased risk of recurrence. So we now have data to show that maybe this is not a good idea during cancer treatment or even right before cancer treatment. Getting your vitamins through your food is probably the safest way to do things. Another supplement, acetyl L-carnitine, increased neuropathy, which is damage to the peripheral nerves in your hands and your feet in patients getting chemotherapy for breast cancer. So it didn't decrease it, actually increased it. And vitamin E in high doses can actually increase the risk of bleeding, which is already a spontaneous risk in brain tumors. So now you can kind of get a sense of why your doctors are not super, super thrilled about big lists of supplements. Because one, we don't have a lot of data to go on, but two, when we do have data to go on, it hasn't been particularly good data. So Dr. Nagpal's goals for patients. I really like it if you eat food and not pills. That's more enjoyable anyway. And please enjoy what you eat. Avoid supplements during radiation and chemo. So if you must do them, please wait till after. And if you must explore them, use good resources so that you have a really good sense of what you're actually taking. These are drugs. Anything that you are taking that is not just a food substance is usually concentrated and can have side effects. Pharmacists know a ton about this. Cancer center nutritionists also do as well. And the NIH actually has an Office of Dietary Supplements with a nice website. And that's going to be included at the end of this slide deck. And when that's not possible, balance, talk to your doctor. It's a negotiation, right? Things that you would really like to do, just making sure those aren't the harmful ones. So the other supplement, this gets used a lot in California and I imagine in more states across the country at this point as well. So medical marijuana contains over 400 compounds. The two that we know the best about are CBD and THC. THC is the compound that is most likely to be psychoactive, meaning when people are talking about being high, that's the one. CBD actually has an FDA approval in epilepsy, and the CBD also is used for anorexia, nausea, anxiety, insomnia, and other tumor side effects in the form of Marinol. But, in California, at least, we just ask patients to go get it and go talk to someone who knows more about it than we do. Why? Because dispensaries are now dispensing cannabis in all different ways. So pills, smokable cannabis, baked goods, skin creams. All of these different delivery formats actually have different speed and different dose, different ratio of CBD to THC. That's why it's really important to talk to someone at a dispensary when you're getting these, if you're going to use them yourself. Many of you may have heard about medical marijuana also having an anti-cancer effect. I think the data out there is limited, but here's a picture of how it might help. Apoptosis is also known as programmed cell death. That's typically the goal of our classical chemotherapy drugs and even radiation. You can see all these fun sciencey pathways where the cannabinoids from medical marijuana have this receptor on a cell membrane that actually can ultimately downstream lead to apoptosis. We don't know which of those 400 plus compounds can do this and how well it does it, but there is some thought that maybe maybe it could be used as an anti-cancer agent in the future. The only tested ratio is 1:1 in glioblastoma, and that study showed that it was safe, but it did not really show anything about efficacy. So more data to come, we hope. If you're going to use THC and CBD, please only use it if you feel comfortable doing that and you feel safe. Remembering that this is not legal in every state, so you can be at legal risk of using this. It can really cause paranoia for patients too. And the best way to figure that out is really, really low dose first. Don't start by getting stoned, okay? And a little bit can go a really long way. In fact, the low, very small doses tend to be the best ones for anxiety and nausea. So now for something very different. So the big why. I think the things that as physicians we don't get to talk enough about in clinic visits because we're trying to get through all the stuff up above, your seizures and supplements and all that stuff, is why did this happen? How did this happen? So the only definitive risk for developing brain tumor is prior radiation. So the big radiation, that's what ionizing is, from medical devices. Sometimes tumor syndromes, or if you were unfortunate enough to be like literally in Chernobyl. No evidence that cell phones increase risk of brain tumors. A big European study that showed it does not. There are no environmental exposures other than big radiation exposures that definitively are linked to brain tumors. And CMV may or may not be associated, but it's probably not causative. So why is that important? I want to take a minute here to say something that maybe your doctors haven't, maybe your priest hasn't. There is nothing you did or did not do to get a brain tumor. There is nothing you did or did not eat to get a brain tumor. There is no supplement you did or did not take that gave you a brain tumor. And there is no exercise you did or did not do in order to get a brain tumor. There is no blame and there is no shame. Getting a brain tumor is bad luck. Okay, and I know that many of us grew up in cultures, Catholicism, being Hindu, whatever, we're really, really good at guilt. We're really good at looking for that why. But I want to reassure you from all of your physicians here today, there's nothing you did or did not do to get this. And we're just here to help. I think because of this, it really matters how we talk about it. I want to say it is okay and normal for you to be scared right now, to be really mad, and to feel betrayed. It is okay to feel alone, but I hope you know just from looking at the number of participants that you are not. It is okay to ask for help from your family and your friends and your coworkers, because wouldn't you be sad if they did not ask you for help? I think you would be. And it's something that both Dr. Kumtekar and I really, really dislike about how the press talks about brain tumors is that this is not a battle, it is not a war, this is not a fight, this is a journey. People who die from cancer did not fight hard enough, they didn't surrender, they had bad disease. No blame. So what do we do from here? Well, I encourage you and all of my patients, if you're a regular church, synagogue, or other house of worship goer, you know what? This is the time to reach out. Most integrated cancer centers will also have support groups. The ABTA has support groups. Individual and family counseling can also be really important. And I often tell folks when they're like, well, now I don't really know what to do. Work is not my priority anymore. I get it, man. This changes the perspective, right? But you are important. You are still a valuable member of our community and society. And volunteering if and when you feel able for causes that you believe in is still really important. And that gives value. I also think that can flip this brain tumor diagnosis on its head. And it sometimes is an opportunity to say, I'm sorry, I was wrong, I miss you, come back into my life, thank you, and I love you. Okay, that is actually what brings joy to my day, taking care of all patients like you, because I get to witness those things. I get to witness that I'm sorry, thank you, I love you, I miss you. That's the best part of my job. And so here are some resources for patients and families, and I think you're going to get copies of this. Nick Batowski gave a wonderful talk on cannabis and brain tumors. That's an hour long. And that is all I have too.
Thank you so much, both of you, for sharing your expertise and insight. We'll have some time for questions. Just as a reminder for our attendees, if you have questions that you'd like to ask, please type and submit it using the question box using the control panel on the bottom of your screen, and we'll answer questions as time allows. All right, so one of the first questions we have here is going back to the conversation on steroids and how they can sometimes cause mood effects like anger, irritability. Do you have any advice on how patients who are coping with side effects like these, how they can better manage these effects?
Yeah, absolutely. And I apologize because I typed these responses as well, but I think the number one thing that I would try to do is try to see if we can decrease or get you off of the steroids. So like I mentioned before, the goal isn't to have steroids on long-term, for years, because we see a lot of issues with that. So first and foremost could be to either get you off completely or to decrease the dose, because we do note that a lot of the steroid side effects are dose dependent. So even coming down on the dose can be helpful. Now, if you're in a situation where you cannot get off the steroids, there are different medications that can be helpful to help balance some of those moods and feelings that you're experiencing because of the steroids. So you can discuss potentially adding those on with your doctor.
Thank you so much. Another question we have here is on the topic of diets. How effective are anti-inflammatory diets on coping with side effects and symptoms? Reducing the intake of certain foods that might cause inflammation, is that helpful? Is it effective?
So I think I'll take this one. My experience with truly limiting diets in an extreme fashion is that is not helpful because people don't feel better. However, if you as a person have experience with eliminating a few foods that you feel like your body just doesn't respond well to, that's totally fine, okay? So for some patients, they really feel like when they eat bread, they're like, that for me makes my joints swell up and it doesn't feel good. Well, then it's okay to limit your bread. I'm fine with that.
Thank you so much. I think you said it really well when you talked about just taking things in moderation. Another question we have is about what seizures can look like. So can finger cramping, toe cramping, can that be a type of focal seizure, or is that due to neuropathy? And if it is due to neuropathy, do you have any tips on how to manage that side effect?
So focal toe cramping and finger cramping, if it is on one side, possibly. It's more likely to be related to neuropathy if it is both hands and both feet. And that's because of anatomy. So when we think about where a brain tumor is, it's usually on one side of the brain that's controlling the other side, right? And so it might actually be in your hand knob anatomically. And if that's the case, then yes, a cramping right in your hand knob might be a focal seizure. However, if it is both sides, that is highly unlikely to be a seizure. Why is that? Because what we talked about before is if a seizure goes from one side to the other, that's when it becomes the big one. That's when it makes you lose consciousness. So then it is more likely to be related to neuropathy. Now, most of the drugs we use for primary brain tumors do not cause neuropathy. So you want to talk to your doctor about why you're having those symptoms, because it could be something totally different. There's lots of causes for neuropathy. If you are using a drug that causes neuropathy, you can talk to your doctor about getting that as a side effect. Many times patients will feel better if they're keeping their hands and toes warm, and if you're drinking enough water. And doing gentle stretches before bedtime is usually the other way to prevent the cramping.
Thank you so much for that advice. Another question we have is regarding sleep. I think both of you touched on the importance of getting enough sleep, but for a brain tumor patient, sometimes that can be really difficult because of all the stress that you're having. You're a lot of fears, a lot of anxiety. Do you have any advice on how patients can better cope some of these mental health issues so that they can ensure that they're taking care of their own well-being and getting the sleep that they need?
Yeah, absolutely. I think, Seema, I'm happy to take that first. And I know it kind of is, so it took me a second because it's so complementary, I think, to both of our conversations. Yeah, so I think that the idea of sleep is complex, right? And so I would say if there's an emotional piece of it, trying to target that underlying emotion, how to, whether it be maybe meditate before going to sleep, whether it be more sleep hygiene. So that's things like not looking at bright screens before sleeping, sleeping at the same time and waking up around the same time, limiting your caffeine intake, all these things. And if you Google sleep hygiene, you'll see these kind of popped up bullet pointed. So I think that there's the sleep hygiene part of it to help with like the true insomnia. But then from an emotional standpoint, you're right, having those anxieties does limit all of us from getting rest. So I think the best way is to learn not how to ignore those anxieties, but just how to digest them so that you can sleep. And for some, that's meditation. For some, that's talking to other people. And not everybody's solution is going to look identical. So just talking through what those different solutions could be, either with your provider or your family, there are a lot of resources for that.
And Dr. Nagpal, did you want to add anything on that?
So I actually really agree with Priya, but the other piece of sleep is remembering that as adults, we forget what works for our babies. Many of you are parents. What do we do with our babies? We give them a warm bath. We sometimes give them warm milk. We rock them. We put them in a quiet place. They don't have devices. They don't have a TV in their bedroom. And we give them a routine, right? And they go to bed at the same time. So aside from melatonin, medications, and all the other good things that Dr. Kumtekar just talked about, really thinking about how emotions affect sleep, just do the stuff you would do for your baby. And that's often the first step.
That is such great advice that I need to take myself as well. Another question we have is about benign brain tumors. So a lot of what we talked about today had to do with malignant brain tumors. Is the advice that you shared regarding symptom management in terms of diet and exercise, is all of that still applicable to someone who has a benign brain tumor as well? For example, this attendee is specifically asking about sugar intake. Does sugar impact benign brain tumors the same way it impacts a cancerous tumor?
Priya, do you want me to take that one? Okay. So I think the important thing to know is that a meningioma generally is not considered malignant, meaning can spread to other parts of the body or could spread to other parts of the central nervous system. So that's the first important thing to know. Meningiomas may actually take up extra sugar on PET scan because they're growing, right? And remember that your brain takes up 25% or 1/4 of the amount of sugar in your body. So I think that sugar is a part of all of us. And in general, as Americans, we overeat refined sugars to begin with. So I don't think I would worry about sugars other than if we can decrease our processed food and decrease our refined sugars. That's probably going to be better for all of us, including patients with meningiomas, including patients with gliomas. Biggest culprits are typically soda, which is sweetened with refined sugars. And then for those of us who love coffee drinks, that's like the adult version of the soda problem. So trying to reduce those is probably a good idea.
Thank you so much for that insight. Another question we have is about, the use of vitamins in coping with results of seizure medications like Keppra. So this individual specifically asking about vitamin B6 and if that is effective, or if you have any advice and insight on other tips on how to manage that kind of a side effect.
So I'll take that one too. So B6 is often actually used in children, not as often in adults for some of the mood issues. Vitamin B6 is a very interesting vitamin in that it's one of the few where if you take too much, and it's very easy to take too much, you can actually cause a problem. So you certainly want to ask your brain tumor doctor before you add it in, because most of our vitamin B6 levels are actually quite normal. And if you eat even a 25 milligram pill, you can actually end up in the too high zone and give yourself neuropathy within 3 months. So doing that under a carefully regimented program where you're actually getting your blood drawn would be quite important. My experience in adults is that vitamin B6 has not been as helpful with Keppra-related mood. And I often will then ask patients if they're ready to switch to another medication. Dr. Kumtekar, how about you? What's your experience?
No, I fully agree with that. I think that it's again, going back to Dr. Nagpal's approach of that balanced, holistic approach. And there's often not going to be a perfect solve with a vitamin. And there might be, what we might need to do sometimes in these complicated scenarios is even involve an epileptologist who can help balance the medications. And, you know, it's not a one size fit all for all the medications as well as for all the side effects.
Thank you so much. Another question we have is regarding exercise. I think Dr. Kumtekar, you talked about the importance of exercise and staying active. Some patients may be struggling and finding ways to stay active now during the COVID-19 pandemic. Can you share any advice on how we can still stay active while we're ensuring that we're taking care of ourselves if we're immunocompromised?
Absolutely. I'm so glad that you asked this question because I think it's a really important one. And I think, you know, brain tumor or not, the whole world's sort of struggling with how to balance this because we all know the importance of activity to our health. So fortunately, we live in a very cyber world. And I think we can very much take advantage of this from an exercise standpoint also. And you don't necessarily need to have, you know, a treadmill or a Peloton at home to be able to exercise. There are a lot of really simple, even walking classes that you can take at home. In fact, I, through the pandemic, showed my parents some of these that you can do really mild and easy classes at home, from basics of yoga to a really vigorous high intensity interval training class and everything in between. And so I would encourage you all to help to find these things online, and there are various apps as well. So you can do, if you were locked in your home for a year, as many of us have been, there are plenty of resources to take advantage of, and it requires a screen.
Thank you so much. And I think that looks like all the questions that we have for this session. I want to thank you both again for your time, and I will go ahead and turn it back to Emily.
Thank you so much, Dr. Priya and Dr. Seema. We truly appreciate you taking on this very large session and breaking it down so attendees can understand. You two are truly a dynamic duo, so thank you so much for your collaboration and sharing with the whole brain tumor community today. And thank you to all of you who asked those wonderful questions. I hope each of you learned something. And again, everything shared in the slides today will be shared after the event, so each of you can have the resources to refer back to. All right, I'm going to hand it over to our chair, Dr. Erin Dunbar, who is going to introduce our next session and our next speakers.
Hi, everybody. Thank you. I agree. They were a dynamic duo. And we now have another dynamic duo coming up. I'm really privileged to introduce two fantastic speakers. The first is Megan Whetstone. She's representing the Southwest in Houston at MD Anderson, Texas. She's a master's trained social worker, and she is an essential piece of the multidisciplinary care of patients and caregivers. She is a new time expert panelist to the ABTA, and we all wish her a warm welcome and thank you. We're also welcoming back a veteran presenter. Craig Presley is a master social work out of Beth Israel Deaconess Medical Center in Boston, representing the Northeast. And He has given us fantastic presentations that are on the ABTA website. And he has a truly special skill at garnering resources for patients and caregivers and providers who are caring for patients with brain tumors and directing them to the people as they need it at the perfect time. So I'll turn over the con to our presenters. Megan?
Thank you so much for that introduction. So today I will be talking about finding emotional support resources after a new diagnosis. And I did want to take the time to thank you all for joining me today, and also for the American Brain Tumor Association for putting on this wonderful conference. So as Erin explained, my name is Megan. I am one of the social work counselors at MD Anderson in the Brain and Spine Center. I am a master social worker with my LCSW. Okay, so here are my disclosures and support. And I did also want to mention that everything that I talk about today, all of the links, the web addresses and everything will be on the resource document that will be made available later. So everything should be easily accessible for everyone that's tuning in. So you've received a new diagnosis. Where do I turn? What's next? How do I find support, and what support is even out there? So you're gonna hear me say a lot. It's really important to talk with your medical team, to have discussions with your medical team about kind of what's going on and where you're at, and what you feel like you need. There may be resources available at your treatment center, and they might be able to direct you to resources close to home in your community as well. Also, if you're comfortable talking about it with your support system, with your loved ones, kind of about what you're thinking, what you're going through, that can be beneficial as well. And then, of course, there are several national organizations that have different resources available to help provide that emotional support as well. So some of the different types of social support. There is in-person support, although that is a little bit limited right now due to COVID-19. There's also virtual support available and different community events as well. So in-person support can take the form of counseling. It could also look like in-person support groups, virtual support. Now with COVID-19, a lot of counselors have broadened their virtual capabilities, so they're also offering counseling in the virtual environment. A lot of support groups have moved towards the virtual environment right now as well. There are also different type of support networks and support communities that we'll kind of dive in a little bit more in depth later on. And there are several peer mentorship programs as well, which again, we'll discuss later on. Another type of social support is community events. So things like this wonderful new patient conference hosted by the American Brain Tumor Association. There are other types of conferences that go on throughout the year for patients and caregivers. And then there are also patient-centered community events. So I know ABTA hosts the annual 5K, Head for the Cure. So that's one example of an event that allows patients and families and loved ones to kind of come together and help provide some of that support. Patient and caregiver support. So a lot of times the needs or the experiences of the patient can vary from the needs and the experiences of the caregiver. So these different types of support can be offered to both individually. There are also a lot of support groups, support communities that can be offered to patients and caregivers together as well. So it's really kind of what you or your loved one feels like would be the best fit for you at the time. Okay, so different types of support groups. A lot of times when I first bring up support groups to my patients, they immediately get a little bit closed off to them. They don't want, in their words, to sit in a circle and sing Kumbaya and talk about their feelings, which is okay. Not everybody likes that. If you don't, that's fine. If you do, that's fine too. But support groups come in many different shapes and sizes. So to distinguish, to start off, there are professionally facilitated support groups, and then there are peer facilitated support groups. So when I say professionally facilitated, what I mean is these are groups that are facilitated by some type of mental health counselor. That could be a social worker, a psychologist, a psychiatrist, or any licensed mental health professional. These typically can take three forms. So one is curriculum-based. Usually these types of groups you have to sign up for in advance. I am so sorry. Clearly I have a dog. So these ones are curriculum based. They're usually closed group, meaning that you have to sign up for them in advance. And they usually run for a certain amount of time. So these groups are very scheduled, have a specific agenda that they go off of, and it's all based on evidence-based curriculum. Another type of support group is topic focused. So these types of support groups can be like psychoeducational. So there's a different topic that is planned to be discussed at each group. And sometimes this could involve an expert speaker to come in and discuss on that topic, like physicians or nurse practitioners or social workers, things like that. And then at the end of the group, there's time for people to kind of discuss challenges that they may have faced pertaining to that topic, as well as different strategies that they've used that they found helpful. And there's a chance to connect through that as well. And then the last kind of type of support group is open forum. So these types of groups, they don't really have a whole lot of structure or anything to them. And what's discussed in them is based off of what the needs of the patients and the caregivers are in that moment. So what they truly want to talk about. Peer facilitated support groups are pretty much exactly what they sound like. These are groups that are often ran by patients or caregivers who want to take this on to provide this safe community for patients and family members. These typically also run on an open forum, so whatever it is that the patients and the caregivers want to discuss, that's kind of what is discussed throughout the group. So how do you find a support group? As mentioned earlier, a lot of institutions do have support groups, so I would definitely check with your medical team or your social work counselor to see what's offered at your treatment center. But then there are also two really great support group locators through the American Brain Tumor Association and the American Cancer Society as well. And you can go in and put in your zip code so you can find one that's local to you. Okay. So another form of support is online support, support communities. So there are a lot of different organizations, as you can see, that have these different support communities available. The American Brain Tumor Association has connections, the American Cancer Society, Cancer Support Community, and Cancer Care. They all have these support communities available as well. These types of communities really allow patients and caregivers an opportunity to connect with other individuals facing any type of cancer diagnosis, or more specifically, a brain tumor diagnosis as well. Many of these online communities have members not only nationally, but internationally as well. So it can be a great opportunity to kind of connect with patients and caregivers all across the world. So sometimes these large support communities or even support groups in general can be a bit intimidating and a bit overwhelming for some people, and they might prefer more one-on-one support. So that's kind of where the peer-to-peer support or the peer mentorship could be a better fit for some people. So as always, discuss with your social worker or your medical team to see what's available at your institution. I know some care centers have peer-to-peer support programs within their system, so that's wonderful. And then there are also several national organizations as well. Immerman Angels, Friend for Life, Fourth Angel, and the American Brain Tumor Association actually has one as well, and that one is Community Connect. So if you're looking for more one-to-one connection, this is a great resource to look into. Typically, they make matches either based on diagnosis or based on other demographic factors. So it can be a really great tool to use, especially if you prefer that more intimate setting versus a support group or a large support community. Okay, so many of you listening are probably thinking, you know, I have all the support that I need. I have a really large support system with family and friends, and that's fantastic. These are just some tools that might make it a little bit easier to connect with that large support system. I know sometimes when I speak with patients, they say, you know, I love that I have such a strong, large support system, but it can be exhausting and overwhelming trying to kind of update each one and make sure that everybody knows what's going on. Or if I do need something, it can be exhausting reaching out to each person individually to see if anybody can help. So some of these programs can really facilitate that communication with your support system. Typically, the way these work is you design a profile, and then in order for your loved ones to have access to it, they have to have a password. So your information is protected. But it's just a way to really share the information about kind of what's going on, or if you do need assistance with something, kind of putting it out there. So that way people can check it as they're able, so they can stay updated, and it just takes some of the pressure off of you. Another great resource for support is individual counseling. Navigating a new diagnosis is difficult, and sometimes it's difficult to process that. That's when kind of speaking to a licensed counselor could be beneficial. I know with a lot of my patients, what they've told me is talking with their support system is great, but sometimes they don't feel like they can truly open up as much as they would like to their support system for a variety of reasons. So talking with kind of a third-party counselor can be beneficial in the process if it's something you're open to. If it is, talking with your medical team to see what resources are offered at your care center is a great place to start. You could have a variety of resources like social work counselors, psychologists, psychiatrists, other types of mental health providers at your fingertips that way. You can also speak with your insurance company to see if there are any providers that are within your network. That's a good place to start. And then You can also research and look up licensed clinicians through psychologytoday.com. And one thing that I do mention with all of my patients is sometimes finding a counselor that works well with you, that's a good fit for you, can be difficult, and it can be challenging. So if you try one and it's truly not a good fit, that's okay, and that is rather common. I would urge you not to give up hope on that. And that's where Psychology Today can come in handy as well, because you can read their biographies and get a little bit more information about them and how they practice to make sure that they're a good fit for you. Neuropsychiatry can also be a great resource. So neuropsychiatry is a discipline that really focuses on how the brain and the nervous system can impact behaviors and cognition. And with a brain tumor diagnosis, it can sometimes be helpful to see a neuropsychiatrist, especially to understand how your tumor is affecting or could affect different behaviors and levels of cognition. With this, it is really important that you talk with your medical team about it. One, to make sure that it is appropriate for you and your care, and also so that way they can recommend you to somebody. Some institutions have neuropsychiatrists on staff, others don't. So really talking with your medical team to kind of help navigating that, and navigating what an appropriate option would be. Talking to children and teens. How do I talk to my children is probably one of the most common questions I get. They are difficult conversations to have. You never know what your child might say. So kind of helping navigate that, of course, is very important. Talk with your social workers at your care center. They might be able to help navigate those conversations, or they might be able to help direct you to resources that are available close by. There are also several online support options and resources as well, and we'll kind of go over those right now too. So all of these resources and the web addresses for all of them will be on that resource document that's available later. But Cancer Care, American Cancer Society, National Cancer Institute, the Feather Foundation, American Brain Tumor Association, Cancer Support Community, all of these organizations have so many wonderful resources and articles on how to talk with kids, especially at different age ranges, because different age ranges understand different levels of communication, common questions that might come up when you're talking with kids. American Cancer Society has a great book recommendation list as well. There's a ton of resources on these websites, and I've added specific links to some of them on the resource document as well to make it a little bit easier to find later on. But some other great organizations, Worries and Wonders, it's actually a Texas-based organization, but they do have a lot of online resources as well, and they have a podcast too for parents who have a cancer diagnosis, and that's a wonderful resource as well. Camp Kesem is also a great resource. So they offer summer camps to children whose parents have a cancer diagnosis. So it can be a really great resource for the kids to connect with other children and also have a great time at summer camp. On their website, they do have a camp locator, so you can find which camp is closest to you. Typically, it's at a local college or university, but that can be a great resource as well. Family planning and fertility. So if this is something that pertains to you, I would encourage you to discuss it with your medical team, kind of what your wishes are, what you're looking for, what you would like to do. They can direct you to any resources within your institution, whether that be specialists or support resources, things like that. There are also some national resources as well. Live Strong, the SAM Fund, the Oncofertility Consortium, and the Alliance for Fertility Preservation. These national resources kind of vary in the types of support that they're able to provide. Some of them can provide financial assistance for the costs associated with family planning. Others provide a lot of helpful information on having that conversation with your medical team, and having that conversation with your loved ones as well to kind of help navigate what it is you would like to do. So I would encourage you to check out those resources if you're interested. Some of them do have support resources as well. So they're really great options if that's something that pertains to you. Okay. So here is my disclaimer. And then I believe it is now Craig's turn. So I will turn it over to Mr. Craig Presley.
Hi, I'm Craig Presley. I'm a social worker at Beth Israel Deaconess Medical Center. And I had the privilege of working with individuals and families that had been impacted by brain tumors prior to moving to Boston for a number of years. And it has been such a privilege to be involved with the ABTA. And it's certainly a privilege to talk with you today about something as important and crucial, and certainly a source of distress as your financial wellness and all things that can be impacted, you know, that have a significant impact on you as a person living with a newly diagnosed brain tumor. So hopefully this is a helpful conversation, and anything I don't cover, please, you know, ask questions, and it's a lot of information to review, but I want to make sure this is a helpful time for you. So ask away, any questions you have, please. Okay, let's see here. Here we go. Oh, I have some disclosures. All of that is true. I don't have any stocks or employment with anyone or anyone associated, you know, with anything. So all of those things are true. So just review that if you don't mind. And why is this important? So I think about individuals' financial wellness and their stability when it comes to going through a major health crisis, whether it's living with a newly diagnosed brain tumor or it's living with any kind of chronic health issue. Your financial wellness and stability is a significant factor in your wellness as a person, as a whole person. And I am a big advocate for really challenging the doctors that I work with and engaging with my patients and understanding that aspects of your health insurance and financial wellness are a part of your health. And I really feel strongly that they should be treated like they're a part of your health. So distress or concerns or worries that come along with your ability to afford medications or your co-payments for your doctor's visits or your deductibles or out-of-pocket maximums, all these crazy words that come with your health insurance and the financial aspects of your care, it's an important aspect of your wellness in general. And so to make that point, I'm showing something that maybe some of you saw in college or read about, you know, when you were learning a little bit about psychology, about this guy named Maslow, and he has this hierarchy of needs. And you'll notice at the very bottom of Maslow's hierarchy of needs here, it's a triangle. It talks about physiological needs and your needs for safety at the very bottom of this triangle. And I think this is the image that I want, you know, all the doctors that I have the privilege of talking with and all of the patients that I spend time talking with to understand that when you're in a place of financial distress, your needs around your safety as a person are being impacted, right? Your worries about how you're going to buy enough food to eat if your condition has caused you to stop working. These are things that cause significant distress and can lead and exacerbate symptoms of things like depression or anxiety, and also lead to potential barriers in your care. So these are essential aspects of your wellness. And you're going to hear me say repeatedly in this conversation today how important it is to talk about that with your medical team and the folks that make up this multidisciplinary team that you're probably a part of, wherever you're getting great care. I'm trying to move there we go. Oh, I am just all over the place. Look at me. There we go. So there's a concept that has been coined a number of years ago, and it's this idea of financial toxicity when it comes to medical treatment. And it's actually become such an important concept in cancer care and brain tumor care and in any kind of engagement around chronic health issues that there are now some recommendations made in how cancer centers and other organizations that are involved in caring for people that have been affected by brain tumors should engage this. So this idea of financial toxicity, what it means is, in medicine, it's a term to describe the problems that a patient has related to the cost of their medical care. Not having health insurance or having a lot of costs for medical care not covered by health insurance can cause real financial problems and may lead to debt or bankruptcy. Financial toxicity can affect a person's quality of life and access to medical care. And it's for this reason we should be treating this. And unfortunately, there's an unfortunate correlation between financial toxicity that someone is experiencing, so a problem with like your health insurance or buying a medication, for example, and the symptoms associated with major psychological distress, things like major depression or anxiety-related disorders that are very common when someone's facing a new diagnosis with a brain tumor or serious chronic health issue. Again, just another reason why we should be talking about this with the medical team that you're involved with. So there are I am not able to control here we go. There are 4 significant themes that are going to outline my talk today around this issue of financial toxicity. Number 1, distress related to the cost of just your medical care. So this is everything you could imagine, that comes into you accessing the care that you deserve to receive, right? So these are things like your insurance premiums that you pay. These are your co-payments for your doctor's visits. These are costs of medications, transportation costs. If you're getting treatment in a place like Boston, where I work, the cost of parking is a significant concern. So all the challenges and costs associated with your medical care, theme number 1. Theme number 2, ability to afford your prescribed medications and treatments. Medication is often not covered the way other aspects of your medical insurance provides coverage for, your visits to your doctor's office, for example. So the costs around medication can sometimes be very scary and be a significant source of distress. Indirect consequences associated with your ability to work or provide for your family. Number 3, the impact of your financial wellness and your health care isn't just about buying your medications and going to see your doctors, right? It's also the real cost of life, the real costs around your ability to work. And that leads into theme number 4, the cost burden in non-treatment areas of life, including things like transportation costs, food, and other kinds of supplements that you need. One study that I was reviewing when it came to this topic showed that when people are diagnosed with cancer, the themes of distress with not knowing where to get help were significant. So that's a 5th theme. Where do I get help? Where do I get support around these kinds of issues? And in a study that I was referencing, so there were 34 conversations that were had in this one particular study, and it showed that when oncologists in this study were doing their clinical evaluations with their patients, 47.1% of those conversations sometimes involve themes around financial distress. 41.2% of those conversations, the patients felt like those concerns were acknowledged by their doctors. 11.8% of those conversations, patients who left those clinical visits where these themes were discussed, didn't feel like they were discussed at all. Why am I telling you this and referencing this very unfortunate study here? I'm referencing it because it's important for you as a patient to talk about this, to bring this issue up. And when you feel like you're not getting help around it, it's important that you let your doctor know that, you let your multidisciplinary team know that, and you ask for help. You ask to find out who are the individuals involved in my care that I can talk to about this. And I also say this, I also post this study to say that if you are experiencing this and you are feeling like you don't know where to go, you're not alone. You're absolutely not alone. Your doctors are brilliant and compassionate and caring, and the speed of care sometimes is so fast that sometimes these kinds of conversations, there's not a lot of space to have them. So what I would like to ask you to do following today's conversation, if you're not already kind of talking about this aspect of your wellness with your medical team, to do it, to prioritize it. Before you go in to talk to your doctors, on a scratch piece of paper where you write your questions before you see your doctor, write down those aspects of your distress that are causing you problems and acknowledge those to your doctors and try to make that a focus or an area for intervention from your team. If your doctor can't do it, your doctor certainly has members of the team that can help you, probably a social worker or another member of the financial team associated with your clinic. So theme number one, when you the distress around related to the cost of medical care, number one thing that I would tell people about this topic is get good information. I have met so many patients over my career that one conversation in correcting some bad information that they were given or that they assumed was accurate about how their insurance works, for example. My patients who have Medicare are often overwhelmed by how complex that is. And there's a lot of assumptions sometimes made about how certain things are covered with various types of insurance. And sometimes just getting that correct information can literally move a mountain of distress and concern by just getting that right information. So don't assume that you understand how your insurance works. Don't assume if you have Medicare or a Medicaid program that you know how it works. Get help on your team to know how that works, okay? It's vitally important that bad information be removed and the best information is available to you so you know how to get the information and help that you need. I would also say be proactive. Even if you don't think that you have a financial barrier in your care and your insurance is paying for everything correctly, I think the world has changed. You know, since COVID-19 has become a new challenge for us, job stability and these kinds of themes have certainly had a major impact on my patients' lives for sure. And I would say that, you know, even if you feel like you don't have any concerns around these issues, and I hope that's a lot of you, right? Going through medical treatment is enough outside of all this financial stuff. Be proactive. You know, don't wait until you have a problem. I would say that kind of framing your financial wellness, your insurance should be something that every year when your insurance changes, and it probably does every single year when your employer group health plan benefits change, or you have to pick a new Medicare Part D plan if you're a Medicare patient, or if you're a person who's got a Medicaid benefit in the states that you live in, these programs can change very fast. And knowing where to get support, even if you think everything's okay, is essential. So if when you started your treatment in the center where you are, if you've got business cards for who's the person that helps process insurance, who's the social worker that I can talk to if there's a problem with knowing where to get help with a pharmaceutical assistance program to buy medications more effectively, or who's a person I can talk to if my insurance somehow lapses or there's a major crisis with something along the lines of insurance. Who is it you can talk to? Be proactive, get that information now, and know where to access these people as a part of your care. I am certain that your program probably has really wonderfully, highly qualified people there to help you with these things. Some questions that might help you that I have here on the bottom of the slide is, how do you find these folks if you don't know who they are? Because sometimes when you walk into a big hospital setting or a cancer center, It's huge. There's so many people buzzing around. It can sometimes be hard to figure this out. So some quick questions that you could ask maybe your doctor or your social worker to find out where to get this support. So one quick question might be, who's a person on the team that can help me explain how my insurance works, right? You may think you understand it, and you may understand it, but go ahead and figure out who that person is and just ask, right? If I experience a change in my insurance during my care, who's the person I can speak to get help with that, right? So again, proactively doing that and get that person's name, their phone number, maybe their email address, or know how to reach them. If I'm having trouble affording one of my medications, and so many of these medications can be so very expensive, who's a person I can talk to help me look into what's called a pharmaceutical assistance program? And you're probably a person that now that a brain tumor is a part of your life, you may be taking a number of medications. And some of them may vary in cost. You may have been taking a lot of medications prior to your diagnosis with brain tumor, since a brain tumor can happen at any point in your life, right? So there are really, really great resources, especially if you're taking a medication that's only a brand name drug. There are many, many, many pharmaceutical assistance programs. So the people who manufacture the drugs that you're taking likely have a program that can help you access these medications at a significantly reduced cost or even free potentially. But to do that, you need to know who's that individual on my team that I can talk to about that, who's the people on the team that can help me fill out these crazy applications that I might find, and what do I need my doctor to do to complete this process. So finding out who that individual, this is just a third question you can ask. Who would that person be? It'll be very, very helpful if you know it in advance. It'll make that process be much easier. And if you do take a high cost medication and and maybe right now it's not a distress, go ahead and find out if there's a pharmaceutical assistance program out there. And a great resource, and I'm not promoting anything for the ABTA here when I say this, I'm just speaking from my own experience as a social worker, is a resource called needymeds.com. It is a wonderful resource. It's a clearinghouse of pharmaceutical assistance programs. I've been using it for probably 20 years to help find medications, medication assistance programs. And on that website, you can put in your brand name medication and you can find out if there's a pharmaceutical assistance program. And often you'll find that there are numerous programs to help with these medication costs. Take that application that you can get from that website, take it to your social worker at your doctor's office, take it to your doctor and show it to them and say, hey, how do I get this thing filled out? Can you help me with this? Because I found out there's a pharmaceutical assistance program that might make XYZ medication more affordable or even free. So just be proactive about that. So look over your medications. And if you think, wow, this one cost me $50, $60, $70, $80 a month to buy, if there's a pharmaceutical assistance program that can put that money back in your pocket, that'll help you pay for parking. That'll help you put more gas in your tank. That'll help you pay for something that maybe your child needs for that after school thing. Anything you can do is helpful, okay? Okay, health insurance is, well, I just passed that up. Let me go back here. Health insurance is crazy. There are so many terms that come with health insurance that are just overwhelming that, unless you work in the health insurance industry, they just don't make any sense, right? So below on this link, below on this slide, you're going to see a glossary of health insurance terms from a really reliable resource through healthcare.gov. And if there are aspects of your health insurance that you don't understand, make sure that you get familiar with these terms. It'll just help you navigate your healthcare. The major terms that I would just tell you to get familiar with are a few, and I'll just throw those out at you. One, deductible. Deductible is the amount of money that often a patient has to be billed for medical care when at the beginning of their annual plan year for their medications, or I'm sorry, for their health insurance coverage. There are deductibles for Medicare, there are deductibles for private health insurance policies, and deductible is a very, very common theme. And often at the beginning of your plan year, your deductible can contribute to higher costs in, say, medications initially. And after that deductible is met, it's going to be different for everyone's health insurance. Your costs will become a little bit cheaper. Another term that I would tell you to get familiar with is one called out-of-pocket maximum. So those of you who have a group health insurance policy or a employer-based health insurance is another word for that. Out-of-pocket maximum is the most amount of money that you're going to pay for your care for that year. So it could be substantial. It could be $5,000, $6,000, $7,000, $10,000, depending on the policy that you have. But that's just another regular term that you're going to hear. Another term that I would encourage you to get to know about your health insurance is the word formulary. Formulary is the fancy insurance term for these are the medications that your insurance considers the preferred medications. A non-formulary drug or a non-preferred drug often can be much more expensive. But what you can do with the support of your doctor is partner with them, have them reach out to your insurance company, or you call your insurance company directly, and you can maybe appeal that to find out if your medication can be placed on the formulary. Those of you with Medicare benefits, Medicare Part D specifically, you can do something called an appeal. You can file an appeal with your Medicare Part D plan, and that drug that may not be a preferred medication or on your formulary can be made a formulary medication. It doesn't necessarily make it cheaper, but it may make it accessible to once it's added to the formulary by doing a formulary exemption. That's what that's called. There's another thing that you can do. Those of you who have Medicare Part D, I'm sure you've heard of something called a tier. A tier is how your medications are rated based on their expense. Medications that are generics or preferred generics are usually tier 1 or tier 2. Drugs that are specialty medications are usually tier 5. So the higher the tier, the higher the cost of medication. There is something that you can do as a Medicare Part D recipient called a tier reduction appeal, something that your doctor will have to help you with. So if your doctor prescribes you a medication, you can contact your Medicare Part D provider. With your doctor's help, you can appeal, and a tier 4 drug, which is very expensive, could be reduced to a tier 3 drug, literally saving you hundreds of dollars, maybe thousands. Tier 5 drugs under the Medicare Part D policy cannot be reduced, but anything under tier 5 can be. This is a huge, huge resource and something that I would encourage you to look at and talk with your doctors about. If you're taking medications that are tier 4, 3, get help. Look at that. Call your insurance company. Afford those drugs a little bit better. All that to say, insurance is a crazy thing, very confusing. Theme 2, the ability to afford your prescribed medical treatment. So when you're collecting information about how your insurance works, and it's essential that you learn how your insurance works by talking to that member of your medical team where you're getting your care to help explain these things. It's also important to understand how medications are paid for through your insurance versus how your medical care is paid for. It's often very, very different. Even if you have a group health insurance plan, the way that your medications are reimbursed or covered can vary widely from how your medical care is processed. So understand how your medications are paid for. Those of you with Medicare benefits certainly are experiencing this because you have your Medicare Part A benefit, which covers things like hospitalization, Medicare Part B that covers your medical treatment that you get in your outpatient medical center, or like radiation treatment, for example, or your chemotherapy treatment that you might be getting, or that outpatient visit with your doctor. That's all covered under Medicare Part B. Medicare Part D, as in David, is what covers your prescription drugs. And those policies, like almost every other health insurance out there, changes every single year. And knowing how your Medicare D benefit works, how your group health insurance plan works in covering medications is essential. Ask a lot of questions with that insurance person in your medical center for that. Another thing that you can do regarding the medical aspects of your care, if you've had significant surgeries or you've had you've assumed a lot of expenses associated with medical treatment that you've already received, is something called financial assistance. So most hospitals throughout the United States, because of wonderful policy that our government has put in place, require hospitals, for the most part, to provide financial assistance programs. Financial assistance programs are often available, that information, on your health center's website. Again, ask your social worker about that, or your financial advocate at your treatment center where you're getting care. But asking about your hospital's financial assistance policy is absolutely, can be a tremendous cost saver and reduce a ton of distress and a concern by finding out more about that. You may not qualify for it. These programs certainly vary from hospital to hospital, but most hospitals have these programs in place. And if you don't ask about it, if you don't learn about it, you'll never be able to access it. It's about that idea that I talked about earlier about making sure you have good information available to you. Knowing about the financial assistance policy is part of that. So again, they vary from place to place. If you're getting treatment in multiple places, ask about financial assistance policies at all the centers where you're getting care. What about government assistance? So number one, let me see if I can go back here, if I can get that. Okay, I'm just going to leave it here. So what I would say is, even if you don't think you qualify for a governmental kind of assistance program, and what I'm really speaking about here is the Medicaid program. So the Medicaid program in your state, in every state all across the country has a Medicaid program. Each state runs their Medicaid program uniquely different. There are things that are similar across the country as far as Medicaid coverage goes, but things like eligibility and the various forms of programming through the Medicaid system are different from state to state. So it's hard for me to answer questions or provide you specifics about that because they aren't really there. Each state does this differently, but your social worker in your cancer program or your financial advocate there probably knows this stuff backwards and forwards. So again, this is just another good reason to get to know them. Don't assume that you might not qualify for the Medicaid program in your state. I meet patients all the time that think because of the assets that they have, or the fact that they may live in a house, and or the fact that they're working, or the fact that they maybe have a group health insurance plan means they don't qualify for the Medicaid program in your state. That would be an incorrect assumption. You would be surprised because Medicaid eligibility has changed so much over the years. You might be, and if you are, what that does is it creates another massive safety net to help you around the financial aspects of your wellness. The Medicare program is another federal form of insurance that you may not be eligible for immediately, but it may become something that could help you later. So if you're newly diagnosed with a brain tumor, and let's say that you're under the age of 65, and because of your medical condition, you're no longer able to work, Medicare may become a part of your life if you file for something called Social Security Disability Insurance through the Social Security Administration. Often people just call this disability. Well, it's called Social Security Disability Insurance. And after you've been on the SSDI program for 24 months, as a person who's not 65 years of age, under 65, you will likely qualify for the Medicare program, which, depending on if you have group health insurance or not, may become a primary or a secondary payer, further reducing the cost of your insurance. So the one thing that I'd like to say about Medicare is, if you get disability benefits, please hear me tell you this: you don't automatically qualify for the Medicare benefit. You don't. Unfortunately, that's not how the policy works. You need to be on the SSDI program after you start receiving your benefit for 24 months. After that period of time, you should be eligible for the Medicare program. And again, it could be something that could really help you. So it's something to be aware of. Getting back to Medicaid, Medicaid is not just a one-fit-all program. Every state has a Medicaid program, and the Medicaid program is not just one program. It's actually many, many programs across the board. So that's, again, another reason why I would really encourage you to to not assume that you maybe not qualify for it. You may not qualify for it, but it's still something I would encourage you to at least understand and get to know by talking to that member of your care team. Okay. Theme number, sorry guys, I'm my computer's too sensitive here. So when it comes to, okay. The third theme that I mentioned was this theme around indirect consequences associated with your medical care. And one of those big indirect consequences is around the theme of your ability to work. And maybe because of your medical care, you're not able to work right now. Maybe you're in a period of time where you're receiving a short-term disability benefit and you're not able to work right now for a season. But based on feedback that you're getting from your doctors or from other members of your medical team, maybe work is something that you'll be able to return to. Maybe after your diagnosis, you didn't have to stop working right away. Maybe that was how your journey kind of played itself out. But the impact of work is essential. It has a major impact on your overall wellness, both practically and psychologically. If you're not working, that cuts out a significant kind of impact in your daily structure. A lot of people get a lot of meaning from their work, and aspects around your work also meet a lot of your practical needs. It's income, it's health insurance, it's these things that provide you, again, safety and security. And if you're able to work, it's something that I would encourage you to make sure you're talking to your medical team about. It can be a vital aspect of your wellness for those of you who are able to continue to work. So what I would encourage you to do is talking to your doctor openly about this idea of work is important. If you're not able to go back to work right away, maybe you're on a short-term disability benefit, then making sure that you're telling your doctor that this is a goal that you want to pursue, that this is a goal that you're thinking about. Make sure that they hear that and they understand that so they can help support you. They may not agree with it. They may give you pushback. They may give you feedback, based on what they're seeing in your plan of care right now. But expressing that and talking with them about that is important. If you go back to work, you'll need their help. And one of the ways that you can use their help is to use them to help you seek reasonable accommodations in your work. There is a powerful and wonderful law in the United States called the Americans with Disabilities Act. Your doctor or you or any member of your care team can seek out what are called reasonable accommodations to help you go back to work. And having your doctor involved in that process is really, really helpful. There are also other aspects of your ability to, the goal of returning to work that you might want to involve other members of your multidisciplinary team. Maybe a physical therapy evaluation, maybe an occupational therapy evaluation or speech therapy, or some support from your behavioral health team, your social worker, the clinical psychologist that's working with you to help you in your goals of continuing to work. It's something that I would strongly encourage you take advantage of and talk to your medical team about it. But if you are trying to work or you're trying to return back to work, talk to your doctors, listen to their feedback, take their feedback, debate with them, but make sure you involve them in this aspect of your wellness. You're going to need their help as this is a part of your goal of care. Continuing to work. So one thing that I want to highlight is this idea of disability. Disability is not just a concept that means you're not able to work. Disability is also a term that captures this idea that a person with a chronic health condition is now a protected class of person. You have certain protections under the Americans with Disabilities Act. And under that concept of disability comes this idea that you can seek reasonable accommodations to get support, to go back to work, to engage in those primary aspects of your work. Talk with your doctor, talk with your medical team about that. But this is a very, very powerful idea. By implementing those protections, you might be able to continue to work, especially in the era of COVID, which has taught so many of us that remote work may be a possibility, and maybe your job allows you to do that. And by seeking out a reasonable accommodation that's protected under the ADA with your doctor's support, you may be able to do that and continue to work. All right, so you may be saying to yourself like, okay, Craig, that sounds great. I have no idea how to do any of that. When you say that these accommodations can be made, how do I even go about getting those? Well, number one, I would say don't do it alone. This is why your team in your hospital or your place where you're getting care has got this multidisciplinary team. I heard my colleague say earlier, talking about the idea of counseling. If you're in therapy or you're talking to a counselor, get their help, especially if you're working with a social worker involved in your cancer center or your brain tumor center. Have them help you write these letters. Have them help you communicate with your employer. Have them help you come up with the right language to share with them. So don't do this alone. There are also some really wonderful resources to help you. One of the best ones is called the Job Accommodation Network, or askjan.org. You see it referenced on my slide there. They provide a tremendous volume of all kinds of support, even sort of one-on-one education that they can provide over a telephone call or through their website to give you really good information on how to get the necessary things in place that you need to go back to work or return to work or stay at work, okay? Again, don't do this on your own, all right? I've also posted some information down below from the United States Equal Opportunity Commission. This is part of the Department of Labor. This is the organization that actually regulates the Americans with Disabilities Act. And if you're having difficulty with your employer after you've made good faith attempts to get those reasonable accommodations in place and you're not getting the support you need or the help, this is the governmental entity that you can reach out to for help, okay? But I would say go to your medical team, use organizations like the ABTA, use organizations like the Job Accommodation Network, or the second resource here I have, the Disability Rights Center, or it's also called the Cancer Legal Resource Center, that's got some really great resources to help you navigate this. There's some state programs that you can also get access to, usually called vocational rehabilitation, or the rehabilitation division in your particular state, depending on where you live, that also can help you get the resources you need to continue to work. Another organization that I think is way underutilized in every state, they have this is called a Center for Independent Living, or sometimes people call it a CIL. These are the organizations in your community that are dedicated to helping individuals with disabilities live independently around their work, around their housing, around all kinds of support to help them. These services are free. These services are readily available. So I would encourage you to reach out to your Center for Independent Living in your state. You probably have a local chapter in your community that can help you navigate a whole lot of challenges to help you accommodate and get the resources you need to live independently, no matter what your disability is. Decisions around continuing to work are important, but also the idea of discontinuing work is also something that many of you have probably wrestled with at this early point in your care. The Social Security Disability Benefits Program, another disability program available through the federal government called Supplemental Security Income. These are programs that are available to you that you can apply to through the Social Security Administration. I would encourage you to look at that if you haven't already. Talk to your social worker about that at your health center to help you. There are other programs called short-term disability benefits provided through your employer-based benefits. Likely, some employers offer these benefits, some do not. other benefits called long-term disability benefits for individuals who are not going to be returning to work through their employer. These benefits, again, short-term disability benefits or long-term disability benefits through your employer, they are not the same across the board. They are going to be different from employer to employer. So it's important for you, if you have these benefits, to understand how they work. Understand how long you would be out of work before they start paying you. Understand if they continue to pay your health insurance premium. Often short-term disability benefits do, but knowing how these benefits work is essential to helping you navigate your financial wellness and stability. And I'm running out of time here, but there are a number of things often that get impacted by health insurance. Again, short-term disability benefits through your employer will often continue to pay your insurance premium while you're out of work. This is a really, really important thing for you to understand when you're navigating your goal of care. So I know my time's up, so I will defer back to Emily, and certainly we'll take any questions that you have. I know I went really fast there.
Thank you so much, Craig and Megan, for sharing your expertise and insight. We do want to save some time for questions. As a reminder for our attendees, please, if you have a question that you want to ask our speakers, type and submit it using the Q&A box at the bottom of your control panel, and we'll answer questions as time allows. The first question we have, Megan, it's directed towards you. You talked about some tips on how parents can talk to children about their diagnosis, but do you have any advice that you can share for parents whose child is the patient? How do they talk about what their child is going through if their child is young and may not fully understand it? Oh, you're on mute, Megan.
Sorry about that. It depends on how old the child is. Some of the resources that I mentioned have different language on it that is age appropriate. A lot of the information that I gave today was specific for children whose parents have brain tumors, but I am aware of some resources as well to help navigate the conversations that you're talking about. Emily, is there any way to link me with that person directly so I can send them some information?
Yeah, we can definitely do that, Megan. No problem. Thank you.
Yeah, thank you.
All right. Another question we have, Craig, you talked about resources for individuals wanting to either return to work or maybe stop working. Do you know of any resources or advice that you can share for students? Some patients, especially young adult patients, they may be in college or grad school or even high school while they're going through their tumor diagnosis. Do you have any resources for them? Yeah.
That's a great question, and I'm so glad that you asked about that. I think sometimes college students, sometimes in other students, again, brain tumors can happen at any point in your life, right? And getting support that you need while you're going through college, while you're going through high school, it's important, right? So number one, the rights that I talked about before regarding ADA protections, those also exist for students. And if you're a college student, and you probably know that when you're going through that syllabus with your professor at the beginning of the semester, you're like, oh my goodness, look how much work I've got to do this semester. Often that syllabus will include a statement around getting accommodations or assistance with your schoolwork. And universities take this very, very seriously. And often they have dedicated offices for students with disabilities. And even if you are not formally diagnosed, or even if you're not formally designated as a disabled person because maybe you're not receiving a disability benefit, don't let that stop you, because again, like that definition of disability that I talked about earlier, that is the definition, right? It's the idea that you're living with a chronic health issue means that you meet the eligibility criteria and the protections that any disabled person would do. And so what I would say to you is, find the office at your university. This information should be readily available to you, and make an appointment with that department, and make sure they have a very, very clear understanding of how your brain tumor diagnosis has affected your academic performance and your learning. And if you can, maybe sit down with your family or your friends or other people involved in your medical team, come up with a list of things that would make your learning experience better for you. Write those down, take those to that academic department at the university where you are, and show those to them and ask if they can help you with this. Often these are things like allowing you to get more time on various assignments, or getting more support in the classroom directly. I think in the world of COVID now, it again has had a tremendous impact on how we kind of think about school and how we think about work. And I think that places now are even more accommodating than they ever have been, with remote access to the classroom and those kinds of things. If you're in high school, what I would say to you is talk to your school counselor and make sure that you explore with your family something called a 504 plan. So that's a federal that's a federal protection that people with medical conditions have at the high school level. You can get accommodations around a medical issue, whether it's a brain tumor diagnosis or any kind of significant medical problem, where they will make accommodations. You don't need to be a person who necessarily has a learning disability to get these kinds of protections. But a 504 plan is a way to get formal accommodations for you in high school or secondary school or elementary school. And it's a very, very powerful tool. And if you're a parent out there, advocate for a 504 plan. If your son or your daughter has been diagnosed with a brain tumor, it is an appropriate thing to ask for. And I would strongly encourage you to think about that.
Thank you so much for that thorough response. That was wonderful. All right, another question we have, this one's for you, Megan, regarding counseling. So you mentioned the importance of not only social support, but also professional counseling when you're going through something like a brain tumor diagnosis. What can loved ones do if they feel like the patient that they're caring for, or maybe their caregiver, would benefit from emotional support or counseling, but doesn't want to go down that route? How can they talk to them about maybe exploring this benefit and this resource?
Sorry, that's a really tough situation, because a lot of times we can see our loved ones suffering, but they might not be open to help, which can be tough. We can't force anybody into counseling, so they do need to be open to it. I think if you're in that situation, the best thing that you can do is, of course, provide the education on what is available, that counseling is an option. Try to normalize it as much as possible if you can, but also understand that counseling isn't for everyone. Some people just don't like the idea of talking to somebody that's not in their direct support system, and that's okay too, but maybe just being their person that they can kind of talk with openly and honest to, and just listening to them. And of course, continuing to try to bring up counseling. But again, it's really difficult to force somebody into something that they're not open to, and they're not going to get the true benefit of it if they're not at least open to it a little bit. But that is something that I see happen in the clinic a lot, is we'll have family members call saying that a patient would benefit from counseling, and they might, but they're not willing to talk to me. And I can do as much as I can to kind of build that rapport and get them more comfortable and things like that. But as much normalization as you can give, and just kind of being their listening ear as well, could help too.
Thank you so much. Craig, we have another question about coverage. Some patients, they may be exploring second opinions like we talked about earlier, or they may be considering traveling for their treatment. If they are on a program like Medicaid or Medicare, how does that impact their ability to seek treatment outside of the state that they qualify in?
That's a really smart question. So if you're a person with Medicare benefits, so Medicare has parts, right? It has Medicare Part A, Medicare Part B, Medicare Part D, and there's this other thing called a supplement, Medicare supplement. And then some of you out there may have something called a Medicare Advantage plan. So the answer to this question is complicated. So if you have Medicare, original Medicare benefits A and B, and you have a Medicare supplement, also sometimes called a Medigap plan, you are really in a good position to seek care outside of your state if that's something that you're able to do. Your Medicare coverage really covers you nationwide at any center that accepts Medicare, which is probably going to be about 99% of them. So if that's your situation and you have a Medicare supplement, Medicare supplements cover whatever Medicare Part B is in boy pays for. So you're in a really, really good position, probably the most flexible position. If you're a person with group health insurance and your Medicare benefit is secondary, then your group health insurance, and that's based on employer size of the person who has the insurance, by the way. So if you work for an employer that's over 100 employees, then your employer group health insurance is going to be your primary insurance. If your employer is under 100 employees, then Medicare is going to be your first payer. That's kind of the rule there. You're going to be in a situation where you have to work with if your employer-based coverage is your primary, you need to make sure you're working with that network, right? Because a lot of employer-based coverages have a network. But sometimes those networks are really big, so you may not be restrained, but you just want to know that, okay? Same if it's a secondary, you need to know that as well. It may not be a preferred provider, it may be a non-preferred provider where you pay a higher percentage. So that's that situation. If you have Medicare and Medicaid as a secondary health insurance, so Medicaid is insurance through the state, then oftentimes Medicaid benefits are not covered outside of your state. That would be fairly unusual. Some states that are right on top of each other, like I'm in Massachusetts, we often see patients from New Hampshire, from Vermont, and we accept their insurances because that's how we're so close to them. So if you're in a state that's, if your center is right near where a number of states maybe connect, maybe those other centers will accept that Medicaid benefit, but it's not often that's the case, that your Medicaid benefit will work outside of the state where you're getting your benefit and where you're getting your treatment. So there's a limitation there. If you have Medicaid just straight, and that's your only form of insurance, and you don't have Medicare benefits, then you're much more limited. Just like I said, if it was a secondary. So it's a tough situation.
Thank you so much for answering that complicated question. I think we have time for maybe one more question, and this one is regarding benign brain tumors. Are benign brain tumors covered under disability? And if they are not, what resources are there available for patients who are dealing with a benign brain tumor who do have debilitating side effects that are trying to cope and find support?
So my quick answer to this really complicated question, again, a very good question. So when it comes to disability, I'm going to assume that the person who's asking the question is talking about disability benefits through the federal government. So Social Security disability insurance benefits. So the way that those benefits are determined are based on medical criteria. And so oftentimes, whether you have and I'll defer to the doctors who went to medical school, not me, but on the grade of a tumor. I don't exactly understand the grading of benign tumors and how that works, but oftentimes disability insurance benefits are not eligible to folks if the brain tumor is the only diagnosis for people who have a grade 1 or grade 2 tumor. Often grade 3 and grade 4 tumors do meet the disability criteria under the Social Security Administration. Now, with that said, I don't want that to discourage you from applying, because there are other aspects of a person's functioning that get impacted too. And those are also important aspects and criteria for disability. So if you apply to disability, and if you're a person who's thinking about it, do it. Get help from your medical team to help. It's something that I would do a lot with my patients. I still do help them navigate that process because it can be a little bit overwhelming. I would encourage you to do it. The things that you want to do is you want to make sure you get support from your doctors to make sure that the right documentation is submitted when they're adjudicating your disability benefits, because your functional status, your ability to do your activities of daily living and your instrumental activities of daily living also weigh in on your disability benefit determination. So I would say just if you don't have a malignant brain tumor, you have a very serious condition, right? And I think that you should go ahead and apply for benefits. If you get denied, I don't want you to get discouraged either, because the appeal process is actually very easy. And your social worker may be able to help you with that. Again, it's something that I do all the time for my patients to help them appeal their disability denial. It doesn't happen a lot, but when it does happen, you can appeal. You can actually appeal more than once. And the process works really, really well. So just make sure that all the right medical information is given to the Social Security Administration so they can appropriately adjudicate your disability status. Make sure they understand your level of functioning and what you can and cannot do. A part of that application process does require you to fill out an adult disability report, which will ask you a lot of questions about your ability to do things like sit, stand, walk, reach, crawl, bend, all of these things that we sort of take for granted when we're healthy, but that will also be attribute to your disability determination. So I would say, go ahead and apply, get help to do it. And if you get denied, appeal and get support.
Thank you so much. And Dr. Dunbar, I see that you wanted to add something. Please feel free to unmute yourself.
Those were fantastic presentations, and I want to add to the beautiful answer Craig just gave. The location and specific tumor type are two of many variables that help people understand their disability. The key is working with your providers to help with the documentation, because maybe a benign tumor was resected, but it left someone with limited vision or ability to walk or do another activity of daily living, and we are successfully able to get them work accommodations or full disability. And I wanted to end on an important point made about people's financial abilities and then being able to get access to care with second opinions. More than ever, there are now virtual tumor boards and screening for clinical trials or other free or discounted hospital, state, or federal programs that really start with you having a conversation with your physician and describing your goals and wishes and needs. Because often in just a heartbeat, we can get on the phone and screen a resource or a treatment for you free of charge without any time or money taken out of your pocket. And in many times, if we hook you up with a trial at the NIH or charity care at our hospital or a tumor board review where 30 doctors reviewed your case, you can get all that value instantaneously for free. So start by asking your provider your goals and wishes.
Great. Thank you so much, Dr. Dummer, for adding that. And thank you so much, Megan and Craig, for sharing with all of us the helpful resources to support patients as they plan for the journey ahead. And I just want to say two of the most common questions ABTA receives on our care line always has to do with where can I get social support and what financial aid resources are available to me. And it is only through working with experts like yourself that we are able to continue to build our resources and share it with those that are calling in. So thank you both so much for sharing with us today all the important information. And we look forward to continuing to work with both of you. All right, so we are going to move forward with the rest of our program. And I'm going to invite Dr. Dunbar on to introduce our last session and our last speaker.
Hi, what a privilege it is to introduce the last speaker. I have the opportunity to welcome Dr. Elizabeth Gerstner. She is an associate professor of neurology and division of neuro-oncology at the Massachusetts General Hospital, Harvard Medical School. She's representing the Northeast United States, and she is a return ABTA presenter. She is highly proficient at researching and publication for the advancements of patients touched by brain tumors. Particular areas of interest include circulating substances within blood or cerebrospinal fluid to detect status and treatments within brain tumor, and also advanced imaging techniques. Dr. Gertzner, welcome.
Thank you very much for inviting me to participate in this meeting today. My goal by the end of our time together is that you will have a better understanding of the different types of research for brain tumor patients and how there are many different ways you can fit in and can participate in research. Disclosures. As many of you here are familiar with, the time between finding out that there is something on a brain MRI and getting to a final diagnosis of a brain tumor can be an agonizingly long time for patients. Nowadays, with our more sophisticated molecular and genetic testing of tumors that we can do, this time can be 1 to 2 weeks and sometimes even longer if it's a more complicated case. And during this time, patients have gone through brain surgery. New medications have been started, in particular steroids, which can cause a lot of mood changes, irritability, and insomnia. And so in a very short period of time, a patient's world has been turned upside down. So by the time you actually sit down with your neuro-oncologist to hear your final diagnosis, patients have gone through a roller coaster of emotion and anxiety. And then once patients finally hear the news that they do have a brain tumor, that flood of emotion just escalates. There's this feeling that patients must do everything possible to fight for themselves, their children, and their families. There's information overload as patients process what they just heard and then try to learn about their disease and best treatment options. And sometimes the possibility of participating in research is part of those treatment options. Therefore, as I said in the beginning, the goal of this session is to understand how research can fit into a treatment plan. So if we take a step back and sort of think more broadly about what is research, research really is just gaining knowledge about something. And in our case, it's gaining knowledge about patients with brain tumors. And knowledge can be gained in many more ways than people initially think. If you think about research as an equation with researchers asking questions and patients on one side, really on the other side is the common goal of improving the overall care of patients with brain tumors. But often the first thing that patients tend to think of when they think of research is participating in clinical trials.
Elizabeth, I'm so sorry to interrupt you. I think your cord is getting caught maybe in your hair for your headphones or something. It sounds a little staticky.
Okay, can you hear me better now?
That's perfect. You sound wonderful.
Okay. Sorry about that.
That's okay.
Can you see my cursor too?
Yes, we can.
Okay, good. So as I was saying, often the first thing patients tend to think of when they think of research is participating in a clinical trial. And patients who've just found out that they have a brain cancer often look to clinical trials that are studying new drugs or other interventions, what are called therapeutic trials, as the best hope of successfully fighting their cancer. And, as I said, upon hearing that you have a tumor, there's this sense of urgency to do more than just standard of care treatment. And that initial anxiety and information overload I mentioned before can be so high that patients really struggle to make the best decisions for themselves and their loved ones. If there is a trial available, patients have to decide if they want to participate. The situation can get even more complicated if there's more than one trial presented to patients. And so patients are often at a loss on how to choose between trials. And as physicians, we're taught to honor patient autonomy and not be too heavy-handed in guiding patients towards a trial or a particular trial. And so it really becomes a discussion with your doctor about the specific trial requirements. So for example, how frequent or how long are study visits? What are the side effects from the drug involved? What is the route of administration? Is it an oral pill or an IV medication? What is the phase of the trial? Is it a phase 1 trial where the drug is early in testing, or a phase 3 trial where we have much more experience with the drug? And so this discussion really revolves around figuring out what is most in line with a patient's goals. It's important to remember, though, that the reason we are conducting a therapeutic trial is because we're trying to figure out if a new drug is better than current treatments. That's something we don't really know. That's why we're trying to study the drug and conduct the trial. We want to figure out if drug A really is better than drug B. And as somebody who does clinical trials, I'm always amazed at my patients' participation in trials because there are a lot of unknowns in testing novel drugs. But we know that not everyone is the fit for a therapeutic clinical trial, and there can be many reasons for this. For example, we know that brain tumors are very heterogeneous, meaning that they're made up of different cell types that influence how well people will do or how well they will respond to different treatments. Glioblastoma is no longer just glioblastoma. It's subgroups of smaller populations of patients who share distinct tumor markers. And so trials will often enroll only patients with very specific markers, the subpopulation of patients who have similar markers or molecular features in which we think a drug or novel therapeutic approach will be most effective. Meaning that if we think about this tumor here, it's made up of blue cells, green cells, and red cells, and a trial may really only want to enroll patients who have a predominance of blue cells. There are many other reasons that a therapeutic trial may not be a fit for a particular patient. Trials often have strict, inflexible requirements for participation. So if a patient is taking a particular medication that interacts with the study drug, they may not be eligible. Or if they have a comorbid medical condition that would make it unsafe for them to take the study medication, they may not be eligible. There are also more requirements with clinical trials. For example, there may be more frequent study visits. And so the logistics of coming in for those extra appointments or appointments that can be hours long can be a hurdle for patients who don't live close to the trial site. And understandably, there's some patients having just found out that they have a brain tumor want to spend more time with friends and family than at the hospital. And one of the things that I see patients struggle with the most is sometimes patients feel this pressure to relocate for a trial that sounds promising. But moving patients away from their social supports can have negative impacts we can't necessarily calculate. And so if there's not a therapeutic trial open at your hospital or you're not a match for a trial, it's important to keep in mind that therapeutic trials are not the only way patients can contribute to research. And so I've listed here some additional types of research, and they include imaging studies, blood biomarker studies, tumor tissue studies, brain donation, quality of life studies, registry studies, and donating towards research. We'll walk through these, and I'll give you some examples of how important these forms of research are to gaining knowledge and improving the care of patients with brain tumors. The details of the examples that I'm going to go through are not important. I really want you to take home really the importance of the knowledge gained through these other non-therapeutics types of research. So let's start with talking about imaging studies. And so imaging studies are really critically important because they can shed light on tumor biology non-invasively. It's very hard for brain tumor patients to send brain tumor patients back for repeated brain biopsies. That's not really feasible, and I can't seem to convince my patients to go back for, say, weekly brain biopsies, understandably. And so there's a lot of interest in using advanced imaging techniques such as MRI or PET scans or other imaging modalities to better understand tumor biology. And these are non-invasive tests, as I said, but they can be more time intensive because often these studies will require extra scans or longer scans. Nevertheless, the information we can gain from these studies is incredibly informative and provides very powerful information. For example, in this study that we conducted, we explored how combining two drugs impacted the efficacy when used together. There's this push in neuro-oncology to combine drugs to give the tumor a double or triple punch. But what we found in this study is that when you combined a drug called Avastin with a drug called Temodar, the Avastin actually decreased the delivery of Temodar to the tumor. So that's shown as in the red here. This loss of red here is showing that not as much Temodar chemotherapy is getting to the tumor. And so we learned that we need to be more thoughtful about how we should be combining these drugs to maximize the efficacy of both drugs. And so these studies are really critically important in longitudinally and non-invasively monitoring tumor response to therapies without the need to do another surgery. Let's talk a little bit about blood biomarker studies. And these are being used to answer many different types of questions, in particular, detection and monitoring of tumors. They tend to be very straightforward studies in the sense that all it is asking for an extra tube of blood. And ideally, this can be timed for when blood is being drawn for routine monitoring. One of the challenges we face in brain tumors is that we don't have a bloodborne marker like PSA for prostate cancer that really helps us to detect or track tumor response to treatment. Recently, there's been some interesting data that may be changing that, and there's some circulating markers that are under exploration. So in particular, they're circulating tumor cells. So these are cells that the tumor sheds into the bloodstream and can be measured. Tumors can also shed DNA, that building block of our cellular machinery, into the bloodstream. They can also shed exosomes, which are just little blebs of the tumor that comes off into the bloodstream and carries information about the tumor that shed those exosomes. But one of the challenges we faced with brain tumors is we weren't even sure we'd be able to measure circulating tumor cells in brain tumor patients. As you may know, the brain does a very good job of protecting itself from the blood through the blood-brain barrier. It does that because we don't want poisons in the blood to get into the brain and affect how we think and how we function. So we didn't know if these tumor cells would get through that blood-brain barrier. And what these researchers found is that they were actually able to detect circulating tumor cells in 40% of the samples they looked at. What was also interesting in this study is that at the time of progression, the number of circulating tumor cells increased. Now, you may say that 40% doesn't seem like a particularly high number, but I think as this technology improves and as we're better able to separate out these circulating tumor cells from normal white blood cells, hopefully that 40% will only get better. We just need to optimize our technology to better separate the wheat from the chaff. Other studies have looked at circulating tumor DNA. And again, don't focus on this somewhat complex graph. Basically what these lines are showing is the circulating tumor DNA measured from the blood, as well as the size of the tumor based on the MRI scan. And you can see that all the lines are tracking together pretty well, suggesting that a simple blood test could improve our ability to monitor and maybe even detect brain tumors sooner. So hopefully with these examples, you can see that these imaging and blood biomarker studies really provide valuable information on how we can better detect and track tumor response in a less invasive manner. The next step will be to identify markers of resistance to a particular drug that will inform next steps for treatment. Meaning if we can identify why a tumor developed resistance to a particular drug, the next step might be to target that particular resistance pathway. All right, let's move on to tumor tissue studies. These studies are incredibly important because they allow for a deeper dive into the genetic and molecular makeup of tumors. And again, as I said, it's not feasible to go in and do multiple brain biopsies in patients. So this tissue is obtained at the time of a necessary surgery. And so tissue that's not needed to make a diagnosis can be used for research. And so nowadays we can do some very sophisticated analyses to better understand tumor biology and particularly drivers of tumor growth. So again, back to this concept of better understanding the difference between the red cells, the green cells, and the blue cells that make up different brain tumors. For example, here these researchers were able to tease out 4 subpopulations of cells that make up gliomas. And remember, I mentioned previously that glioblastoma is not just glioblastoma anymore, but has become groups of smaller populations of patients who share distinct tumor markers. And so it's become critically important for us to understand this tumor heterogeneity. And being able to understand what subpopulations of cells make up a tumor will allow us to tailor treatments more effectively. Meaning that if we identify identify that the blue population of cells here really are the ones that are driving tumor growth, maybe those are the ones we really need to be designing and targeting our drug therapy towards. Let me share with you one success story that has come out of these tumor tissue studies. So in these tissue studies, we've been able to identify a particular mutation, which is called the BRAF mutation, in several different types of primary brain tumors. And this BRAF mutation was previously identified in melanoma, so there are actually drugs that target this mutation. And so neuro-oncologists started using these BRAF targeting therapies in patients with brain tumors, primary brain tumors who harbor the mutation. And we're seeing some very nice responses. And so now there are trials ongoing to validate these responses in brain tumor patients in the hope of ultimately getting FDA approval for these drugs so we can use them more widely in our patients. I'll show you one example from my own practice of a patient that I treat that has a BRAF tumor. And so this is an MRI scan here on the left. It's a horizontal section through the brain. So you can see the patient's eyes here. And this is after the injection of the contrast dye. So you can see the tumor lighting up over here. But then 12 months later, after this BRAF targeting therapy, you see resolution of the contrast enhancement. So a really nice response to this drug and a sustained response. And so really, this treatment would not have been available to our patients, several years ago without using tumor tissue to better understand what these molecular markers are, who these subgroups of patients are. I'll mention brain donation here in this context. Talking about brain donation is very hard for patients and families, particularly in the setting of initial diagnosis. But really, brain donation is another source for obtaining tumor tissue that allows us to learn about the disease process. And so I think this brain donation really highlights how important patients are to achieving our overall goal of improving the care of patients with brain tumors. Without the generosity of patients donating their brains, we wouldn't be able to get such access to tissue in order to look at these more detailed molecular and genetic studies. All right, we'll talk a little bit about quality of life studies. And so quality of life studies are really look at how well functioning someone is. It's asking questions about, are patients able to do what they want day to day, or their symptoms preventing them from living their lives? And these studies typically involve questionnaires targeted at teasing out what symptoms are most bothersome for patients. And they can take time to perform, so require commitment from patients or caregivers to participate. Increasingly, they're being attached to therapeutic trials because while we recognize that it's important to know that drug A improves survival, we also want to know that drug A is not causing terrible side effects, preventing patients from enjoying their lives. And so in this example, looking at patients with grade 1 meningiomas, which is considered a benign tumor, and a little bit towards the last talk where we were talking about our benign tumor patients are eligible for disability, these kind of studies help us to tease out those sorts of questions, because what these patients with this benign tumor underwent surgery, and then the researchers did quality of life studies after the surgery. And you can see with the black bars that which is the meningioma patients, their quality of life metrics were much lower than a normative population. And so what we're really learning is that our tumors and associated treatments have a significant impact on quality of life. And so the more we can learn about how our patients are struggling, the more we can design interventions that target areas of struggle. And I've listed here some of the ways that we can support patients, and you've heard some of that about some of these today. So support groups are a way that if we can better understand what is most bothersome to patients, what are they struggling with day to day, then we can better design our support groups as a way of helping them to get through their days and support them. Cognitive behavioral therapy is an approach that's used widely in medicine to help target depression, anxiety, cognitive issues, which is obviously a big concern in our brain tumor patients. So again, if we can better understand what our brain tumor patients are struggling with most, then we can really focus and target cognitive behavioral therapy to the brain tumor population. It's a similar theme with palliative care, and I'll be very clear that palliative care is not the same thing as hospice. Palliative care is focused on symptom burden and really minimizing any symptoms that patients have. And again, if we can better understand what the symptoms are that is most troublesome to our patients, then we can better make use of palliative care. And then lastly, these quality of life studies help us to evaluate our treatments to lessen any negative impact they can have on patients. I'll move on to registry studies. And so these registry studies tend to pool patients into a database, which includes important clinical information. So such as the type of the tumor, treatments received, and response to treatment. And many brain tumor centers will create their own internal database of patients that have been treated at their center. And this really allows us to do retrospective studies on select cohorts of patients. You're really hearing today this theme that brain tumors are very heterogeneous. And so if we can go back and look at our database and see that patients with a predominance of blue cells in their tumor have responded to a particular drug, then that could be very important information. These studies are also very helpful because some types of questions cannot be asked through a therapeutic trial because a trial is not feasible. For example, if we want to understand how pregnancy impacts brain tumor growth, you can't really randomize people with brain tumors to get pregnant or not. The only way we're going to be able to get to that question is by looking at patients who did get pregnant and had brain tumors and what their outcomes were. And as I alluded to a little bit, these results can sometimes lead to a therapeutic trial if there's enough signal to suggest a therapeutic response that should be confirmed in a larger prospective cohort. So if we did identify that blue cell tumors responded to a particular drug, then maybe that's enough to go on and try that drug in patients with predominance of blue cells in their tumor. I'll give you one example here of a particularly interesting registry study, which is called Count Me In. This is sort of funded through a nonprofit organization. This is their website here. And patients voluntarily sign up to share their medical information. And if possible, they will do genomic and molecular profiling of the tumor tissue. And then this information, once it's de-identified, can then be shared with researchers widely, meaning that they will distribute these results publicly. And the idea is that the more people we can get looking at this data, the more people we can get thinking about brain tumors, the faster hopefully we will get to solving brain tumors and getting closer to a cure. And I'll finish here by talking about donating towards research. And donating to research is incredibly helpful. Running a research program is very expensive. You need to have personnel and infrastructure in place to make sure that we're running these studies and trials safely and not harming patients. Also, all those extra MRIs, blood draws, and genomic testing cost money. And in the landscape of cancer, primary brain tumors at least are much less common. And so we do not catch the attention of big drug companies. They don't tend to fund a lot of studies in brain tumor patients. And so we need to find alternative ways to fund our research studies. And so donating to your local hospital or national organizations funding brain tumor research really goes a long way in our efforts to fight brain cancer. So in summary, hopefully I've convinced you that research can take many forms, from therapeutic trials to more non-therapeutic trials, such as imaging studies, blood biomarker studies, tumor tissue studies, brain donation, quality of life, registry studies, and donating towards research. And these are all critically important to our ultimate goal of improving the care of patients with brain tumors. So some of the take-home points I listed here, I think there's, one of them is that opportunities to participate in research can come up at multiple points and in multiple ways during the course of disease. There can be a possibility of participating in therapeutic as well as non-therapeutic studies throughout this challenging disease course. And patients are really critical to that research process. And there's this important feedback loop between patients and researchers. And hopefully what researchers learn today will help the next generation of patients and will really kind of move the needle on improving the overall care of patients with brain tumors. And I'll just end by saying thank you to all the patients out there who do participate in any form of research, because I think researchers, and I, as one of those researchers, recognize the added time commitment and burden any type of study places on patients and caregivers. So I think we really thank you for partnering with us as we really hope to solve this really challenging problem of brain tumors. And I think that's it. And then I think I turn it over to Dr. Schwab.
Thank you so much, Dr. Gerstner. I would now like to introduce a former researcher in the field of entrepreneurial cybernetics and 7-year brain tumor survivor, patient advocate, and advisor, Sabine Schwab, who, as you just said, is very involved with research, and she's about to share with you right now. As a member of the ABTA's Volunteer Advisory Council, she has been involved in multiple different programs, including being a patient research grant reviewer. And you will now hear from Sabine how she has been impacting research from the patient's perspective. Please welcome Sabine.
Well, thank you, Emily, for the introduction, and thank you to the ABTA for inviting me today. What a great meeting this has been. I wish I had known about the ABTA that early on in my own brain tumor journey. So I am one of the patients who is actively involved in research, and I'm here today to share 6 different ways to impact research from a patient perspective. So I do have a handful of advisory board agreements that are listed on the slide. As you can see, the ABTA is one of them. Excuse me. Others are the Memorial Sloan Kettering Cancer Center, the Count Me In registry, Dr. Gerstner just talked about. CCC19 stands for the COVID and Cancer Consortium, and also EPIC Experience. Now, before I dive into the 6 different opportunities that I will be presenting today, I wanted to briefly address the why. Why do patients decide to be involved in research? Well, I can obviously only speak for myself, but to me, being involved in research provides a feeling of empowerment in a situation where there's so much out of control already and taken away by the tumor. It's a way to make my diagnosis count, I want to say. Plus, I do learn a lot about new studies and innovative trials and treatments, and I get more fluent in the medical brain tumor lingo, as I call it. Now, 5 out of these 6 projects or opportunities listed here are open for enrollment for patients. I will alert you when I speak about the one that is already closed. Emily has shared that I am involved in the ABTA's patient advocate research grant reviewing process. Now, I know that's a long word, but all it means is that I do read grant applications from researchers who seek money from the ABTA, and I then give feedback and comment on it in writing. The ABTA is not the only organization that involves patients within that reviewing process. I have done something similar for my treating hospital, Sloan Kettering, and I do encourage you, if you're interested in this opportunity, reach out to your cancer center and ask if they have such a program, or reach out to the ABTA and ask if you can potentially be included. If you have signed up for the volunteer social hour that is following this meeting, my 2 volunteer advisory colleagues will give you more details on this very opportunity as well. One of the research opportunities Dr. Gerstner just talked about is the Count Me In registry. To me, Count Me In is very special because it's an organization that emphasizes the true partnership between patients on the one side and researchers on the other side. Count Me In has several different registries. The one that is particularly interesting for brain tumor patients is called the Brain Cancer Project Registry. In fact, they are going to rename it early next week to the Brain Tumor Project Registry. I've been involved from two sides, as a patient advisor who has helped the Count Me In researchers to come up with the name, the website, the logo, some of the content within the surveys and so on. But I have also been one of the patients who has clicked on the Count Me In button on the website and who has shared her data and saliva and tissue sample with the Count Me In team. Participation is very, very simple. All you have to do is click on the Count Me In button, provide consent, share some information about the hospital and your doctors, and respond to simple survey questions such as your diagnosis date or your brain tumor type. The Count Me In team will then send you a saliva kit in the mail. You do provide your saliva sample and you can return it at no costs. Now, it's very important to note that the information the Count Me In research team collects is, of course, anonymized before any data is being entered into the database. So you do not have to worry about that. And I hope that you too will help the database grow and click on the Count Me In button on the website. Now, this is a research opportunity I have not been personally involved with. It's the low-grade glioma registry by Dr. Elizabeth Claus. Dr. Claus is not only a neurosurgeon in Boston and the director of medical research at Yale University, she's also one of the clinical advisors for the ABTA. And the ABTA has provided pilot funding for Dr. Claus to build this registry. The reason I have not been involved is because it's a low-grade glioma registry, and I was diagnosed with a high-grade glioma, a so-called anaplastic astrocytoma. If you are interested in participating in this registry or just looking at more information, you can go to abta.org and find information on the website. Now, this is the one opportunity that is already closed, but I wanted to share anyway today for you to see the variety of projects and ways that patients can be involved. It's a so-called quality of life study, and the title was Impact Study. And Impact stands for the design of the improving physical activity after cancer treatment randomized controlled trial. Now, all it means is the purpose of the study was to test a program that helps young adult cancer survivors to increase their physical activity. And the way they did it was to enroll 300 patients, young adult cancer survivors across all cancers, not just brain tumors, and always send a Fitbit device. That's why it's pictured on here. And we had to wear this device for a full year. And then also participate in quarterly surveys and interviews with the research team from the University of North Carolina at Chapel Hill. We were also asked to weigh ourselves every day and then submit our weight to the research team. There was a little bonus after the year was up. We got to keep the device, the Fitbit, and we were also paid a small compensation. The next opportunity is still open for patients to enroll. In fact, this is one for patients and caregivers. And in case you were counting along, yes, the numbering is off. This year is supposed to be number 5, not 6. I apologize. Now, if you do like surveys, I highly encourage you to consider signing up with the Rare Patient Voice. The Rare Patient Voice connects patients and caregivers with the opportunity to voice their opinions through surveys and interviews to improve medical products and services. And the reason why I am suggesting to sign up is because they do pay for your time and participation. It's not a nonprofit organization, it's a company, and I think that's the reason why they are able to do that, just that. And then lastly, I wanted to highlight the easiest way to participate, and that is by a donation to a research supporting organization such as the ABTA. Dr. Gersner has shared earlier that running research programs is very expensive, but we all know that research is important for advancements to happen. In addition, through our donation, we do support medical discovery and research, and we help develop new treatments and techniques and innovations that improve health outcomes and hopefully also our quality of life. If you would like to give to the ABTA directly, there's so many ways you can do that. There's a donation tab on the website. You can participate in one of the many BT 5K run and walks across the nation. In fact, it's even easier this year than ever before because everything is virtual and you can do it on your own time in your own neighborhood. They have marathons and half marathons where you can sign up and run for the ABTA. Ralph, this morning, Ralph DeVito shared there's a golf challenge coming up in June. They are part of the Amazon Smile program, the ABTA store, just so many different ways you can do that. Now, just to give you an idea, I'm not a runner at all. I prefer yoga and rock climbing, but I have still created a team for the New York City BT 5K many years ago. And my husband, who's the runner in our family, has challenged his colleagues and our friends to join the team. And together we have raised over $10,000 for the ABTA over the past years. Now, I would like to close with a quote by Carl Sagan that speaks to me personally when I think of research, and it goes somewhere, something incredible is waiting to be known. Thank you very much. I'm here to answer any questions, and I will also be joining the volunteer happy hour if we run out of time here, or you can contact me through social media. Thank you. Have a good day.
Thank you so much, Sabine and Dr. Gerstner. We do have time for questions for this session. Just as a reminder for our attendees, please feel free to type and submit questions using the Q&A box at the bottom of your control panel, and we'll answer questions as time allows. So one of the first questions we have is regarding some of the ways that patients can engage in research that Dr. Gerstner had mentioned. Are these research opportunities, do they compensate for time and travel? I know Sabine talked about some of the projects she engaged with that did compensate, but this question is more towards the opportunities that Dr. Gerstner had spoken of.
It really depends upon the study and whether or not they're, as I said, it's very expensive to do these studies. And so sometimes there's not always funds to compensate patients for their time, but sometimes there is ways of sort of paying for that extra parking, knowing that you're coming to the hospital for an extra visit or a longer visit. Sometimes there'll be coverage for parking. So it really just depends on each of the study design and how it's set up.
Thank you so much. And also, Dr. Gerstner, there's another question for you. If patients want to participate in this form of research, is there a way that they can proactively find opportunities?
So I certainly think, the first place is to start talking with your provider and kind of see what's available at your institution. I think that's the best way of seeing what's most easily accessible for you. I try to avoid sending patients to clinicaltrials.gov, which lists all kind of clinical trials for brain tumor patients, because that can be very overwhelming. And so I think if you start with your provider, they should have the best information as to what might be the best fit for each individual patient.
Thank you so much. And Sabine, for some of the research projects and opportunities that you talked about, where can patients find more information on joining those opportunities that you had mentioned are still open?
So for the 6 opportunities I have shared today, we will send out the information, including the websites after the meeting. So you will get that in your inbox. And then again, some are listed already on the ABTA website. So I always encourage you to check out the ABTA website. It's a great resource for information of any kind.
Thank you so much. All right, let's see what we have here. Okay, we have a question about brain donation. Dr. Gerstner, do you mind just giving us a brief overview of how brain donation works? If a family is interested in that, how do they go about getting more information? Where does the donation go? Things like that.
So usually it's through your local hospital and your local institution. So hopefully they have a program in place for brain donation. And so, to be completely honest, once a patient passes away, then the funeral home transports the body to the local hospital. A lot of my patients ask, can they still do an open casket at the time of the funeral? And yes, there can still be an open casket for the funeral. And then the bodies get transported back to the funeral home once we've taken the brain out. So it's a pretty quick process and shouldn't kind of slow down, the patients grieving their lost loved ones. But again, it's just having that access to that tissue really helps us learn a lot about the process of the disease.
Thank you so much. This next question is for Sabine. Sabine, what has participating in projects like these, what has that meant for your own personal experience as a patient and a survivor?
Yeah, as I have shared in the beginning of my presentation, once you're diagnosed with a brain tumor, you have a feeling that the control is taken away, like the way you have pictured your life to be, and even for some people, the purpose of the life have been stripped away. I was not able to pursue the career that I had envisioned for myself. So by participating in research from a patient perspective, it gives back that feeling of control. And it does feel like I'm, empowered. There's something I can still do. And my diagnosis, it's a way to make my diagnosis count, knowing that I can contribute to a higher purpose and help brain tumor research to make these advancements. Maybe won't help myself, but the next generation of patients. And that just is a great feeling to be part of that and to be able to contribute to that.
Thank you so much. And I have another question for you, Sabine. Sometimes for patients, especially brain tumor patients, when there really isn't a definitive moment where you go from patient to survivor, it can be difficult for patients to determine when is the right time for them to start engaging in processes like this and giving back. What advice would you share to others who are in that situation?
I absolutely agree. The survivor patient to me is fluid. I do not, even though I'm 7 years post my initial diagnosis with no recurrence, and I have to knock on wood, that long ago, I do not consider myself a survivor every day. I think I can be a patient today and a survivor tomorrow, depending on how I feel, how much sleep I got. I have days where I have scheduled meetings to be part of something, and then I have to decline because I'm just too tired, or I want a nap, or my brain is too foggy to talk. And it's difficult to make that decision, and I cannot pinpoint a year or a month or a certain milestone that you have to reach in order to participate. There are several of the options that I shared today. You can sign up today, for example, the Count Me In registry, and then others like interviews or speaking about your personal journey with a researcher. Those have to happen whenever you feel good, when you have a good day. We all have good and bad days. I'm sure of that.
Definitely, I couldn't agree more. And we have one more question, Sabine. Someone's asking, do you mind sharing how long it's been since you were first diagnosed?
Yeah, like I just said, I was diagnosed in May 2014. So it will be 7 years ago in a few weeks, with an anaplastic astrocytoma brain tumor.
Thank you so much for sharing. All right, another question, Dr. Gerstner, maybe you can help with this one, is about how can patients advocate for their own tissue across time? For example, they may need to send tissue to obtain a second opinion, or maybe to evaluate if their if they qualify for a certain trial? How can patients be better advocates for themselves and their tissue?
Yeah, so I think it's, that goes to the point that tumor tissue is just so vital. And so oftentimes if patients are coming to MGH for a second opinion, we kind of work with them and their local institution to obtain that tissue. So I think really partnering with whoever needs the tissue to get it, really advocating with your local providers. You just have to kind of be a little bit of a nudge, I feel like, in this process. But often when people go for a second opinion, that secondary institution wants to see the tissue themselves to really confirm and make the diagnosis themselves. So often are there pathways in place to really share some of the tissue between institutions.
Thank you so much. Another question regarding research. Now in the current climate with COVID-19 and the pandemic, has that impacted participation of patients in projects like this?
It definitely has, and it definitely has slowed down our research, and particularly for those non-therapeutic trials, because you don't want to be bringing in a lot of patients unnecessarily, although I wouldn't say that it's not necessary. But therapeutic trials have maintained to some extent, but certainly have taken a little bit of a hit in enrolling because patients are understandably hesitant to come in. One good thing, though, that has come out of COVID is we're doing a lot more telemedicine. And so, those extra study visits that I talked about, having to come into the hospital, sometimes weekly, sometimes monthly, a lot of those got converted to telemedicine visits, and then labs could be drawn locally rather than having to be done at the institution conducting the research. It'll be interesting to see post-COVID how much that continues, but ideally I'd like to continue to see telemedicine incorporated into clinical research so that some of those extra study visits that put that burden on patients who live far away from the hospital that's running the trial might make it a little bit easier for patients to participate in research.
Thank you so much for that insight. And Dr. Gerstner, do you mind sharing your perspective on where you think research will go in the near future? Do you anticipate research going in any specific direction, or what can you share regarding that?
So I think as was one of the themes that I was trying to get across is that, brain tumors are very heterogeneous. And so as we learn more about what those subpopulation of cells are, we'll really be having smaller and smaller cohorts of patients with more specific drugs targeting those smaller subpopulations of patients. I think that's one way that we'll move forward as we learn more about the particular pathways that are upregulated in these different types of tumors, these different subpopulations. The other thing is there's been a lot of advancement in clinical trial design, in that we're trying to do a little bit more of platform trials, which is a way of, rather than just doing one trial, one drug, these trials will have multiple arms to them. And so it makes it a smoother transition, and you're able to study multiple drugs using this platform design, and then enroll patients with particular markers into different arms of the trial, depending on what particular tumor markers they express. And so I think we're getting more efficient in our clinical trial design, and hopefully that will expedite drug development for patients.
Thank you so much for that insight. I think we'll take just one more question. Now, we hear a lot about health disparities, barriers to care and access that certain populations may face. How are we ensuring that research projects like this are also including the minority voice and the minority group?
It's a great question, and it's certainly something that the Society for Neuro-Oncology has been talking a lot about recently, and how do we get more patients to participate in clinical trials, and particularly underrepresented minorities. And so, the idea is to just keep that conversation going, try to get out as much information as we can through these ABTA, meetings, and really try to, let those minority populations know that they are invited and equally able to enroll in clinical trials. And maybe there are ways that we can figure out support programs to try to defray some of the costs of clinical trials participation, but it's a big conversation that's going on in the neuro-oncology community at this point.
All right, so that's all the time that we have for questions for this session. Thank you again, Dr. Gerstner and Sabine, for sharing your insight and advice. I'll turn it over back to Emily.
Yes, thank you so much, Dr. Gerstner and Sabine, for sharing with us from both the clinician and patient perspective on how you can impact research. And thank you to all of you who've asked those really important questions. This now concludes the main sessions of the ABTA Newly Diagnosed Empowering Your Journey Patient and Family Meeting. We invite those of you who want to get more involved with the ABTA to stay on the line and participate in our social hour for current and future volunteers, led by 2 of our very own ABTA Volunteer Advisory Council members. This interactive session will start in just a few minutes. We hope each of you gained some new insight, understanding, and resources from our meeting today. As mentioned, all of this information will be sent to you post-event with the recording and a copy of resources so you can refer back to at a later date. Before we go, we would love if you could help us to understand if you have learned something new today by responding to this last poll. Now that you have learned some new information, please rate your understanding of brain tumors. All right, so this is where we land right now. So earlier today, majority of you voted for 46% said general understanding. We now see a few have bumped up to a greater understanding with 52%, and 14% have an excellent understanding. We really hope that each of you increase your insight today and continue to learn more from the information that we have on our ABTA website. And as mentioned, all of this information will be archived to access at a later date. In addition to the polls, we invite each of you to continue to share your feedback with us. Each of you should have received an email asking you to take a brief survey to evaluate this meeting. We ask each of you to please take a few minutes to share your feedback, which is important for us to plan for future programs and meetings. For everyone who fills out this survey and includes their email address, you will be entered into a raffle for a chance to win a $50 Amazon gift card. I don't know about you, but I love free money, and especially on Amazon. So definitely fill out that survey and you'll be entered into this raffle. The winner will be emailed the gift card post-event. I would now like to thank our program planning chair, Dr. Erin Dunbar, for all of her time and effort into putting together this well thought out program that was based on previous feedback from meetings. Please welcome Erin Dunbar to say a few closing remarks.
Thank you, everyone. I want to say thank you on behalf of all of the ABTA staff and panelists and presenters, how incredibly proud we are of each of you. And we sincerely hope that this has helped you on your journey. We tried to create a range of topics that truly represented you, and we tried to present a group of providers and presenters that truly represented us who care with you and for you. We're really excited about the enduring resources that will live on the website. And although this meeting specially highlighted patients newly diagnosed with brain tumors, I hope that you look at the ABTA website and tell other people in your life about all of the resources they have for other primary brain tumors, palliative care and survivorship, rare tumors, metastasis, young adult and adolescent tumors. There's something on this website and within this organization for everyone. So when I talked about creating your medical team and your care team, really the home team organization is the ABTA. I'm privileged to be a part. Thanks, everyone.
Thank you so much, Erin, and we really appreciate your continued support and partnership. It is sincerely always a pleasure to work with you. Additionally, I would like to also say thank you so much to all of our speakers and as well as our sponsors. We thank NovaQ, our presenting sponsor, our gold sponsor, SDP Oncology, our silver sponsor, Karyopharm Therapeutics, and our funders, Genentech and Integra Foundation, for all their support of this virtual event. Without the time and effort from each of these individuals and organizations, we would not be able to bring you this quality educational programming that has been brought together the whole brain tumor community. And most importantly, I thank each and every one of you for joining us online today. I know virtual meetings can be very long and you may have been sitting for a long amount of time, but we truly appreciate you joining us today. Be sure to be on the lookout for our upcoming meetings, events, and webinars found on our website at www.abta.org. Our national conference will be taking place this year on Friday, September 10th through Saturday, September 11th. Registration opens early spring. Additionally, the ABTA offers an educational webinar series with one taking place next month on April 28th at 1 p.m. Central Time. Ambreen Mann, who was asking all the questions today, is actually the program manager who leads our webinars each month. This topic is on clinical trials, paving the way forward. Join this webinar to receive strategies in considering clinical trials for adult and pediatric brain tumors. Hear expert perspectives on the current state and future directions of clinical research and learn from the firsthand experiences of a participant in brain tumor clinical trials. Register for free at our website underneath the heading Webinars. Thank you again for joining us and enjoy the rest of your day.